shine. Dark is the sky. I know this love of mine will never die, and I love her. Will never die, and I love her.
She calls out to the man on the street, "Sir, can you help me? It's cold and I've nowhere to sleep. Is there somewhere you can tell me?" He walks on, doesn't look back. He pretends he can't hear her. He starts to whistle as he crosses the street. Seems embarrassed to be there. Oh, think twice. It's just another day for you and me in paradise. Oh, think twice. It's just another day for you, you and me in paradise. She calls out to the man on the street. He can see she's been crying. She's got blisters on the soles of her feet. She can't walk, but she's trying. Oh, think twice. It's just another day for you and me in paradise. Oh, think twice. It's just another day for you, you and me in paradise. Is there nothing more anybody can do? Oh Lord, there must be something you can say. You can tell from the lines on her face. You can see that she's been there. Probably been moved on from every place, 'cause she didn't fit in there. Oh, think twice. It's just another day for you and me in paradise. Oh, think twice. It's just another day for you and me in paradise.
My love, I can't live with or without you. I said with or without you. With or without you, my love, I can't live with or without you. With or without you.
rain on my window, I'm thinking of you. Tears on my pillow, but I will come through. Josephine, I'll send you all my love, and every single step I'll take for you. There's a storm on my radar, but I can still fly. You are the reason, the blue in my sky. Josephine, I'll send you all my love. Josephine, I'll send you all my love, and I am far away. Josephine, I'll send you all my love. Josephine, I'll send you all my love. Life without meaning, I was walking away. In the coldest of winters, night becomes a day. Josephine, I'll send you all my love, and every single step I'll take for you. Josephine, I'll send you all my love. Josephine, I'll send you all my love. Every time I'm far away, Josephine, I'll send you all my love. My Josephine, I'll send you all my love.
I think it's time to start. A very warm welcome to this third edition of Elaacc. So we started in Barcelona 2 years ago, Philippe. So we had a last meeting in Munich, and now we are in the wonderful city of Rome. So a warm welcome to the city, a warm welcome to the meeting, and I think we will have fruitful discussions. And it's my pleasure to give the opening word to Philippe, who was the initiator, let's say, of the entire group.
Thank you, Nina, and thank you all to be here today. Can I have my slides? Yes. Yes, absolutely. That's the third edition today. We started 2 years ago in Barcelona with the first Elaacc meeting, and last year we were in Munich, and we are very happy to have you today in Rome, in Italy. The first edition was focused on the procedure, and we designed the Elaacc score that you probably know today. And last year we focused on imaging and combined procedures. That was the hot topic of the moment. And this year we decided a few months ago to focus on patients' risk profiles. And I think that was a good choice regarding the recent trials that were published. And we're very happy to work on that together. That will be critical, that will be timely, that will be crucial to work on that and to have some discussion, votes, and consensus on that. So, a few words about the club. What's a club? I think it's important, especially for the newcomers, to understand what we think by the word club. We want this to be a forum for discussion, and we want you to be very interactive. We don't want to have some kind of knowledge delivered by some people to other people. It's a club, we're all experts of the procedure. You were selected because you know about the procedures, because you're an implanter, because you're an imager, because you are working in this field. And definitely, and I thought from the beginning that was the first idea of this club, is to think that collective intelligence is much better than additional intelligence. I mean, 1 + 1 + 1 makes much more than 3. And this is why we did the consensus of the score. This is why we worked on imaging and now on patient's profile. And this is, yes, what was a club 2 centuries ago in Great Britain. Like Phileas Fogg, the hero of Jules Verne, decided with all his friends to do this road trip around the world in 80 days. You cannot think about that if you're alone at home with your computer. Okay, I will do a road trip around the world in 80 days. No, this is something coming when you are in associations of like-minded people getting together to socialize, drink, eat, and talk about whatever it is that binds them. So this is what we did. We socialized, eat, drink, and we talk about left atrial appendage closure. This is a picture from last year in Munich. And this year, this is Elaacc this year. So you can see the evolution, the increase of the number of physicians, which is quite not so big. And I think we want to keep it like this, to keep the level of discussion very high and not to have some kind of with too many people, and we are not able to continue to share and discuss together. The good point is that we have more and more electrophysiologists. You know that in Europe, as opposed to the US, we have more interventional cardiologists doing these procedures, but we're increasing, thanks to Tom and others, the number of EPs in the meeting. And interestingly, we are much more people from the industry in this room. You can see that it was 16 persons 2 years ago and more than 40, I think. Today it's more 45 than 41. So we are very happy about this success. Again, we don't want to increase up to 1,000 people meeting. Definitely not. It's a club for discussion, so we want to keep it like this, but we want to increase the quality of the discussion. So I said it's not another LAA meeting because it's your meeting. It's your meeting, it's your working group, and you were selected because we want together to collect some data in the European Left Atrial Appendage Closure Research Registry. We will talk about this during the meeting. We want to make research collaborations with you to initiate multi-center projects, again with the idea that we are much stronger together than 1+1. We want to make the consensus. It's very important, I think, that now we are observed by the community as a group which is able to have some consensus, even if we are not a society. We are a group that is accepted and respected in the field in Europe. And of course, we want to continue to be and to have a forum of this dialogue and discussion with the industry and to promote the therapy. So that being said, we have a large agenda today, and you will see that we have a lot of space for discussion, much more than last year. We have a lot of space for voting systems. Everything will be explained. And there's a lot of sessions today, mostly about patients' risk profile, as I mentioned. And then we will have the session that you know with high risk or highly complex procedures or the new devices or sessions that we are really happy to share with you. So one word about patients' profile. You know that we have a lot of data, of new data, and now with all these trials, we are covering a broad spectrum of patients from very low risk with ocean and alone AF to a very, very high risk group of patients with closure AF. And you can see here, it's a summary of, a kind of summary of what happens with these trials, with patient's age, thrombotic risk, comorbidities, bleeding risk. And yeah, we have to find together the good position for the role for LAAC, maybe not proposed to patients with a very, very low risk of stroke, and not to be proposed to patients with a very high risk in which the population could be considered futile for the procedure. So we will go through this, and to define these populations, we need data. We definitely need this data, and you know that data are coming from trials. So we have randomized controlled trials that you know. We have post-market registries that you all know, and we have real-world data. So hello, Jim, you just arrived in the room. And we will discuss together the NCDR registry in the US and our Elaacc research registry and how we can collaborate. Why doing that together? Because I think that you all agree that meaningful real-world evidence is needed. We need to collect new insights. We don't have any exclusion criteria as we have in randomized controlled trials. And we need to confirm safety, effectiveness, and long-term outcomes of randomized controlled trials in real-world settings. So we will conduct some studies, multi-country, multi-sites, and complement the EMR data and strengthen the real-world evidence. This is the goal that we want to do. Just one word about the two registries that we have in the US. You know that NCDR, and I think Jim will explain that, have a large number of patients. We have less for sure, but we are all prospectively including patients and data within these registries. We have a little more insights on follow-up imaging and the Elaacc score that has been included into the registry. And yes, patient's profile is part of both registries. So I think we will have a lot of data to compare and to analyze. A call for studies. Of course, we need to generate some data, and there's a dedicated session for that, for unexplored areas, unmet needs. You have been invited to propose some trials, and we will discuss that tomorrow. Proposals from you, and we will try to address the best proposals with the REDCap Research Registry. I would like to thank our partners. We need you. your input, not only for funding, but also for the discussion. As I said, we want to build together a forum for dialogue and to promote the therapy. We need you, we know you, you know us, and we want to continue together in good trust. Thank you all. We have newcomers there, so thank you for those who are coming back, and thank you for the newcomers. We want to continue to build with you in this spirit. I also want to thank the technical team, Alexandra, Benjamin, Eileen, and all the team for organizing this meeting. Thank you. We would not be able to do that without you. And welcome to all, and have a good meeting. Thank you. That being said, I want to introduce the next speaker, who is Nina. Nina, you will explain the achievements of last year, what we did since 1 year.
Thank you very much, Philippe. Well, I need the clicker. Thank you. So it's a working group. So if you work, there should be some outcome. So what are the achievements of the Elaacc group in 2025? So first of all, during the last meeting, we thought about what are the gaps in imaging during left atrial appendage closure, and there was some consensus. So definitely imaging is central to outcomes. So we have workflows, but most likely the workflows are not standardized. We have inconsistency in definitions in between computed tomography and TE. We also have inconsistent definitions, for example, what is a peri-device leak? How do we define it? What is a good device position? And so many procedures are performed because the operator has experience and it's operator dependent, so we don't have structured workflows. So what was the intention for 2025 concerning imaging? So we wanted to implement and focus a little bit on multimodality imaging as standard, not only fluoroscopy alone or maybe TE alone, so multimodality approaches. A major focus was on 3D-driven understanding of anatomy and on 3D-driven measurements. We wanted to achieve some harmonizations, at least in the space where it's possible, across modalities, for example, in between CT and TE. We wanted to work on clearer definitions, and we wanted to work on standardized workflows. So from variability, so this is a pathway to structured and more reproducible workflows. So in this pleasure, I'm speaking also in, Laura, I'm also speaking with you because you've led this project with me. And a big thank you to everybody who contributed for this paper, which is a statement consensus paper on multimodality imaging for pre, intra, and post-procedural guidance. So it's always a long way. So we worked on the project for the last year. And fortunately, how many days ago, Laura? I think 2-3 days ago, we got the final reviewer comments, and we just had very minor comments. So we are very happy that we think we make it this time and it will be accepted very soon. So what was the focus of the papers? You wanted to bridge the gaps by introducing structured frameworks, harmonizing definitions, and put the focus on multimodality imaging, especially 3D. We also wanted to let you think a little bit deeper, because imaging during LAA closure is not just a step, or it's not just a step that accompanies a procedural step. It's really defining the workflow. So this is a little bit of rethinking concerning imaging. So what marked the shift? So we want to come away from multimodality, more to from single modality, move to multimodality approaches. We definitely want to implement a little bit more the 3D imaging, a 3D-driven understanding, not only of anatomy, but also for measurements. There's some discordance in the definitions, and this is also something we wanted to address to come to a more harmonization across modalities, aligned measurements, how do we measure in CT, how we measure in TE, and a more consistent interpretation. Clear definitions, for example, what is an appropriate landing zone, how we define the landing zone, what is a PDL, what is a good device position, and some more definitions. And maybe this could lead from a more individual practice, how everybody who's experienced is doing it, to more standardized workflows. Because if you want to teach people who are less experienced than you, they need some guidance. So to give you an example for structured workflows, and Adele, this is based on your shoulders. You proposed this, for example, for pre-procedural imaging, so that we can get something where a beginner can go through and have some guidance. If something is missing, did I do everything to prepare myself for the procedure? So this is, for example, a checklist for the pre-procedural LAA planning, which could be helpful and structure this pre-procedural planning. Also for the intraprocedural steps, so we worked on a structured workflow, and you can follow the idiomate steps. And the S is standing for safety check, so you all know that. You look for thrombi, you look for pericardial effusion, transeptal puncture, how should it be guided, how should it be done. The evaluation of the left atrial anatomy, which is one of the major steps you have to do and to prepare yourself. So we also included the Elaacc criteria, not because it's a score, but what's included in the Elaacc paper. I think it's important because these are all the anatomical issues which may be critical for your procedures. So for positioning and device deployment, a couple of steps, and for the surveillance that you should check for effusion, leaks, per-device leaks, and you should start your antithrombotic therapy. We also try to work a little bit better on harmonization of definition. So what is a good device position? You have experience, you do it by experience, but we thought we should come up with at least some definitions, and especially if you have a position during the procedure which is not perfect, that you should do everything you can do to correct this position. We also try to work a little bit on the harmonization of a PDL, so what is acceptable, what is not acceptable. Uncovered area is maybe an interesting point because this is something which can be harmonized in between CT and TE imaging, as you can see here. I mean, if you have a color flow next to the device, this is a flow phenomenon and it can only be addressed with TE. If you're looking for patency, yeah, you can address that with CT, but not necessarily with TE. So with the uncovered area, we might have a chance to harmonize the definition of a PDL in between imaging modalities. So bridging the gaps, we are leaving the paper on imaging, but standardized workflows. And I don't know if Lisbeth Roussel is in the room, but she led this important paper for standardizing the approach for transeptal puncture. Lisbeth, are you here? Can't see you. Okay, she's waving in the very back. So Lisbeth led on this, and I think it's also a very important step to get a standardization for transeptal puncture. So great work, and it's published this year, Lisbeth, so congratulations. I mean, it's always a lot of work. Also towards standardized workflows, if you think of the future of left atrial appendage closure, so we will not have an invention of new imaging modalities. So what will be the future? We'll integrate artificial intelligence, we'll integrate multimodal frameworks even more than we do now, and I think a minimalist approach, which means so we have a miniaturization of devices is also very important. And in this context, Sergio, you published with the group a standardized workflow for transeptal puncture and LAA closure. It was included in the paper next to other procedures. But I think also a very important step towards standardization of workflows. Another important paper, and I mean, maybe one of the largest achievements, Philippe, you led on this. This is the Elaacc paper on left atrial appendage closure, which I think it includes the definitions of endpoints, studies, a lot of structured work went into this paper, and you led it, and I think it's also very close to be published very soon. And just, this is why I'm just showing it, it's just a piece of the puzzle, but Jens Erik and I worked on the definition of PDLs, and to be honest, it follows Jens Erik's really structured suggestion. But I think it's important to define how we approach PDLs, and this is one very good example, I think, how we can come to more precise definitions. So, but if you're looking at a framework to practice, the next thing to develop the framework is only one step. So what it needs to be implemented in daily practice, we need education and dissemination. Yeah? So if you define multimodality imaging, or what we should include there, it must be taught and integrated in daily practice. And in 2025, we had 2 major platforms where we had the chance to do so, and this was PCR London Valves and Europe PCR. So for example, just to give you an idea, so we had a couple of sessions during Europe PCR, and Philippe, you've been involved in PCR London Valves, because for the first time, it was a valve meeting. For the first time, we included closure procedures, so PDL occlusion was included and left atrial appendage occlusion. And I think it was a pretty nice success. So now we try to standardize procedures, mainly by imaging in 2024-5. So the next question is, who should we treat with LAA closure, and who are the patients who benefit the most? So, and this is a transition from 2025 to 2006. In 2025, we worked on standardizing how do we perform a left atrial appendage closure under the aspect of imaging. And in 2026, so this is something we decided on last year, so we are going to work on defining who benefit the most. So it's going from procedural excellence to patient selection. And if you think a little bit about patient profiling, I think the focus will definitely be, because we know some new trials came up, it will be the evidence, so there will be a big discussion on the trials. But if you think about patient profiling, it includes a little bit more. It includes a clinical profile, the stroke risk versus the bleeding risk. We have to look at anatomy, morphology, imaging phenotyping, and also, this might be a minor focus, but also the feasibility of the procedure, the access and the transeptal puncture. And this should lead to a more personalized strategy in left atrial appendage closure. So thank you for your attention for this short introduction. And I think the major thing is to go directly into the topic, which will be the topic of this year, Tom. And you guide us to patient profiling. Oh, Tom, you choose the more difficult way. This one is easier.
Thank you very much. So thank you very much, Nina. Also, warm welcome on my behalf. And I want to spend just a few more minutes in this introductory session to set the stage for what we hope to be discussing in the next day and a half, which is the discussion, as Nina already very elegantly introduced, in patient profiling in LAAC, which is the consensus theme for our discussions this year. What are we discussing? In general, in terms of treatment strategy, nothing new. We still have the same options for stroke prevention. We have drug therapy, surgical exclusion, and transcatheter appendage closure. For drug therapy, I believe the arguments in favor did not change significantly. The body of evidence is quite solid, of course. It's in every guideline, it's easy to implement, and also the downsides did not change significantly, which is exactly, of course, why the therapy is not universally applicable, and we do need solutions for patients to meet their specific needs. And the LAA closure, long-term protection, for, in terms of stroke, very strong argument for bleeding risk reduction. Of course, on the downside, besides what was already there, invasive node procedure, non-LAA protection, I think the argument that changed the most recently is the argument there is limited data, because this is absolutely no longer the case. We have a ton of data that came out, which is the scaffold which will guide us through the discussions of the coming days. And just to bring that back to the front of your mind, we're talking about recent developments. When we wrote 2024 AFib guidelines. Most of this was not published, most of this was not yet applicable. And so the AFib guidelines 2024 guidelines do not put a very strong focus on other solutions for stroke prevention beyond drug therapy. The AFib guidelines, as you very well know, focus on modifying a little bit the risk scoring system, CHADS fast score, female sex being a risk modifier only in elderly patients anyway, and focus a little bit on surgical options, in particular in those patients experiencing stroke despite anticoagulation, and focus on the, at that time, published data on the benefits of LAA occlusion in surgery, concomitant surgery, the LIVESTREAM trial. But a lot has changed. A lot has changed, and a lot of data is now out there suggesting that we may have a solid impact on outcome parameters using LAA closure strategies. The option trial was presented, concomitant PVI plus LAA closure, randomized versus DOAC, presented November 2024. LAOS 4 has been initiated, trying to replicate the observations from LAOS 3 in a percutaneous approach, so LAA closure on top of anticoagulation. And of course, recently, CLOSURE-AF and CHAMPION were presented. CHAMPION, by far the largest data set that was generated thus far, 3,000 patients randomized in an all-comer setting, randomized to LAA closure versus anticoagulation. And this brings us to potential new pathways or future indications, future potential guideline messages, which I believe we will be willing to discuss. Future messages may be such as the ones that we published in this practical guide that many of the people here in the audience participated in this paper, a practical guide on left atrial appendage closure, where besides the conventional pathway, those patients that are not on anticoagulation today, whether it is due to a history of major bleeding or a perceived excessive risk of major bleeding, doesn't matter, they are not on anticoagulation today. These are the patients that are now referred for LAA closure, but we can certainly think about, and recent trial data supports thinking about these patient profiles, because there's more, of course, than a patient that has already experienced major bleeding. First of all, there's the issue of compliance, of patient adherence, to anticoagulation. This may be also a personal patient preference, a failure simply to accept anticoagulation, ongoing bleeding issues, and the phenomenon of breakthrough stroke thromboembolic event on anticoagulation, where you might say the anticoagulation we are giving is not effective. Whatever the underlying reason is, the anticoagulation we're giving is ineffective. And so we can indeed certainly imagine patient profiles, for example, patients with unacceptable bleeding risk, where today it's, I think, clear that there's a very strong consensus on offering these patients LAA closure if, for example, they already have a history of major bleeding or life-threatening bleeding, where the consensus is much weaker if you want to start doing this based on patient preference, for example. But you can have a discussion with your patient now. You can have a discussion with your patient based on the data that's out there. Ineffective anticoagulation, as said already, breakthrough stroke, I think little discussion, again, that these patients are excellent candidates for anticoagulation. More discussion, for example, for a patient that seems to not respond to anticoagulation, that did not yet have a clinical event. And concomitant procedures, a good example, again, on how data can drive insights. Again, at the time we wrote this paper, option was not published yet, so we said that the consensus for catheter ablation plus LAAC was weak. Now that the option trial is out, especially in the US, I think close to 40% of procedures are being done concomitant now. So the consensus has increased dramatically. And this is because recently we did find answers in literature. We found answers for several scenarios, several patient profiles. Doesn't necessarily have to be patients that need an occluder or that need anticoagulation. For example, we'll discuss it in one of the upcoming sessions, but the ALONE-AF trial and the OCEAN trial showed that in certain patient profiles, if patients receive an ablation and are fine after the ablation, it's actually safe to stop the anticoagulation and do nothing whatsoever in terms of stroke prevention. Alone AF showed this randomized study comparing patients after PV isolation. The OCEAN trial, pretty much same design, showed the same result. It's safe to stop. In the case of OCEAN, put them on aspirin, not completely stop stroke prevention. What the trials don't answer, of course, is what to do with these patients if the AFib recurs. If the PV isolation was successful at some point, you stop the anticoagulation and the AFib recurs. A MACE trial was negative for efficacy for LAA isolation. I don't want to spend too much time on that here. Option trial, as already indicated, confirmed non-inferiority in terms of stroke prevention for LAA closure combined with PV isolation. Closure AF, as everybody noticed, end of last year, reintroduced some doubts of the feasibility of interventional strategies in very high-risk populations. And Champion AF just very recently confirmed non-inferiority of LAA closure for stroke prevention and superiority for bleeding risk reduction in a more general low to moderate risk population. And finally, LAAOS 4, still ongoing, aiming to replicate the LAAOS 3 results in a percutaneous setting. So thinking about patient profiles, looking at all this recent data, and this is what we'll discuss in the coming sessions, you can think about certain characteristics of your patient and try to think about who is likely to benefit from LAA closure. For example, a patient that needs effective stroke prevention but is a poor fit for anticoagulation. For example, patients with favorable LAA anatomies, patients with access to experienced operators, because this is also one of the things we observed in recent trials. LAA closure is an invasive procedure. There is a potential for procedural risk, so you need to make sure training for this procedure remains adequate. And of course, patients with a reasonable life expectancy. It doesn't make a lot of sense to put devices in patients with an life expectancy of less than a year. And on the other side, there's those patients where probably we need to be more careful thinking about LAA closure procedures. For example, patients with a very high competing mortality risk, patients where any bleeding would be catastrophic. So what changed in my practice? Exactly as I just showed, I identified patient-specific profiles for those patients more likely to benefit from either therapy strategy. And this can be no therapy. Those patients that receive AFib ablation, this can perfectly well be DOAC therapy, and this can be LAA closure. And I think it's time to move past what we have historically used, the framework of anticoagulation ineligible patients. I think that's not useful anymore, given the data we have today. Unfortunately, in my country, and I think in most of European countries, we're not yet ready with reimbursement to follow this mindset. We're not yet ready, for example, to start implanting patients based on patient preference. But that is a bit the stage we wanted to set for discussion, and I think that's my last slide. Thank you very much.
Thank you, Tom. Now, Lorenz, you have the task to explain about how the session will be with the discussion and the voting systems.
Yes, thank you, Philippe. Welcome, everyone. So we liberally decided to spare a bit discussion time to session 2 and 3 because we believe there is much to be discussed, and therefore I just want to introduce our voting system, the housekeeping rules for that. As you know, the aim of this two-day meeting is also to get a consensus, and given your esteemed presence, we will use the voting results also to derive the consensus. And this is why we just want to do a test run for the voting now, and then we switch to session 2. Can you now show? Yeah, here is the code that you should scan, everyone with your cell phone, and while you are doing this, I would like to propose that as these voting results will be used for the consensus, we only ask the doctors that are present here and not the industry to vote, with the exception of this very voting round. So currently I ask everyone to vote, but then for the subsequent sessions we really would like to politely ask the industry to abstain from voting. Did it work for everyone? If not, hand up, yes. For who it did not work? Nobody. Okay, then I think it's time to move to the questions. Does it work? Can you show the first question? You have them available? We have now 5 questions prepared. Yes, so, yeah, of course you see them. So the first question is just to get an impression who is attending. Are you cardiologists or not? So that would give an idea about the distribution of maybe other disciplines and industry. I hope that everyone is able to vote. And then we wait a little moment. 52 votes, if I'm not wrong. 53. Everyone was able to vote? Okay, then 63% cardiologists and 36% are non-cardiologists. Then we go to the next question. Can you show the next question, please? Are you an active LAA device implanter? That would be the next question. Already 60 votes. I think this is the number of votees. So it's about 50-50.
Lorenz, just
Yes?
a question. I mean, I'm an imaging person, but I feel that I'm an active LAA implanter. So should I vote for this?
The question of the definition, yes. So let's define that the LA implanter really pushes the device into the LAC, and that's why I put up the next question, are you an active imager? Please respond to the next question. So here 50-50. Next question is, are you an active imaging specialist? That would be defined as a person that does the imaging but not the implantation. Of course, the implanters are also in some way specialists in imaging. So here we have 23-24%. Thank you very much. And then we go to the next question, and that is how we should actually approach the question when consensus is reached. And we have 2 options, either 50% agreement or 2/3 agreement. That would be the question. So we move to the first option. 50% agreement would represent the consensus. Can we move to that one, please? And the second option would be 2/3, so 66%. And you should decide for either of the 2. Of course, we know that we could make it in a graded fashion, moderate, high, very high, but we will keep it simple. So do you vote for 50% as a good consensus or 2/3 majority? So here we have 26% is for 50% agreement, if I read it correctly, 66 votes, yes. And then the next question is, do you prefer to have a 2/3 majority? Yes, I think that's clear. Huh? So we take well note of this. We will issue a positive consensus for whatever question if there is a 2/3 majority. And then the final question, which is a bit somewhat odd because obviously the program is already out, but we would like to ask you whether it is indeed a good idea to focus on patient profiling for this very meeting. And if you say no, I would like to open the discussion. Please stand up and make your arguments. A bit pressure. No, I mean, it's reasonable to say no, but then we would really be happy to get your input. Maybe for the next year then. That would be the diplomatic response. So we have we have a very high consensus that this is a good topic. So the voting seems to work. I give the final word for this introductory session to you, Philippe, and I wish you a very nice meeting, of course.
No, thank you, Lorenz. I mean, the system is working. That's a great news. And the most important information from this voting is about this 66% agreement that you want to have. And I agree that it's better to have a strong agreement. But then sometimes in some really critical questions, it's not so easy to find a so strong agreement, but we will take care of that. That means it pushed the bar higher. We have to increase the level to convince you if we go to 66%. Thank you, Nina, for this introduction session and for the achievements last year. And I think we go, as you said, to the second session on clinical trials and new data on left atrial appendage closure.
So we need
James
Freeman, please, to come
join.
here. And I think now the really deep discussions will start.
Thank you. Thank you, James. Thank you for coming. We need your inputs. We are very happy and proud to have you here today. We really want to discuss with you about the real-world data that we have in this part of the Atlantic and the other side that you represent today. The pointer? No, it's here. As you are the leader of the National Cardiovascular Data Registry, we want you to introduce this registry, the goals, the aims, and the main results that you have.
Well, thank you very much for the opportunity to be here today. It's a real honor to be at this conference and to be with this esteemed group of investigators and clinicians. I'm Jim Freeman. I lead the program in cardiac electrophysiology at Yale, and then I direct the Analytics Center for the National U.S. Left Atrial Appendage Occlusion Registry. So I was told I have a couple extra minutes, so I'm going to try and fit in a lot. We've have a fairly substantial body of work, and I just want to try and cover some of that. So the NCDR LAO registry was launched by the American College of Cardiology. It's a U.S. national registry, and it was launched in January 2016. In February of 2016, it was designated as the U.S. Medicare coverage decision, so the registry for that coverage decision. So if someone is getting their procedure and the reimburser in the United States is Medicare, they have to be included in the registry. And the vast majority of sites include all of their patients. So we think we have about 98% capture of all procedures performed in the United States. In terms of data collection, we collect data at implant, 45 days, 6 months, 1 year, and 2 years. So active follow-up through 2 years. The follow-up is quite good. By the time we get to 2 years, we're down to about 70% complete follow-up, but that's pretty impressive actually for a registry. There's linkage to Medicare data for 5-year follow-up, so I'll show a study or two where we have full data out to 5 years. We created an automatic and manual adjudication process, so we try and adjudicate this data and make sure that it is accurate, and validated that and published that. We actually think this is a paradigm that should be used across large registries and even trials in the future at greatly reduced costs, and is well validated for adjudicating our major adverse events. There's audits of 5% of sites annually, and that's to confirm that the data is accurate and complete, and have very good agreement with source documentation. And then, of course, the data is used for science through a standard process. So this is actually, I was just trying to update my slides with data I got today, but couldn't put them in just in time. But we are over 600,000 procedures in the registry at this point in the US, and over 3,800 sites, or rather implanters with over 920 sites in the US. So really broadly generalizable, obviously, and really representative of everything that's happening in the US. The registry serves a number of regulatory functions. So obviously I talked about the CMS coverage decision and the fact that we have about 98% capture of cases performed in the US. It also serves as the formal FDA post-market surveillance study for approved devices in the US. So the data is pushed out to Boston Scientific in a registry called the SURPASS registry, which is just a sub-registry of the LAAO registry, and Abbott, that's called Emerge LAAA. And that's for 2 years after a device is released or there's a major device iteration. So for example, with the first generation Watchman, that was pushed out, and then when they released the Watchman Flex, that was also pushed out to Boston. They convene steering committees that work with industry analytic teams to perform research and answer FDA-related safety and effectiveness queries, as well as strategic questions for the companies. So what's our research output been today? I'm just kind of tallied this up. This is the stuff I've been involved in. There may have been a couple papers that I wasn't involved in, but 37 publications to date since 2020. This is funded through a number of mechanisms, directly funded through a competitive process at the ACC and CDR, so there's an annual process where anyone can submit, and you don't even have to be a US citizen, so anyone can submit to this competitive process annually in February. Our group obtained funding from the NIH in the United States to answer a number of questions, and that was a really successful effort. And then industry funding to NCDR to answer strategic questions. So occasionally, even outside of SURPASS, if they want to do things, but they don't have the full set of data that they need in SURPASS or in Emerge LAA, industry will come to us and ask us to do some science with them. And then, as I say, there's funds paid to the NCDR for the SURPASS and Emerge LAA efforts. So I'm just going to highlight who's in the registry, what we've seen to date. This is actually older data from early in the registry experience, but it's quite representative of what we've seen. So the average age early in the experience was 76. We're now up to about 78. And about 40% women in the US and about 90% white and European, although actually that has pushed down over time and we've started to see more underrepresented minorities. 26% of patients have a prior history of ischemic stroke in the US. 37% have a history of prior congestive heart failure. 37% with diabetes, over 92% with hypertension, intracranial bleeding in 11%, and then prior clinically relevant bleeding in about 70%. So I think this data shows these are sicker, older patients, and the vast majority of them in the US anyway, early in the experience, had prior clinically relevant bleeding. That has drifted down a little bit over time as we see a little bit more patient preference, but overall it's held in the mid to high 60s. Mean CHADS2 VAS score in the US is about 4.6. It's actually pushed up to about 4.8 and substantially higher risk than in the prior trials upon which the device was approved. And then the HAS-BLOOD score about 3, and that's remained very steady over time. Procedural success in the registry, 98%, very similar to what we've seen in the clinical trials. And I think I'm going to highlight that a bunch of the data that we've seen has been very consistent with what we've seen in the trials because I think that's important for giving face validity to the data. And I just also want to recognize that this is observational data. There are limitations to that. We understand that better than anyone. We try to do science that's appropriate to observational data and then leave certain key questions to randomized trial data. So I'm just going to run through very quickly some of our data research. Do I have a little extra time, more than 10 minutes, to talk today, Philippe? Is that okay? Is that okay? Okay. So we did this natural experiment analysis. We really wanted to understand how much better is the Watchman Flex device than the previous 2.5 device. So what we did is right after the transition, in the US, you had to take your old devices off your shelf when you got the new devices. And so if a site had done 37 Watchman Flex procedures, we looked at the prior 37 2.5 procedures, and so a site basically was compared to itself. We ended up with 27,000 people in each arm of the study, and you can see that the baseline characteristics were almost perfectly matched using this study design. So this is an example of an interesting observational study design, and the patients were quite similar. So what we see is that the major adverse event rate when we went to Flex dropped by almost half. The rates of catastrophic adverse events like death and device embolization decreased from 1 in 500 to 1 in 1,000. And then most importantly, we see this marked drop in pericardial effusion requiring intervention from 1.2% to 0.4%. So, and that resulted in marked reduction in major bleeding. So this is an example of some data that we did quite early on. We have looked at the real-world experience with Amulet as well, and it's just to say that we've shown very similar effectiveness. I think the one thing that we've have shown consistently with Amulet is this rate of pericardial effusion requiring intervention being a bit higher, and I've seen the second-generation device. I'm very excited for that, and I think we'll largely address that problem just as the iteration with Watchman addressed the issue of pericardial effusion there. This is one-year data looking at rates of ischemic stroke, and we've shown very consistently rates of ischemic stroke in this population, again with CHA2-VASc score of 4.6 to 4.8, of about 1.5%, and that has been extremely consistent with what's been seen in clinical trials. This is an example of work that we did where we used the Medicare linkage to get long-term follow-up, so 4 to 5 year follow-up. Here you can see rates of stroke after left atrial appendage occlusion accounting for competing risk of death, and you can see all stroke, so ischemic stroke about 1.5%, all stroke about 1.8%, and whether we use Medicare data or the active follow-up, we saw very similar numbers, which is very reassuring again. And I think this answered a really important question around the durability of left atrial appendage closure for stroke prevention over time, okay? So we knew that the trials went out. At that time, we didn't have 3 to 5 year data from Champion and Catalyst. And so for us, this was important to show that there's a durability of the impact. We also have shown this, and I think this is a really important slide. About 8.5% of people die every year after this procedure. And so this is a clarion call, and I think a really important slide for us in our discussion today as we're going to try and achieve consensus about who should be getting this procedure. We're not doing a great job universally in finding people who aren't going to die. These people are not dying of cardiovascular causes, but they're dying of all-cause mortality, and we need to be doing a better job of selecting people that are not at risk of dying soon. I'm really proud of some work that we've done looking at post-procedural antithrombotics. I think this is a really, really important topic. I talk about this whenever I get a microphone. I think this is a huge opportunity to try and mitigate bleeding risk after this procedure, which continues to be a problem in the field, in my opinion. So we've demonstrated several times, and this is also an interesting thing to state in a European community, because I think DAPT is still very commonly used after left atrial appendage closure here, but we've published several times now that using anticoagulation alone without aspirin is markedly lower risk than anticoagulation plus aspirin, and is lower risk than DAPT for bleeding just in the first 6 weeks. So a decrease of about 1.5 to 2% in the first 6 weeks alone after the procedure. There are some differences in people that get this, so you have to be a little careful about this with observational data. It's been a pretty consistent finding, and then has subsequently, of course, been demonstrated in trial data. We published 2 papers in JACC with both iterations of the Watchman device on this. We looked at residual leak, and we did some of the early work demonstrating that even small leaks are associated with an increased risk of thromboembolic event, and I think something we'll be talking about here. So I think meta-analytic data from the PROTECT and PREVAIL trials showed a similar finding, and then subsequent studies have confirmed that finding. We've got a suite of studies that we're planning looking at concomitant AF ablation and left atrial appendage occlusion. This is increasingly very common in the United States. We do have data from OPTION, but there's a dearth of data, so we're looking at trying to publish about 8 studies in the next few years in this space, and we got a large grant to do that work. So in terms of future directions, I think DRT incidence, outcomes, and predictors, we've got a study that we're working on right now. Historically, we've been a little limited in the registry because not everyone does universal late imaging, but we found 30 sites that do universal late imaging and allowed us to really assess when DRT is occurring. So we're going to define high-risk populations and try and understand who has DRT. Our hope out of this science is to define high-risk populations who need more intensive antithrombotics after the procedure and who should have universal late imaging to help us better detect DRT and or prevent it in high-risk patients. We're going to look at the growth of concomitant sequential AF ablation and left atrial appendage occlusion, as I said, with a suite of studies over a number of years. We need to continue to look at leak incidence, outcomes, and predictors. New device performance after commercial release, because we are still the registry of choice for this, we will continue to serve as the FDA post-market surveillance study for new devices, so that'll be great as we start to see new devices come onto market. Post-procedural antithrombotics, optimization and customization of this remains a really important topic in my opinion. As I said, we'll look at discharge regimes and duration, how that evolves over time. It's really changed over the last several years, and we hope it will continue to change. And then if anyone is interested in trying to do a trial looking at aspirin discontinuation for those without vascular indications at 1 year, I'm very interested in this topic. Aspirin puts people at higher risk for bleeding, and I think is something that we're really interested in trying to do. We're thinking about trying to do it as a cluster randomized trial embedded in the registry. And then we have a lot of interest in ICE versus TE. We're seeing growth in the use of ICE-only procedures, particularly with concomitant procedures in the US. So in conclusion, the NCDR LAO registry is a US national registry with high procedural capture, broad generalizability, and very good follow-up. It serves a number of important regulatory functions in the US. There's been substantial research output today, potential to continue to answer foundational questions, and then we'll monitor the safety and effectiveness of new devices after commercial release. So that was a whirlwind. Thank you very much. I appreciate the opportunity to speak.
Thank you very much, Jim. I don't know if there's a hot question or we have time for question at the end of the session. So maybe Jens-Erik, you can join the podium, because the idea for this second presentation is that you guys together, you define if there's some need and goals for US and European collaboration. We definitely need some kind of global forum discussion about this, and as you mentioned, Jim, there's still some unanswered questions. It's about what is the best imaging technique to drive the procedure. Do we really need to follow and to continue antithrombotic therapy beyond 1 year, for example? There's a lot of questions, and we need data for that. I mean, we cannot just say, okay, that's okay, my patient is okay, I will remove everything. We don't have this data, so we need data. That's why we're here. And Jens-Erik, please, go ahead.
Thank you very much. First of all, James, where are you? There, okay. We are completely impressed by this NCDR registry. Having almost now 500,000 patients enrolled into the registry, having a coverage of almost 100%, having all those important publications, I think it's completely amazing and very, very impressive. And when we started this club back in 2024, it was clear for us we must build something like the NCDR registry here in Europe. We need to see if we here in Europe are doing good and safe LAAC. We need to follow patients' outcomes. So we had two aims actually from the beginning when we formed the club. One was to initiate and try to build this registry, and the other one was also to come up with a new classification for LAAC, more implanter-friendly. And the last thing, we have built the Elaacc score, and we also did a reasonable good start building a European registry. From the beginning, we actually considered requiring, if you wanted to be a member of this club, you should also have a center that reported all your cases into the registry. We have 20 centers now that has the frame and the database, but not all are reporting cases. So at the moment we have about 1,200 cases entered into the database, and we have about 20 centers that have the frame. They are not all active. But also in order to have the discussion with James representing the NCDR, I would just here try to demonstrate for you the construction and how the database, the Elaacc research registry works. So the platform here is the REDCap platform, which is very nice because it allows you, all academic institutions can get access to REDCap totally for free, and it allows you completely to build up and structure your database as you want to structure it. And we did that, and in the beginning we also considered should we have one single server for all the data, and that led to some issues around in the different countries. So it ended up that each country actually has their own server for communicating with REDCap. And we are using completely the same database, and the system allows us to share data across countries and centers in specific projects. But I cannot go in to the database, for instance, and see Barcelona data, etc. We have to define specific projects and then merge the data. So the structure of the database, we have demographics, we have pre-procedural imaging, we have the procedural data itself, and then we have early follow-up and late follow-up, and we have clinical outcomes. And just shortly to demonstrate for you how it works. So now we are into the demographics, and we have country of institution, we have the institutional patient number. This is just a demo patient entered here. So the LAAC was done today. It's a male. Date of birth, January 1950. It automatically generates the age, height, weight. We have the parameters for the CHA2DS2-VASc score here. If you click, it will automatically update the CHA2DS2-VASc score, similar for the HASPET score. We have information about pre-procedural echo with ejection fraction. We have renal function, and we have the indications for LAAC here, urinary tract bleeding. We have the type of AF, if there's a hypercoagulation state or disorder or not. Information about presence of valvular disease or surgical, prior surgical or transcatheter valve therapies. What was actually the antithrombotic therapy at admission, and you can always rapidly monitor whether your charts here are completed or not. So the next step here in entering into the database is about imaging, about pre-procedural imaging, and that's where I think there's a difference between the NCDR and the European registry, because we have data both on pre-procedural and post-procedural imaging. So it was performed, yes, it was cardiac CT. You can also click TE, and you can go in and click which kind of TE was used, 3D, etc. Let's stay at cardiac CT. We can enter the date for the pre-procedural CT, and we can enter all our measurements about the landing zone, perimeter, and area derived is calculated automatically. And then we also have the systematic anatomical approach, which is the basis for the Elaacc classification. We look at entrance to the appendage with the osteal characteristics. Then we look at the landing zone. Here we have a low ostium take-up. We have a proximal lobe at the landing zone area. We can look at the main axis for the LAA. Maybe it can be pronounced anterior, and here also the overall anatomy, it's an early sharp bend here. So we have all those, also contractility can be entered here. So we have this systematic anatomical approach for all the patients. So I'll just go back here, just 1 second here. This one. It should be online, the database, unless it coupled me off. Yeah, but I'm just searching for the patient that I entered. Yeah. Okay, we're back again. So, about the procedure itself, technical success, yes. Note, this was an uncomplicated procedure, fluoroscopy time, contrast use, procedure time, type of device, what size of the device diameter after implant, degree of device compression, if you had recaptures or not, how many devices were used, which kind of intraprocedural imaging was used. Here it was ICE. You have a lot of options here. It was 3D ICE. We had the patient just in local anesthesia, no PDLs at finalizing the procedure. It was not a combined procedure. No thrombus during the procedure, LA pressure, date of discharge, and also information about post-procedural antithrombotic therapy for this patient, aspirin, planned for lifelong, and no procedural complications. Okay, and now this was the procedure itself, and then we have similar pages for follow-up of the patient. This is early follow-up imaging within the interval 30 to 120 days, and we have follow-up imaging, yes, and primary modality used was cardiac CT. You can enter details about the data, etc. If we found a PDL, you can enter details about the PDL, the location, hyperattenuated thickening, etc. If you go for further interventions like leak closure, or you just go for some other solution, and in that way you can really characterize also the actions related to some of the complications here. And same again, you have an option for some patients. We go for also later imaging, and we can insert similar data points later on. And also, most importantly, let's see here, we can go to clinical outcomes, and for every patient that come in with an event, or if we do research, we can go back and enter all the relevant hard clinical endpoints like death, ischemic stroke, hemorrhagic stroke, etc. And then also really follow whether we have had a beneficial course or we had complications, leaks, and heart events and things like that. So that is the structure of the database. So, of course, with only it is now 1,200 patients, we have to be very, very humble and modest, but the idea, it's not completely the same, and I think the value of this registry is that we have a lot of detailed information about imaging, about the anatomy before the procedure, and also actually the whole follow-up data capture here is also very detailed. So that can be probably a contribution, and let's imagine things like period device leaks. If we want to try to link that to the pre-procedural anatomy, for example, that will be possible with the information in this database. So I hope there can be options in the future where we can collaborate. But I think the most important thing right now is that we realize and all of us in the room here appreciate the importance of having a European registry, so we have really this framework similar to what you have. So
thank you.
Thank you.
Thank you, Jens Erik. Stay on the podium for the discussion. So, Jim, now it's time to discuss together. What do you foresee as a collaboration or point? You mentioned very long-term treatment. Jens Erik mentioned PDL. It's true we have less patients, but we have some favorable data that to show like imaging and everything. So we can help as a mechanistic insight, for example, for PDL, and you have the numbers for the clinical outcome, something like that. I don't know. I give you the mic and let us know.
Perfect. So congratulations, really a remarkable effort, and I think particularly to have we've done a lot of homegrown efforts like this without substantial external funding, and it's really a remarkable achievement. So listen, I think the data are highly complementary. All data is complementary in my opinion. And I couldn't agree more that we have a dearth of data on pre-procedural imaging, so that's a huge contribution to the literature. I'm wondering too whether there's an opportunity to have a sub-registry of leak closure procedures. There's a real, I don't know, there's a cottage industry in the United States right now around leak closure, when it's being done, who it's being done in, what the acute outcomes are, and then long-term outcomes. Do they actually drive down rates of stroke? It's a really foundational question because we know that even in Champion, I think it was close to 20%. I thought that number had been drifting down to, under 15%. So just like in the EP space, we have a whole industry that's been created around getting devices out once we put them in with extraction. I think similarly, there's likely to be a whole space around leak closure as we start to understand increasingly the thromboembolic risk associated particularly with larger leaks, but I think even with smaller leaks, if we get really good at it, and or if there are devices that are developed and for our industry partners, I think there probably is room for development of devices to close leaks, then we'll be needing data on that. So I think that's a huge opportunity. And I think one of the other wonderful things about this effort that you have here in Europe is that you can be nimble. I think we have a larger bureaucracy. There's whole committee meetings that have to go every time we want to add a data element to our registry, and there's substantial costs involved. So that's often a 6 to 12 month process if we want to iterate on the registry, and so you can iterate pretty quickly, which is pretty remarkable and exciting. And then, I'll go home from this. I'd love to get the data collection form, if I can, or access to it to understand exactly what you have for data and do a lot of thinking about how we can collaborate and what we can work on and what you may be able to add to this space. Also, there are some really different practices here in Europe than in the United States. Let's start with the fact that about 2/3 of your implanters, I think, are interventional cardiologists, whereas in the United States, it's 2/3 EP. As you heard earlier, increasingly concomitant procedures are becoming very common in the US, so I'm not sure that's as much the case with an interventional cardiology-led community here in Europe. And there may be pros and cons to both of those things. We're going to study a lot the concomitant space, but early data looks encouraging, but we have some other data that we're looking at, and there may be challenges or pitfalls. And then the use of post-procedural antithrombotics with DAPT being more dominant in Europe. I think it's really important to have registry data on that. Our registry data, where DAPT is used less commonly, would suggest that DAPT's associated with higher rates of bleeding, and there's a signal towards increased risk of thromboembolic events, including DRT. But there is selection bias there because the DAPT patients we know are a little bit higher risk. And so it would be really helpful to have that data from Europe, where it's the dominant thing, and it's not something that people are doing only in subselected folks that are higher risk. I think a tremendous number of opportunities to collaborate and continue to do things. What has been the scientific output to date? Are you still in the early stages of data collection, or?
We are still in the early stages. One of the first projects was to try to look at the reproducibility of the Elaacc score and the whole anatomical classification system. So that project is very far. And we have also tried to address what can the Elaacc score really predict and what can it not predict. So there will be later on the meeting presentation of some of the data there. So it's still quite early. I think also regarding, you mentioned the post-procedural medication, one difference between Europe and US is also that we actually have quite a lot of centers and countries using only single antiplatelet therapy, aspirin. And of course there's also a selection thing into this, but many centers had this strategy because it's almost all the time very high-risk bleeders, patients with a bleeding history, to go from the beginning very minimalistic. So I think if we collect it in Europe, we have a huge number of patients that are treated post-procedural only with aspirin in a low dose. And we actually also have centers that do appendage closures and leave the patient completely without any antithrombotic treatment. So I think that will also be very interesting data to look closer at.
Yeah, and just one word of, I guess, advice is there was a substantial delay from the inception of the LIO registry to the first publication. And I mean, if you're at 1,000 patients, write the initial paper just with who's in the registry, what you have, describing the registry to kind of get exposure out there. Because there was a bit of a delay, and it was actually one of the reasons that I got involved is because I sort of stepped in to help get the publication process going in 2020. But it was, I mean, 4 years is too long. Like that's not appropriate. You know, when people are paying a lot of money to be in these registries and whatnot, they want to see scientific output. And so we very quickly accelerated the scientific output after that, and I think you're there. So I would encourage you to publish that first paper.
And of course, one of the challenges we have, it requires work to run databases like this, and at the moment it's totally voluntarily. We don't have any economical support at all for this. It could be nice to have a group that could really 100% of their time take care of the database. And I know with the NCDR, you also have monitoring, actually. You have spot monitoring of what are centers really reporting. One fantastic thing with your database is that you have the requirement, you have to report if you want to get reimbursement. And we don't have the similar thing here, so we don't have 100%, of course, reporting of cases. So until now, it's centers that are active and interested in the LAAC field, but we should find a way to, convince centers that this is really the way to go to report to this. And I think it's very, very helpful also for the institution, each institution, to look at their own data and be able all the time to compare with other centers and do we do it good enough? Is there something we should change? Is it a completely different patient profile we are treating in my institution? And so there's a lot of benefit for each center also keeping the database.
You know, I couldn't agree more. So we actually, I'm very sympathetic to this. So we have the reimbursement requirement for left atrial appendage occlusion, but we have a similar registry for AFib ablation, and that's entirely voluntary. So the way we've gotten in the U.S. anyway is that hospitals like to publish their quality metrics to be able to compete against other hospitals in the U.S. And so that's been motivational. But for the AFib ablation registry, we have about 165, depending on when in the year and what year you're looking at, 165 to 180 sites, which is probably only about a 10% sample of sites in the U.S. It's still obviously an enormous number of patients and sites, but smaller, and that comes through our ability to allow hospitals to get their data back and then publish it nationally for kind of in a competitive landscape in the U.S. So it's something to think about, I suppose. And we benchmark the data so that they can, with face validity, say they know where they stand relative to the national data and whatnot. So that, I think, has been very helpful for sites and is why voluntary work still happens.
Yeah. Okay.
In terms of 2 years follow-up, what do you have as a data? You have like imaging follow-up also at 2 years, or it's only clinical follow-up?
Yeah, so it's a registry. So in the U.S., we have imaging. It's very commonly performed around the 6-week mark, which is consistent with the original recommendations, 6 to 12 weeks, I would say. Imaging after that is really rare, which is why our DRT study, for years, Vivek Reddy's been coming to me like, Jim, why haven't you published on DRT yet? And the problem was we couldn't say with any face validity that we could capture late DRT. We found 30 sites that routinely do late imaging on all their patients. And so then we are publishing on that subset of folks. We're working on that paper as we speak. But really what we have then is not late imaging because it's not mandated in the US and sites just don't do it. I think it's a problem. So if you have, that would be another thing is I think if you can institute, and we've tried to do the same in the AFib ablation registry, find a coalition of the willing that are willing to do, for example, late imaging. That would be a huge contribution to the field because you could look at, do leaks close up? Do they get bigger over time? And the DRT problem over time, because we know a lot of DRTs occur late. So if you can have not just data collection, but you can protocolize post-procedural assessment and imaging, that could be really valuable. And this could be like the imaging registry of the world. So I think that's a great idea. But yeah, we have 2-year active follow-up of clinical events. Again, by the time we get to 2 years, about 70% of sites have follow-up. But we have the Medicare linkage has allowed us for at least heart events. So stroke is very well validated in Medicare data. It's actually excellent stroke capture. Death is near perfect. And then bleeding we've actually published on as well. And we have, for some sites, also medication data. And we're just working on that. That data is a little less clean. But so we have that out to 5 years with Medicare follow-up. And that was that data that I showed, showing the very steady rates of stroke and death, which I think is super powerful and important to show there's durable effects, but also the death phenomenon continues. So.
Just a practical question also. I've seen you probably have 20 pages or something when you have to report to NCDR.
Yeah.
So is it the implant itself that, and who fills out actually the NCDR forms?
Yeah, so the reason that we have, the CMS mandate's really important because sites, I mean, to be honest, don't always love having to do this. They have to pay to participate in the registry. They're mandated to participate in the registry, and it's time consuming. So most hospitals will have data abstractors. So historically, they're non-clinician data abstractors. Nowadays, actually, it's increasingly being done by these third-party vendors that can scan the electronic medical record and scrape the data off that way, and then they do some active sort of querying of the data sets. But and the HRS in the United States is trying to get an AFib ablation registry going where it's all entirely passive using third-party vendors to scrape the data off EHR. That's not been well validated. So we'll have to see how that effort goes, and it's still a developing effort. But yeah, I think there are vendors that can try and pull things off depending upon what electronic medical record you have, and then you have to do some manual entry. But yeah, it's not. We don't have the clinicians entering the data in general.
Okay.
Yeah. So I have a question and a comment. Sorry.
Yes,
yeah,
hi.
Ashan from UK.
Yeah, hi.
So last 2 years, similar to the US, we have the National Audit Reporting System called NICO, which capture PCI data, TAVI data, and last 2 years we started collecting the LAO data. So it is again, we have a capture about 80% capture rate because it's kind of mandatory. So the European one, sorry, is it in addition to your national registries or the one, or is it every country might have a national registry for LAO? Or?
No, not at all.
Okay.
Few countries have a national registry, so...
Okay. So what I'm thinking is, I mean, for UK, I think if we can have the same variables that you're collecting, it might be very much easier to amalgamate, and there are a lot of governance issues when I try to start in my institution. But a way forward could be, what I would try is when you agree on the variables, I could try to persuade the committee to add all those variables into our registry, and then maybe export that kind of a system if we can't get into the red and app system. But compared to US, we have very small numbers of LAOs, so definitely contributing to a registry is the way forward, because we won't be able to publish any academic useful data using a very small numbers at the moment.
No, I think that's very, very important that you don't do a double registry. That will be too much work. So, of course, we'll have to find a solution. And I think the RedCap database is very friendly to import different formats. And we do also have some technical people that can do these things and help to do that. And even though you don't have all the, parameters, we would be very happy to have the UK data within this framework. I mean, that will be very valuable as well. I think we have a wish list for also what we can do with the registry. So that's you, Xavi, that are going to present that.
Thanks, Eric. And thank you for the registry, because actually the registry comes from Arus, from Jens Erik, Anders Kramer, and Casper and the rest of guys. So this needs to be acknowledged. It was born there. So basically, well, I was supposed to talk about the trials I would like to see published related to the Elaacc registry. So then, since we had the pleasure to have Professor Freeman here, and then went back to the NCDR registry and then tried to learn a little bit about them. Of course, it's comparing a giant with a newborn. We are the newborn, but as newborns, we can grow, we can change, we can adapt, and we can learn from giants, from the strength, and also, I guess that I would like to ask you from the weakness as well, if you would change something, no? We can discuss about that. So we have the opportunity to change at this right moment, because, we're still small. The other thing I would like just to tell you is that I'm not going to talk about the current status, how to engage, how to do it, and go deep into the, just the inclusion of every country, because there's going to be a dedicated session at the end of the meeting. You have like 1,200, but in Spain there are like 1,000 more, and in other countries there are more. So like so far we are like probably around like just almost 3,000. So I mean we have like some power, and that's it. Of course, the problem is that we are not funded. I think that, and Philippe and the rest, we should consider just to be funded, because one of the issues that people tell me, it's that sometimes they struggle in trying to implement the blueprint into the system, try to implement RedCap into their systems, and of course the fact that the NCDR is audited. I mean, it's of course a plus. I don't know if at some point we will be able to do that, but so far, so what I did is just type in PubMed, and then you say that it was 37. Now it's 38. So, and you can see here in PubMed from 2020, 2026, the rate of publication. So it has been, like high since 2022. And this is the last publication. The thing that it's nice in the method section, they always, just acknowledge where the information comes from, NCDR, and of course, the number of patients and all this information. This is, I guess, the way that we should just proceed in that sense. And also, the impact factor of these publications, it's really high. It's, JACs, it's JAMA cardiology, it's circulation cardiovascular intervention, JAC CIs. And actually, you already show, but I try just to from these 32 publications, try to, see what were the topics of publication. And in 3 publications, you talk about generic, the first one, and then, like some, discussion about, the therapy itself. Then you also have 4 papers talking about demographic, gender, frailty, and some other, like just determinants of the population. Then also you analyze LAO in specific settings, intracranial bleeding, GI bleeding, and chronic kidney disease. 5 papers on LAO and imaging, like TOE, eyes, and all this. 4 on antithrombotic therapy post-LAO. 2 assessing the long-term outcomes after LAO, and you were born in 2020. So specific device analysis comparing Watchman Flex and with Watchman 2.5 or Watchman with Amulet 7. So that was probably the most, I would say, published topic or analyzed topic. Procedural analysis, more like, I would say, like technical stuff too. And then, complications, intra and post, like DRTs, leaks, embolization, all these 4. And concomitant intervention, I guess that now it's going to grow, so far with EP1. And that's your impact, okay? So 12 JAK CIs, 8 JAK clinical electrophysiology, 5 JAK, just in the general, 5 circulation cardiovascular intervention, 1 JAMA cardiology, and 7 other, publications. So congratulations. I mean, I think that it's the way for us just to follow. Of course, we're small, but I guess that we have, a lot of opportunities. So then, I will ask, all the audience at the end, what they like just to have published with the Elaacc registry. But I think, as you said, I don't know, maybe we don't need to wait until having, 10,000 patients, but maybe we should just first present, the registry into, the public, to know that we exist, and to know that maybe we can get some help, from, funding and audition and all this. I think that that's probably the most important publication. And then I pose, some ideas. The other thing that probably we have the strength to publish very long-term data, because since we started the therapy more than 15 years ago, I would say like maybe more than even that. So we can publish a lot, on data and beyond the 10 years. So I think that we have an opportunity here as well. Of course, DRT and PDL analysis, as Jan-Cedric showed, we're going to have a lot of information about, specific information about DRTs and PDLs. And you didn't open the window of DRT, but the DRT, you can also define the DRT. It's not yes or no. It's DRT, and then you can see exactly what's the DRT. And that's like really good, because we will have this information. And of course, then we can, analyze risk factors, management outcomes. Antithrombotic strategies, we will have everything. Even, like patients with prothrombotic status, we also capturing this information. And of course, like the things that we're going to talk today, so patient profiles associated with a higher clinical benefit. Then it's going to be interesting, maybe after our first publication, to compare, the difference between Europe and USA. The LIVESTREAM score validation, now it's been done, but maybe in a more, larger basis. And then, the imaging has been very successful, like 5 publications with your registry. We will have a lot of information on imaging, because the database is also dedicated for imaging, so we can analyze pre, peri, and post-procedural imaging. And of course, we will have a lot of information to compare different devices, because here in Europe, we have more devices. We have Omega, we have Lambre, we have other devices, so we will have information that we can use, as compared to Europe. The other thing that maybe we should discuss at some point, I don't know, but I would like just to put it here, and we were discussing it before. I would add, the quality of life into these registries, but not as a Kansas City, that it's more, about functional status. This is like here probably useless. I would just more, I don't know, to create maybe a quality of life score based on, like the bleeding and, the fact of taking or not taking the anticoagulation. So, I mean, people that don't take the anticoagulants can go out. I mean, like the agenda is completely different. They can have activities. They don't have just to be dependent on the pill. So I think that should make sense, just to record that change of habit. And finally, I would like to ask you, and now you have the poll, the questionnaire, where I ask you, what you would like, and this is a ranking, this is not, one option. I would like just to see, in order, the first, second, third, fourth, and fifth. This is like random, but I think that it's just a summary of what you would like just to see published in this Elaacc. What do you think that is more important? So I don't know if we can activate or, yeah. So we're talking about the general manuscript, this first in Europe, maybe just to have like the largest registry in Europe. Procedural data, talking more technical stuff, then, deep analysis of the DRT, PDL, and, the implication on outcomes. Focus on imaging, because, here in Europe we have a lot of debate between CT, eyes, TOE, 2D, 3D, and something that is really contemporary, that's the antithrombotic strategies. So this is a ranking, okay. No, it's still, like just only 19 votes. Sorry, what happened? Well, okay, so 2 options only? Well, it doesn't work. Okay, so let's do it, the manual way. So, what, like coming from here, like just the first option, who thinks that, a general manuscript, the LAO in Europe, with a large, sample, it's the most important publication at this point of the Elaacc registry?
It actually works, but for option 1, we need to make 1 star, for option 2, 2 stars.
Okay, so let's go back. It's more complex. Well, the primitive way didn't work because nobody, raised the hand, so let's go back to this. Well, anyway, what it seems that, like the antithrombotic strategy, it's probably now the paper that people would like just to see. And the rest would be balanced.
So just, if you publish the first paper, just what the registry is, all subsequent papers will reference that paper, and it will, it just has a description of, and in your method section, you'll just say, the registry has been previously described in summary, and you have a paragraph, but you've described the registry, and it ends up improving the impact factor of the work in the registry, so that our original paper from 2020 is highly cited, just because everyone else ends up, anytime they make a reference in CR registry, they reference that. So I would get that out.
So with any patient, no patients, just presenting the...
And the fact that you have devices that aren't available in other registries is helpful, just so, because people will then know what you have and what you're doing in terms of data collection and whatnot. And then just, I agree that you were talking a lot about funding as an important thing, and I think it's worth thinking about national funding sources and whatnot. The thing that really accelerated the publication out of the LAO registry is that our group at Yale, separate from ACC, we got permission from ACC to submit, and we got a $5 million grant from the NIH. And we published, most of those papers came out of that effort.
That's an important point, like also for publication, but also, for implementation. At this point, we need some help because it's easy once you have it. Sometimes it can be not too easy just to implement, the blueprint into the REDCap system. So that would be really much appreciated, just some funding in that sense.
And you want to pay data analysts. It'd be nice if you can have a stable of 2 or 3 data analysts that you can pay that stay with you for 5 years because you pay them well. And that's largely what our funding went towards, is our stable of our data analytic team that we've been able to retain. And you have a standard table 1 that's used in every one of your papers, and that makes it a lot easier. So I think the less you have turnover in terms of who's accessing the data and who's doing the publication, if you have a centralized publication committee and all that, it makes it much easier.
So I would like to ask you, like the question before, of course, like you are in another level. I mean, you are a giant and it's amazing, it's much better. I mean, audited, funded, everything. But what would you change, like putting it in our skin, like from the NCDR. I mean, if you can just make us a suggestion in that sense, just to be more information, just to be more precise, or just to be more broad? I mean, what do you recommend in the sense?
Yeah, I mean, again, I think we were slow getting publications out there, and so I think once you start that process and build enthusiasm, I think getting funding really accelerated things. So to the extent that you can do that, particularly to fund your analytic efforts, that'll be really valuable. I really think that some of the detail, it's always a tough balance of like more data, which is more to input and more work for all the sites versus less data, but being very strategic about what you add to the registry and being able to do so in a nimble fashion as new data comes out and as we start to worry about certain things more than we did in the past. And then also dumping old data fields. So look at your data collection form, and if there are things that you've not published on, get rid of it to make it easier for sites, and we've done that as well. So I think trying to be nimble with the registry is the other thing I would recommend. And then thinking about collaborations worldwide, which is of course why I'm here. Thank you, Philippe, and everyone for having me.
Thank you very much, Xavi. And Jim and all. So to close this session about data and clinical trials, I would like to go a few minutes with you about this question of the Academic Research Consortium initiative. First of all, thank you so much for those in this room who participated to this first effort. It's been a long journey, like 2 or 3 years, 2 physical meetings, one in Washington, one in Paris, and many discussions, remote and votes and discussion. That's the beauty of collaborative work. And we finally get some consensus, some definitions and endpoints that clearly updated the Munich assessment that we had from 10 years ago, and it will be published very soon in the European Heart Journal. So thank you so much for that. That was a great journey again, and sometimes it's tough. I mean, it's the beauty of collaborative work, and we know in this room, some of people, they know that we had some tough discussion for certain points, but I mean, it's very important for us to align on what is really important in clinical trials. And thank you again to the companies that helped doing this effort. So what should be done in new initiative? I mean, should we stay on this one for 20 years, or should we go further? Should we go beyond? I think we definitely need to go beyond. We covered with this one procedure, definitions and endpoints on mortality, neurological events, systemic embolism, bleeding. Cardiac imaging definitions were updated, antithrombotic treatment, about the intensity and the duration. We went through the composite endpoints and the trial design principle that were covered with this first initiative. And then we talk about patient profiles today. And this has not been covered with this first initiative. I definitely think we need better patient characterization. We need to balance the ischemic and bleeding risk in patients. And we all know there's some overlap between factors leading to higher or increased ischemic and bleeding risk. We have all these old patients with renal failure, with suboptimal procedure results, and what about the post-procedure treatment? Everything leads to higher thrombotic and higher bleeding risk, so we definitely need to better define this population. For those in this room who are interventional cardiologists, you probably know that we had a first effort to define high bleeding risk patients. It was in the PCI population, and it was in 2019. And this was the first effort to define these patients that are at high bleeding risk. And you can see here that we had some patient-related, procedure-related characteristics about this high bleeding risk. And this was at the origin of a lot of publications that have been really highlighted in the past 10 years on focusing on this population that was completely outside the focus before, because they were excluded from clinical trials, and we didn't know anything about these patients, but they are the critical patients. And logically, we tried to apply this criteria, PCI patient-specific, to a TAVR population. And we found that these criteria do not adapt to these TAVR patients because they are not the same patients, they are much older, it's not the same procedure, we have much bigger sheath for this procedure. So we were not surprised to see that these PCI specific criteria were not working for this TAVR population. So that's why we did another definition with the Academic Research Consortium behind us, and we defined these criteria that were really TAVI specific. And you see that we have now the validation of this in large registries coming from North America and coming from Europe in a broad population, some of them having some oral anticoagulants, and some of them representing high risk, very high risk patients. So what about the left atrial appendage closure procedure? I think we have to test these high bleeding risk criteria, but I would not be surprised that it's not working and that we need to define this new population, and that could be part of the next initiative. What about concomitant procedure? We just say that we have more and more concomitant procedures, especially in the US. But then, what if both an ablation or another procedure like mitral clip or other procedure and the LAAC are performed at the same time? So what is your guidance on how to assign device complications to two devices, to one procedure, which one? So we have to better define that. I mean, if you have a pericardial effusion and you have done an ablation and you have done a LAAC closure in the same procedure, how would you declare this pericardial effusion? This is something that should be clearly discussed in the next document. Let's go back to strokes. I mean, it's something, we defined strokes by the LAAC definition that we slightly modified, but we didn't want to change that because the LAAC has been defined by neurologists, and we really think they are the good specialists to define this. But at the end, when we think about grouping hemorrhagic and ischemic stroke, and especially for this left atrial appendage closure procedure, you can obscure some opposite effects and harm or lack of benefit by canceling each other, you know? So if you have an hemorrhagic stroke and if you have an ischemic stroke, and if you think about non-inferiority, you get neutral. But it's not neutral because it's not the same to have an hemorrhagic or to have an ischemic stroke, because hemorrhagic stroke are usually, as we all know, much more serious. So we have to think about that. Usually we have all strokes included in the definitions, and all strokes is not really fair. We talked about some, and we will talk about trials in the next session. And I think you all agree that it's not the same to have a large bleeding, intracranial bleeding, and to have a very small ischemic stroke without sequelae. So it's not the same, and it's quite bizarre to group all these events. I think we have to continue to promote sex-specific outcomes. I mean, there's underrepresentation of women in clinical trials. We have seen from your slides, Jim, that women are 42% of the procedures in the NCDR registries, and they represent maximum 30 to 31% of the patients in clinical trials. So we have to have an effort altogether to increase female representation in trials, because females have characteristics that are associated with more major bleeding, vascular complication, more pericardial effusion, and we want research to be driven by this specific aspect. And then that's another one. I think since years we can see that everyone said, okay, we need to ask the patients their opinion because everything we are doing here is for the patients. I think we all agree about that. And the regulators really strongly support that we get some opinion of the patients for designing clinical trials because, yeah, okay, now the primary endpoint is usually like efficacy, death, stroke, systemic embolism, but we don't really know if it's really something that is the most important for the patients. And I'm sure in this room, if you have some patient in the consultation, you will ask them what they really want for the future. And what they really want, as Xavi said, is I want to live, yes, but I want a good quality of life. What I don't want is to stay in a wheeling chair and be like, a problem for my family for 10 years. So they say, okay, yes, survival is definitely something important, but survival how? And this is not covered by the definition that we have at the moment. And I think we should make really an effort to ask to patients' association and to go through, what they think about bleeding concerns. If you have a bleed and a bleed and a bleed, and if you are going to the hospital every time, I think for them, I'm sure it's much, much, much more inconvenient than having a TIA, and then it's okay. And we usually perceive as physicians and as people working in this field that a bleed is not so important. You just give some blood and that's it. No. I strongly disagree. We don't see these patients when they bleed, but they are going in the ER, they are going in the intensive care units, and finally they have a much, much, much worse prognosis compared to patients without bleeding. So I think we should take this really into account. We have some statistical distortion. I mentioned the fact of hemorrhagic and ischemic bleeding, but I think it's really important to think about this. It's about the fact that non-inferiority trials are sensitive to even dilution. And we should not dilute events quality and severity by adding all these events in a composite endpoints. I think it's really important to continue to be as clear as possible. We will discuss in the next session about champion AF, about closure AF, and I think this is really some points to take into account. What about how to analyze the population? You know that efficacy is usually analyzed by intention to treat, and safety should be, or must be, I would say, analyzed as a per protocol analysis because they are driven by what has actually exposed the patient to a drug or to a device. So bleeding, did you get the bleeding? Yeah. Did you get a procedure? Yes or no? I mean, this is something, if you use the safety outcome as per protocol analysis, I think it would be less subject to discussion, and this is something that has been discussed, especially recently with the Champion AF trial. So I hope, it's a clear attempt to have you for the second initiative, both experts and industry, to have you supporting us. We need to continue to better define and to better, I would say, clarify about the definitions and endpoints in clinical trials. It's an endless story. We will continue to have new data, and we will try to get this done. I'm not sure that everything that I presented is okay, and there are probably additional very interesting things to discuss. So if you have suggestions, please take the microphone and let me know. Jim, other people, what do you think? You have been so important, so crucial for the left atrial appendage academic research consortium document.
we put the list back up? I think, I agree. I would agree with the prioritization that you put in place around kind of what we should be prioritizing next. And I agree with you. It's really interesting, your comments with regards to bleeding. Just, I did a bunch of early, in my career, did a lot of cost effectiveness work where we use quality of life data for that. And bleeding we really discounted as a few day phenomenon that didn't generally result in mortality. And I think I've really come to see with this patient population that that's not true for everyone. There are certain people for whom they have a single bleed and that's that, but many of these patients are really impacted by incessant bleeding events and whatnot. And so I couldn't agree more. I'm thinking that maybe a collaboration with John Spurtis, it's worth, John Spurtis has done a lot of work around development of scoring and quality of life, developed the AFEQT score for AF ablation, and I'll bring it up. I'm collaborating with John on a DRT project right now and can raise it with him around bleeding risk and quality of life. So, but I would agree. I think bleeding risk and thinking about how to, these net benefit endpoints are, I think we need to be thinking about. It was one of the challenges, we'll talk about closure, where it was a combined endpoint, and it's really hard to know what to do with those combined endpoints. So thinking about how to parse that out and then think about net clinical benefit is really a worthwhile endeavor as we move forward.
Okay, thank you very much. So maybe it's time to go to the next session.
So for many years we have asked for more data and especially more randomized data for LAAC, and now we have it. We have a very recent publication, actually 2 publications in New England Journal of Medicine, one with, I believe, a positive signal, and the other one maybe with not so positive or maybe a little bit negative signal. And also what has happened during the years are more and more ablation going on, and especially we have now PFA, a technology that probably is more safe than prior methods of ablation, and there's a lot of patients being sent to this treatment. And we also have 2 very interesting trials addressing can ablation therapy lead to stroke prevention. So it's a pleasure for me to introduce Tom DePotter. He's a highly recognized invasive electrophysiologist working in Belgium, and Tom, you will dive into the Alone AF and the Ocean trial.
Absolutely. Thanks a lot, Jens Erik. Let me check something. Yes. So I'm very much still working in Belgium, indeed, not in the Netherlands. I don't know why that's on there. I do speak Dutch, though. No, you were right. It's wrong here. As Jens Erik already introduced, 2 interesting trials were published in the space of AFib ablation and stroke prevention. The background to all of this is, of course, that first of all, what you need to remember if we're talking about stroke prevention in the AFib ablation population, you need to realize that the background stroke incidence is low. This is data from more than 10 years ago already from a European registry, where you can see that in our AFib ablation population, the incidence of observed neurological events is pretty low. And this is, of course, due to the fact that, especially then, but nowadays still very much so, a lot of the patient population that we treat is very low risk to experiencing clinical strokes. There is some argument to be made, of course, that there is more than stroke. There's good data, for example, one study we did using apixaban, evaluating apixaban, where brain imaging was performed exhaustively, where we were made aware of the existence of these phenomena, which are called silent cerebral lesions or silent cerebral emboli, not necessarily translating to stroke, but of course phenomena you'd rather not see in your patients. And again, in this study, as with all the NOAC trials, we saw that first of all, NOACs are capable of reducing these phenomena, and stroke rates are low to begin with. Now, the other two interesting questions for the purpose of this presentation are, and they are related, the questions are, is a fibrillation a sensible strategy to prevent stroke, and is stroke prevention still needed after afibrillation? So, is ablation a sensible strategy? Historical opinion seemed to say no. This is, again, more than 10 years old guideline recommendation, already saying that you should absolutely not do afibrillation to restore sinus rhythm for the purpose of avoiding anticoagulation, despite the fact that this is actually what many patients come for. Many patients, especially outside of the paroxysmal cohort, come to you, and if you tell them, well, you'll still be on anticoagulation after reablation, they look at you and they're a bit confused because they thought that was the goal of the procedure, that was why you were there. And also in the recent 2024 guidelines, quite clearly, although without data, class 1 level of evidence C recommendation, quite clearly the guidelines say that you should not discontinue anticoagulation after an ablation based on the fact whether you think the procedure was successful, yes or no. However, intuitively, it makes a lot of sense to say if we cure the atrial fibrillation, why should you do ongoing stroke prevention? And all these recommendations fundamentally are based on opinion. There is no was no definitive data. What we had was retrospective data and smaller prospective studies, and they were actually supportive of the hypothesis that you can safely stop anticoagulation, that you can reduce the stroke risk by ablation. And this is a hypothetical curve. This is not a data curve. This is a hypothetical curve illustrating the idea that if a patient that receives an AFib ablation most likely has a stroke risk which is similar to an AFib patient who is anticoagulated. And this revisits a bit what we learned 20 years ago in the AFFIRM trial, where we said, okay, it's not so important to have patients in sinus rhythm, and apparently there's not much impact on stroke. If you look at the data, that's not true, of course. If you look at the sub-analysis of AFFIRM data, the patients in sinus rhythm obviously did much better, and the patients that stayed on warfarin obviously did much better. A lot of patients in AFFIRM were taken off warfarin because the procedure was perceived as successful, and it was actually not. So the debate becomes a bit anticoagulation after ablation. Do you believe that, yes, indeed, atrial fibrillation causes stroke due to the traditional mechanism, the triad of thrombosis, which is universally present and also present in the left atrium, leading to clot formation and stroke? Or do you believe more that atrial fibrillation is more a marker of atrial disease, of atrial myopathy, of potentially systemic vascular disease, and in that case, of course, the afibrillation will not necessarily fix the stroke risk? As mentioned before we dive in the data, historical observational data strongly supports the notion that patients with ablation have pretty much the same stroke risk as patients without atrial fibrillation, no matter what the CHA2DS2-VASc score. If you compare cohorts, you will see in these large databases that patients without AFib and patients with AFib with ablation have the same stroke risk, and patients with AFib without an ablation typically have a higher stroke risk, regardless of their baseline risk. And so, based on this, two studies were performed. First of them, the ALONE-AF trial conducted in Korea, randomized clinical trial, where patients were selected that received catheter ablation for atrial fibrillation as their initial procedure, not necessarily a single procedure, and were at least 1 year after this procedure. No upper limit defined. Procedure may have been 5 years ago. Maximum age for the ALONE-AFib study, 8 years old. Patients were then screened to make sure, to verify that they were indeed considered successful ablation recipients by two Holter recordings of 1 to 3 days to confirm they were in sinus rhythm, and then they were randomized to either continue anticoagulation or to stop completely their anticoagulation, and they were followed with Holter recordings every 6 months for 2 years. Here's the patient flow in more detail, 840 patients randomized in the alone AFib study. Not too many protocol deviations, not too many crossovers. Baseline characteristics of the patients, you can see that about a third of patients is in persistent atrial fibrillation, which is considered potentially a more advanced disease state, certainly if you think about this atrial myopathy hypothesis, which is potentially a sicker patient profile. And you can see that despite the relatively low numbers, that alone AFib did not have particular important exclusion criteria. Pretty much all comers were accepted. And even patients with previous stroke, although only 5% of patients in the data set were randomized into the study. What the results of alone AF very clearly show is that for the primary endpoint, cumulative incidence of stroke, systemic embolism, and major bleeding, the primary combined endpoint, you can clearly see that continuing anticoagulation has a worse outcome, has a significantly worse outcome than stopping anticoagulation in patients with successful ablation. And you can also see from the secondary endpoints that this is predominantly, I would say, exclusively driven by a difference in bleeding risks, which makes a lot of sense. You can see that in terms of stroke reduction, it doesn't matter much. Again, the baseline risk for stroke is low in these patients to begin with, and obviously if you keep patients on anticoagulation, they will experience a bleeding risk. The other equally important and very similar trial, which was published beginning of this year, is the OCEAN trial. The OCEAN trial, again, recruited patients that received a catheter ablation for atrial fibrillation, again, at least 1 year after their procedure, and again, no upper limit on the duration of how long this ablation should have been in the past. Again, a cutoff on age. Both studies avoided recruiting very old patients, although OCEAN was a little bit more liberal in that it allowed patients up to the age of 85 years. And OCEAN did exclude patients who had a recent stroke defined as a disabling stroke within 1 year of enrollment, or any stroke within 2 weeks of enrollment. And also, OCEAN excluded patients with end-stage renal disease in their design. Just similar to alone AF, OCEAN screened patients with Holter recordings to verify that they were indeed in continuous sinus rhythm before randomizing them. And then slightly different to alone AF, where in alone AF, anticoagulation was stopped. In OCEAN, patients were randomized to receive either aspirin, low-dose aspirin daily dose, versus rivaroxaban at the reduced dose of 50 milligrams, regardless of renal function. OCEAN did study not only clinical outcomes, but also imaging outcomes. OCEAN pre-specified MRI imaging at baseline and at 3 years, specifically to look for these silent lesions, of course, and had a 3-year follow-up. In OCEAN, a little bit over 1,000 patients were randomized, 1,284 patients. Again, you can see from the patient flow charts that protocol violations and discontinuations were favorable, that most patients were able to adhere to the study protocol and complete the study until the final visit. You can see in the baseline characteristics of the OCEAN trial that, again, about 1/3 of patients has persistent or long-standing persistent atrial fibrillation, 2/3 of patients paroxysmal atrial fibrillation. And you can see, probably due to the slightly different design of Ocean, the slightly more, well, not slightly, the clearly more stringent exclusion criteria of Ocean, that few patients had a previous stroke, although again it was not specifically excluded, provided the stroke was long enough in the past. The primary endpoint of Ocean does not include bleeding, only includes stroke or systemic embolism. So here the survival curves are a bit different, but they give the same message, being that discontinuation of anticoagulation, rivaroxaban in this case, was not inferior to a strategy of aspirin alone. And Ocean, of course, did report on bleeding events. It did report in its paper on bleeding events, where you can see that there is a slight numeric, although statistically not significant, difference in bleeding events, both of them low, a little bit higher in the rivaroxaban group versus the aspirin group. Comparing both trials, you can see that the designs are fairly similar. The geographies are a bit different, which may matter in terms of stroke prevention and bleeding tendency. Ocean was done in 56 centers in 6 countries. LAAC was performed in South Korea exclusively. Enrollment similar, around 1,000 patients. And you can see the median CHA2DS2-VASc score in both trials, also relatively similar, not the highest stroke risk population. You can imagine a mean of 2.2 in Ocean, a median of 2 in LAAC. LAAC doesn't report the calculated mean value of their CHA2DS2-VASc score. And with respect to their primary outcome of stroke prevention of ischemic events, you can see that Ocean reports 1.4% of ischemic events on aspirin versus 0.8 on rivaroxaban, and you can see that LAAC reports 0.3 with no therapy versus 0.8 on DOAC, which is both the equivalent outcomes, and you can see that the penalty lies in bleeding, especially in the design of LAAC, where due to the fact that one of the randomization arms is no therapy whatsoever, and the LAAC reported 0 bleedings, so have a 0% of major bleeding rate versus, of course, a low but not negligible 1.4% of bleeding rates on DOAC. Ocean reports a very similar DOAC major bleeding rate of 1.6% versus a residual bleeding risk, as we're all familiar with, on aspirin of 0.6%. So what does this mean for stroke prevention by ablation? First of all, I think the risk factor versus risk marker debate is not settled. Remember the data we received from the ASSERT study. The ASSERT study clearly looking at subclinical atrial fibrillation events in pacemaker patients. The ASSERT study clearly showing that this intuitive concept we all have, a patient has atrial fibrillation and develops a clot in the appendage and develops a stroke, is not necessarily true if you look at our patient population that is monitored continuously, which is our pacemaker population. In the ASSERT study, we quite clearly saw that this linear temporal relationship between AFib and stroke is not always true, on the contrary. NOAA, AFNet6 and Artesia, the 2 studies on subclinical atrial fibrillation, also did not make life easier, I think, with their mixed message on stroke reduction versus bleeding risk increase. But the 2 studies just shown, Ocean and LAAC, do confirm safety of either no treatment or aspirin alone after a successful ablation. So I think the key takeaways for this space are, first of all, remember baseline stroke risk is low in the AFib ablation population. That's very simple. We don't treat a patient that is in the closure AF study. We don't treat such a patient with AFib ablation. That is not the patient profile that we see in our labs daily. And this is a historical observation. And this is a shared signal which is confirmed in 2 randomized trials. There are some clinically relevant differences between the trials. So first of all, one trial has no treatment as the comparator. The other trial has aspirin. On the other hand, the LAAC trial did not do any imaging, just looked at clinically evident strokes and used Holter monitoring alone for follow-up. But in general, I believe the takeaway is we now have 4 strategies for stroke prevention after AFib ablation, which are studies in randomized trials. These strategies are LAAC closure, DOAC, aspirin, or no treatment, as studied in the OPTION trial, the LAAC trial, and the OCEAN trial. And based on the individual situation your patient is in, I believe we can offer them any of these options, given what considering what might be most appropriate for that patient. And finally, remember, reassuring is that in all groups in our entire AFib ablation population, the annual stroke rate remains low. Thank you very much.
Thank you, Tom. It doesn't matter. Let's stand up. So, for any comments now, questions from the audience, Adele.
Just, yeah, sorry. I'm invasive cardiologist, you're EP, so when I see the data from the 2 trials, I see that there was a very selected population when you could ensure that there was a very low risk of AF recurrence, if I understand well. They did Holter and they checked the Holter again before randomization. And so to what extent, when you select, as an EP, when you select this kind of patient, you are sure that the rate of recurrence is low, so you can provide that kind of downgrade in the antithrombotic treatment. So you know what I mean? It's like if they're highly selected and you ensure that you have no recurrence, you can go for that.
No, it's a very relevant question. So what the trials did was they waited 1 year. They waited 1 year, and then after minimum 1 year, and sometimes longer, in many cases longer, then they did Holter screening twice to confirm or to maximally assure that the patient was indeed in sinus rhythm. Now, that gives you a population that is reasonably safe to assume that for the near future, this will stay the case. This does not mean that this is a population that will stay without symptoms for the next 10 years. And this is, for me, it's one of the big open questions, is what do you do? The trials don't answer this. If this patient, you see him 1 year after ablation, everything is fine, you stop the anticoagulation, and another 18 months later, the first recurrence is documented, I guess we'll restart the anticoagulation. But this is an open question. The trials don't answer this. What they do is they give you a good argument to doing something which, frankly, many in the EP community are doing already, which is not to anticoagulate the low-risk population indefinitely after a procedure which is perceived successfully until that time where you document the recurrence, which is easy to do in the paroxysmal population, which is sometimes tricky to do in the asymptomatic population.
What was in the protocol? Was there any action required in the protocol if these if a patient got atrial fibrillation within the trial?
I'm sorry, I missed the first part of the question.
Was there anything in the protocol? Was there any action required? So, of course, low-risk patients. But then if these patients had a relapse and they had atrial fibrillation, there was no anticoagulation required then?
No.
Or was there any? So they were off the whole time?
Yes. No, if a patient that has a recurrence of atrial fibrillation until now, for lack of better evidence, receives anticoagulation again.
James, you have a question?
Yeah, so it was interesting. I saw a tool presented on this on Ocean at the AF Symposium in Boston, and he said that in his opinion, this applied to anyone with a CHA2-VASc score of 3 or less. And there was only about 20% of the patients that had a CHA2-VASc score of 3 in the study, and then a very small number with 4 or greater. And I have to say there are a number of challenges associated with this. I couldn't agree more, your point about it's a highly subselected population. But it's also we know recurrence rates occur in 30 to 50% of people. Who are you applying this to in your practice right now? I mean, I would agree with you. We basically just use it as confirmatory for our very low-risk patients if they do well after AF ablation, but it hasn't really broadened what we're doing otherwise.
No, I agree with that. And so it applies for us in our practice to the majority of our patients, which are still the low-risk patients. We still have not moved extensively to treating very high-risk patients, which translate, the CHA2DS2-VASc score is not meant to determine a patient's risk for a procedure, for example, but it does translate. Like many things, you can use the CHA2DS2-VASc score for many things it was not designed for. And so if you end up looking at our database at who we actually ablate, there's not that many CHA2DS2-VASc 4 or more patients that we select for ablation. And so what we use this trial data for is to strongly confirm what we were doing already. So 0, of course, was off anticoagulation always. Patients with CHA2DS2-VASc1 were, in our practice, typically suggested to stop anticoagulation after successful ablation based on the equipoise that was already there in the guidelines, right, with the CHA2DS2-VASc1 score. These two trials now strongly confirm that it's probably actually the wiser choice to do that. CHA2DS2-VASc2, based on the trials we see that are published, will now also get this suggestion where historically they did not. So we have shifted our threshold from CHA2DS2-VASc1 to CHA2DS2-VASc2, everybody. CHA2DS2-VASc3 becomes, I don't have an algorithm for you, becomes an individual discussion with the patient.
And it's, I mean, also important to remember that not all CHA2DS2-VASc score points are created equal.
Exactly.
Right? So mild essential hypertension in female sex not the same as somebody with heart failure.
Exactly. Previous stroke, for example, although they were in the trial, I can't see myself doing it. And you can have a previous stroke CHA2DS2-VASc2 or 3, unusual, but they are there. It's absolutely right. And so the CHA2DS2-VASc score is an opaque general marker of potential cardiovascular disease. I couldn't agree more.
Laura, you have a question?
Yeah, there is a couple of points that I want to remark. First thing is, as Adele was saying, this is a very selected population of more or less healthy patients, so we cannot extrapolate that to all the patients with AF ablation. And probably in this very healthy population, they will not also a closure of the appendage at the same time. That it's other of the topics that we are touching. And probably we go back in the time for these patients as patients without any atrial fibrillation. So we need to just do a surveillance of them. And if another AF episode comes, we decide at that moment. But the other important thing is that in most of the studies of the EP groups, there is a lack of information regarding the anatomy of the atrium and also the anatomy of the left atrial appendage, because we are still looking at the anteroposterior diameter of the atrium for a lot of EP guys just to decide if they do the ablation or not. And we don't have like more strong markers of left atrial disease. So probably if we can combine this maintenance of the sinus rhythm with a healthy atrium, probably we can say that those patients are not at risk. So maybe it's something just to think forward.
I have no argument with what you're saying. As you know, we've also contributed to data trying to analyze, to do simulations of flow dynamics in the left atrium to exactly via one mechanism try to understand what you're hinting at, which is that in some patients and some anatomies, stroke risk may be very low no matter what. And this is why I showed this assert data. It's not because you have AFib that your stroke risk is the same as another patient with AFib. And this whole idea is not necessarily proven, is not necessarily correct that you have AFib and tomorrow there will be a thrombus in your trabeculated appendage. It remains speculative. There is no answer to your question. And the observation we have, and this comes back to the first part of your comment, and that's why I showed the first slide, is today the bulk of our patients we treat are very healthy patients. We treat them because we believe we can cure them from their atrial fibrillation, which excludes the vast majority of patients which you see, for example, as a potential LAA candidate, which are typically patients far beyond hope of restoring their sinus rhythm. Having said that, there is a lot of data emerging, for example, in heart failure, showing benefit of PV isolation in heart failure patients, which has led us to treat sicker patients. And especially in that population, I do think the concomitant story makes sense, because especially in that population, there is at least a subset where you think the probability of recurrence is going to be high and the probability of future issues is going to be high. And it makes sense whether you need to do it at the time of the procedure or later is a debate for another session. I guess you can argue about that. You might do it in 2 sessions. But it is shifting a bit. Until now, however, our patient population is extremely fit and healthy and unlikely to experience stroke no matter what.
Hi, Tom, Joël. Thank you for your presentation. So you demonstrate that after atrial fibrillation ablation, you can stop anticoagulants because the risk of recurrence is so low in your population. So based on that, is there still a space for combined procedure of LAAO plus the first atrial fibrillation ablation? So do you consider first attempt of AF ablation, then stop anticoagulant, and if recurrence after 1 year or 2 years, then consider LA occlusion?
Well, so that's exactly the sentiment I also have. You're absolutely right that, well, I didn't necessarily show that the risk of recurrence is low, but it is fortunately low in our healthy patient cohorts. It's not that low in the long-standing persistent cohort, but there you can argue whether you should ablate them. But having said that, yes, I agree that the debate, should you do an LA closure at the time of PV isolation versus in a second session, merits arguments for both sides. The argument to do it concomitantly is, of course, 1 exposure to risk, 1 exposure to procedure, which is not an invalid argument. The argument to do it sequentially is precisely like you say, especially in the patients you think are likely to respond, you wait. And this is the OCEAN and the lone AF population, I think, is the population where you wait. The CHASVA 0, 1, 2 population, you do the ablation, you wait. If they have recurrence, you can discuss LA occlusion if there is a patient profile that warrants it. The very high CHASVA population, which today I don't think we're treating a lot of them, especially not in Europe, but we are treating more of them, where for whatever reason you think the probability of AFib recurrence is high, I think the argument for concomitant is still not 100% do it, but we shouldn't throw it out of the window. But I think the European practice validates what you're saying. We don't do that much concomitant.
I mean, there's also the high-risk bleeding population, right? So, I mean, someone who can't wait a year because they have cerebral amyloid angiopathy, they just have incessant GI bleeding, those people are other candidates that we think about it for.
Exactly.
SN.
So the recurrence of AF measured by the 24-hour tape and 48-hour tapes, or is it because I thought AF burden is more important than detecting just a few episodes of a few beats of AF? First question. The second one is, do you think it's the most in clinical practice, it's 10 to 12 weeks that you tend to stop anticoagulation, but this trial extended to 12 months. What's the rationale behind this?
So the first part of your question, the detection of recurrence, the Holter screening that was done in the trials, first of all, was to confirm eligibility, was to confirm was the AFib ablation successful? This open question, which in clinical practice will hopefully mean 1 Holter for most of our outpatient clinics. Is Holter the same as burden for stroke risk? That's an unanswered question. The simple answer is if you do more screening, you will find more AFib. If you give everybody a loop recorder, clearly you will find more AFib. And this is, in part, it's not exactly what Artesia and AFNet6 studied, but it's in part what they studied. The question then becomes, what do you do with these potentially subclinical AFib episodes? Are they the same stroke risk as clinically overt AFib? The answer from both trials is if you anticoagulate those patients, as you would intuitively expect, you gain stroke reduction at the expense of increased bleeding risk. Lorenz.
Tom, very interesting talk, thank you. I have one question that is challenging me a bit. So you said that in the current AF guidelines, there's class 3 to stop DOAC after ablation. And then we have 2 trials that you have presented that actually suggest that you don't need it. But if you look at the event rate, it's extremely far away from being powered for ischemic stroke. So you would probably need 10 times the number. So now we are confronted with a situation where on the one hand, the guidelines say class 3. On the other hand, you have 2 massively underpowered trials that indicate that you could do it. So what would be the conclusion now? I mean, I understand it's clinically it makes very much sense not to give, not to continue DOAC in patients who have no recurrency, but still there is this dilemma, I would call it.
The current guidelines, so the class 3 recommendation is from more than 10 years old, is not to do AFib ablation for the goal of stopping anticoagulation. The current guidelines, they do the wording the other way around. They say you should not stop anticoagulation after AFib ablation only because you believe the ablation was a success if the patient otherwise has indications for stroke prevention. And so it becomes a class 1 indication because the wording is reversed, level of evidence C. With this new data, if I were on that, well, I was on that team, but if I were on it now, I think I would say you can revise that statement now. We have data to revise that statement. I agree with you, not to a wording, stop anticoagulation in every patient after successful ablation. But now you can make a statement such as data supports discontinuation of anticoagulation in patients with an appropriately low risk profile for stroke after successful ablation. And that is 2 randomized trials. That's level A. Jim, what do you think?
Can I just comment also, your point about the underpowering for differences is appropriate. That said, the absolute rates were extremely low and well below the threshold that we would often think about for initiation of anticoagulation. So I think it's reasonable to use those absolute numbers rather than having to show a difference that's relative, that's powered appropriately. So that's, I think, how things will shift in the EP community based on the absolute numbers. I mean, the numbers were staggeringly low in Ocean. Including the fact that they did MRI looking for silent cerebral events. I mean, almost unbelievably low.
Maybe can I add something as an electrophysiologist as well, because a little bit of a provocative idea is there is no study out there yet that has shown that doing anticoagulation post-ablation is actually something good to do, because I think each ablation kind of resets the AF burden that we have in these patients, and it's a completely new situation. And so far we didn't have any data. Now we have Ocean, we have lone AF, we have also the data from Option, and at least in low-risk patients, it seems reasonable to stop it. But on the other hand, we always assumed that we do something good, continuing anticoagulation, but actually never knew so far. That's the first time we have data on this.
One more short question, Tom. What is your view on repeated ablation procedures? Is this something you will only consider for the first time ablation, or if a patient come back and need a redo procedure, are you still...
Would I apply alone AF and Ocean to redo?
Yes, to redo
It's an excellent question. The study actually did not, the study population is that population. It did not say patients could only have had 1 ablation. Like many of the elements, so again, TRANSVAS 0, 1, no discussion, 2, probably no discussion. The higher it goes, the more these soft elements come into play if you do your discussion with your patient. For example, a patient with multiple redos, it's obviously more likely that the patient will have a recurrence. And so there it becomes less of a solid statement like we're convinced that you're fine and we're convinced that it's fine to take you off anticoagulation. Less so. There is no black or white. It's a balance, but multiple redos for me would be an argument leaning towards continuing anticoagulation.
Thank you very much. There will be also, after the next presentations here, we will finalize the session with poll questions to try to get some consensus, so we will have more time for discussion, but I think we'll proceed.
Yes, and I will swap places with Jens-Erik, because there's more data than just post-ablation patients, and Jens-Erik will take us through the Champion AF data.
So can you put up the slide? Thank you. Yeah, so very recently we saw the Champion AF trial research published in New England Journal of Medicine. They were initially presented at the ACC and then a co-publication in New England. And we all know about the background for this study. I think all in the room appreciate that left atrial appendage closure is an important option for stroke prevention, because we have many patients out there that simply cannot tolerate long-term anticoagulation. But as you know, the Champion AF is about, can we broaden out this stroke prevention concept to a broad AF population where patients can actually be put on DOAC treatment and are suitable for long-term anticoagulation. That is the purpose of the Champion AF. And it's a large study, as you see. 3,000 patients were randomized. They had, based on CHA2DS2-VASc, 2 for males or more, or 3 or more for females, intermediate to moderate increased risk of stroke. And they were randomized 1-to-1 to LAAC with Watchman Flex or to DOAC treatment. The post-procedural regimen in the trial was predominantly full-dose DOAC. In the first 3 months, 85% had that regimen, and then 15% had DAPS. And after 3 months, all antithrombotic or the initial antithrombotic treatment were changed to just single use of aspirin for 1 month, and then the follow-up imaging was done. So it's also the first trial where you do the follow-up imaging after de-escalation of the post-procedural treatment. Also importantly, the study here is designed for follow-up during 5 years, and the initial publication here is related to follow-up after 3 years, and we still have also to wait at the 5-year data in this trial. Primary efficacy was a combined endpoint of cardiovascular death, stroke, and systemic embolism. And some would criticize the inclusion of cardiovascular death. This was simply also a criteria from FDA, and also looking at some of the prior LAAC trials, there has been a signal actually towards lower cardiovascular death with LAAC, so this is completely relevant. And then the whole concept of LAAC is about reducing the bleeding risk for patients to have them off DOAC. So of course the safety endpoint here is related to bleeding. It's non-procedural major and clinically relevant non-major bleeding, and this endpoint was tested for superiority. You all know about the major bleeds. The non-major clinical relevant bleeds here were a modified one. Actually, the criteria for the bleeding severity was strengthened a little bit. Those bleeding episodes are episodes that require either hospitalization or some kind of healthcare intervention. The design or the non-inferiority margin has been discussed a lot based on the time where the trial was planned. The estimated rate for the primary endpoint was 12% in each group. It turned out to be down to 5 to 6%, so much lower. One of the explanations is that almost 50% of patients in the trial had ablation. But the non-inferiority margin was set to 4.8, and power calculation showed the requirement for 3,000 patients. And of course, there were some dropouts during the trial course, but it ended up with 2 large cohorts for intention to treat analysis. And you can see, first of all, with the Hasbett score, it's low, it's 1.3. So it's not a high bleeding risk, it's a low bleeding risk population, and you can also appreciate that more than 60 to 70% were actually between CHA2DS2-VASc 3 and 5, and almost 20% more than 5, so there's also a good amount of patients with a high stroke risk in the trial. And again, if you see the lower line, almost up to 50% had ablation. The procedure was very successful, carried out with 99% success. And if you look at the complication rate in this large randomized clinical trial with many centers enrolling patients, it's really good data. You can see we have a complication rate around 1%, only 0.6% effusions, no device embolizations, no mortality, only 1 periprocedural stroke. So I think it's very, very good data that we now have a very safe interventional procedure that is not more risky than PCI, ablation, or other things we do in the cath lab. If we look at leak rate and degree of sealing, it was also very good, with almost 99% having a complete seal or less than 3 millimeter leaks, only very few leaks between 3 and 5 millimeters. Then we have a reported total DRT rate of 4.8%. This is a mixture of TE and CT evaluations, and especially CT evaluations contributed to this number, because all layerings on the atrial side of the device being 3 millimeter or more was counted, but you can see that only in 1.8% those changes led investigators to treat for DRT. And also, if you look at the very high risk DRT, like the pedunculated DRTs, the number here was very low, and only 2 patients had stroke associated with diagnosis of DRT. And then the primary endpoint, you can see 2 curves that are almost completely overlaying here. You have to zoom in to detect any differences, and there is a slightly higher number of primary efficacy endpoints in the LAAC arm, 5.7% versus 4.8%. This is a difference of 0.9%, and it's highly away from the initially defined non-inferiority margin, which could have been as low as down to 2.6, and still we will get a significant non-inferiority signal. If we look, this is not reported in the paper, if we look at per protocol analysis, the numbers are even, or the difference is even smaller. Then the primary event rate in the DOAC arm is 4.4%, and it's 4.7% in the LAAC group, so it's down to 0.3%, so it's even smaller. So if we look more on a breakdown of the primary endpoint, we can see that cardiovascular death is the same, and as we all have noticed there is a little bit or numerically higher ischemic stroke rate in the LAAC arm. We have 50 cases, and we have 33 cases in the DOAC arm, including also 2 systemic embolizations. So this translates into an annualized rate of ischemic stroke systemic embolism of 0.8% for DOAC and 1.1% per year for LAAC. But a stroke is not a stroke. A stroke can be very disabling. It can be much less severe. And most of the strokes in the Champion AF trials were actually non-disabling. And if you look only at the disabling ischemic strokes, which is what really matters in daily life, I think, then we have 13 disabling strokes in the DOAC group and 19 in the LAAC arm. So the difference is 6 patients out of a cohort of 3,000 patients followed over 3 years. So that is not a huge difference, I think. And what is also interesting about this study is probably the study where we have the highest degree of adherence to the DOAC. We had 87% of patients in the DOAC arm that adhered to the therapy. So it's a very, very high rate. Primary safety endpoint, that is major and clinically relevant non-major bleeding without procedural bleeds. I will rapidly go to this slide because I think that's probably more fair and more reasonable to look at, because this also includes the procedural bleeds. And you can see initially during the first 6 months there is a higher rate of bleeding in the LAAC arm due to inclusion of the procedural bleeds, but you can see after that the curve starts to separate and you have a huge difference at 3 years of 19% versus 12.8%, and you can see the continuous separation of the 2 curves over time. So looking only at major bleeds, again, remember this is a low-risk bleeding population, has bled 1.3, so there's not many major bleeds, but they are out there as well, and you can see again a little bit higher in the LAAC arm initially, but then numerically more also major bleeds in the DOAC arm compared to LAAC. If you try to put this a little bit into context with the stroke rates and look upon some of the previous LAAC versus DOAC trials, this is actually all stroke rates you could separate into ischemic and hemorrhagic, and you know from the Protect AF we also had more ischemic strokes in the LAAC arm, but it was equalized by less hemorrhagic strokes. So total stroke rates, Protect AF Prevail, PRAG 17, option even closure AF and Champion AF, you can see that the stroke rates are quite similar whether you go for mechanical LAAC or you go for medical treatment with DOACs. Okay, there's one slide missing, but I think we also have to mention here that the ischemic stroke rates in the large pivotal DOAC trials, they were 1.1% and up to 1.7%. So it's actually the same stroke rates we see in those large trials than we see in the Champion AF LAAC arm. So this is a large trial of LAAC, and it has demonstrated non-inferiority to DOAC in this composite endpoint of stroke, systemic embolism, and CV death. At 5 years, we will have a separate analysis on just ischemic strokes and systemic embolism. It might be the case that more patients on DOACs will lose their adherence in this period, and it might contribute, I don't know, but we'll have to see, to more ischemic strokes in the DOAC arm. I think What is very clear is that we, with LAAC, get much less bleeding. And I was amazed to see that in a low-risk bleeding population with a Hasbled 1.3, we have 20% of patients having bleeding episodes over 3 years. So it's a very frequent problem in daily life for AF patients taking DOACs, and we all know that that is one of the main drivers for non-adherence if patients run into bleeding episodes. So LAAC may be considered as an alternative to DOAC in a shared decision-making process with AF patients who are deemed actually suitable for long-term DOAC. We can discuss that if the data will allow us to do this in clinical practice. And again, we'll see more data after 5 years. Thanks.
Thanks a lot, Jens-Erik. Anybody wants to offer any comments or questions or insights? Sergio.
Congratulations, Jens-Erik, an excellent presentation of the trial. So probably the data from Champion are helpful to identify the correct target population for the LAAC closure. Just a comment from you, your interpretation on the ischemic stroke, the difference of the ischemic stroke between the two arms.
In my perspective, I think the stroke rate is very low in both groups. And I think in clinical practice, we can never achieve near 90% adherence rate with DOACs. So I think in real life, we would see more ischemic stroke in the DOAC arm. So I think it has been highly, I think, overemphasized in the discussion. This is 6 patients that differ if you look at disabling strokes. So I don't think of course, you can also think about what if ischemic stroke rates were equal in the two groups. Then we would have a trial that was a completely home run, and we could discuss LAAC as a first-line therapy. No, I think it is a modest difference, and I think in my own practice, I would not sit with a patient and inform about, okay, here we have 0.3% difference between this and this. I think with all the data we have when we look at also the LAAC versus DOAC prior trials and on the pivotal DOAC trials, I think I would make the interpretation that the stroke risk protection is similar between the two strategies. And where the difference is in the bleeding risk. But this is something, of course, we can discuss. So is that a real signal, or is it just statistical variation?
Jens-Erik, I think it's very important to mention that what we have in Champion, as you said, is the best of LAAC with this expert center, I would say, first-line expert center. You mentioned the very low number of complications and the best of anticoagulants with 90% adherence, which is absolutely not what we see in real life. So coming back to this stroke difference that you mentioned, you talked about the per protocol analysis that shows that we have less disabling stroke, and especially with the per protocol analysis. What about the bleeding? Because I think there's something with the bleeding that is, that is quite bizarre, is about this non-periprocedural bleeding, you know. But if we want to be fair, you have to add the periprocedural bleeding. And if you look at the per protocol analysis, what is the difference between the serious bleeding and the total bleeding?
The breakdown to the disabling stroke numbers, that is still the intention to treat analysis. So the company didn't release all the details about the per protocol analysis yet. I just have the total numbers, which was 4.4 versus 4.7%. But the reason why I think the procedural bleeding is separated from non-procedural bleeds, I think you can easily argue that it's two very different things. Having a bleed, being in hospital, where a lot of the bleeds are growing bleeds, and that's one-time bleeds that can be managed when you are in hospital. It's very, very different from getting a bleed remote to your procedure after half a year, maybe suffer gastrointestinal bleeding. And one more thing, I think this Kaplan-Meier way of looking at bleeding endpoints probably is not completely the right one, because what we see in clinical practice is typically, let's say we get a patient with a gastrointestinal bleeds, and it might be treated surgically or something like that, and then we as cardiologists really aim to put this patient back on DOAC, and then we very frequently see they come back with repetitive bleeding. And also, what can happen many times if you have a bleeding event that will lead to stop of anticoagulation, that's the other route, and then it will lead to more ischemic stroke. So in some way, I think the Kaplan-Meier way to look at bleeding underestimates actually the bleeding problem. So one consideration is maybe to count all those bleedings that occurred during the trial and talk more about the bleeding burden. That could be relevant. And I would also like to have that as part of if you do cost effectiveness analysis, because one of the things that can really support LAAC, if we can come up with some of the expenses for those patients that are going to the hospital, emergency units, etc., with those repetitive bleedings. So I think it's very important. Kaplan-Meier sort of underestimates this issue.
James?
Claudio?
Yeah. I really agree with the concept of the bleeding burden. Probably just makes the difference. Before we listen to the closure AF, I think that we need just to point out some difference between the two studies. Number one, the Champion AF obviously recruited a younger patient population as opposed to the closure AF. Number two was implanted just the Watchman. While on the other studies, just that we have different devices implanted. This, probably we need just to take it into account. I do really think that the message, at least for me, from the Champion AF, that probably the best way is just to intercept patients at the earlier stage. Otherwise, you might, end up to have a different clinical outcome. This is probably what we need just to, take the message home from the Champion AF.
I strongly agree with this statement, and I believe that's the way to go to intervene earlier in the disease process. But Carsten will, in a minute, also go through the closure AF, so we will have that in details. But also one comment regarding the procedural bleeds, because Champion AF full dose NOAC as the principal way to do post-procedural medication, but I think that's always more or less historical, because now we know a lot about DAPT associated with very high bleeding, and we have very intriguing data about just the use of half-dose DOACs or single antiplatelet therapy. And we have the first device. This was Watchman Flex, not Watchman Flex Pro, and Watchman Flex Pro might also allow us to minimize the post-procedural regimen even more. So I think also the procedural bleeds with just our development of the therapy and the post-procedural medication, that will help us to reduce the amount of procedural bleeds. And I believe also we still have some leaks. And James also pointed out that even small leaks can contribute to a thromboembolic risk. And I mean, the next generation device from Boston and from other companies with the Ambulance 360 and the lead device from Boston, they are sealing better, or they are designed to seal better and to also cope with this issue. So there will be this continuous improvement in device technology.
Yeah, really, truly, the fabric is important and critical. I would like just to have a clinical trial by using a half dose of the DOAC. I think that we need that data.
Yeah, that is very important, but as you know, there will be for the Watchman Flex Pro, we already finalized randomization of 1,000 patients having single antiplatelet, dual antiplatelet, or half dose DOAC. So that will come out probably TCT this year, so we will be guided more.
Congratulations for the authors for this important study. I hope this will have an impact on changing some guidelines, especially European guidelines, and it is an important trial for the community. The question I have is, when they decided the number of event rates, if they thought the event rate would be smaller, would have needed a higher power. So do you think if we had more patients, the results would more favor LAAC than the DOAC? Because 12% versus 4%, that led to the inferiority margin of 4.8, isn't it?
I'm not sure I got your point fully.
So it's regards to how did you decide the inferiority margin based on the 12% event rate?
Yeah.
Because if the event rate, what we observed was very low.
Yeah.
So if we initially thought that this group of patients will have low event rate, the number of patients we would have recruited, the power calculation would have been different.
Yeah, you had to have more patients.
So would that have delivered a better outcome for LAAC? Because maybe the difference that what we are seeing may be due to the low number of events.
Maybe because, I mean, the numbers for strokes are so small that they are easily explained by just statistical variations. And I think looking at the other trials would suggest that this could be the case. But of course, we need to see that. But I hope the 5-year analysis will be helpful in answering this question.
Please, we have one more. Okay.
Jens Erik, so some of the non-believers of LAAC closure could also argue that even in the Champion AF, which is a very contemporary trial with expert centers, the rate of DRT is still rather high, even with 3 months DOAC therapy after implantation. And so if you believe that we could go a step down on anticoagulant therapy after LAAC closure, even with these rates of 4% DRT, what is your opinion on that, except for the newer generation devices that are being developed, which may help us in the future, but still in a low to moderate risk patient population like in Champion AF, we still need to address this DRT rate of 4% to convince the community that it's a safe therapy.
I fully agree, and I would say we are not free of the problem of DRT as also seen by those numbers. But I would say that there has been a lot of confusion out there in diagnosing DRT because it is problematic and not extremely easy to discriminate natural healing of the device with real DRT. And I can say that when the imaging protocols were created for this trial, there was not, for instance, the HAD classification and definition of what's going on the atrial side of the device. That was not available, and it was analyzed according to the initial image protocol. So I'm quite sure that there will be a sub-study diving into the details of this. Was it just, had class 1 changes in the majority of cases, and was DRT cases diagnosed falsely, reality being seeing natural device healing? And I think that will be part of the explanation, especially when you see only 1.8% reacted and actually put the patient on treatment for DRT. So I believe it's overestimated, but the number is still out there, and we need to do it better. But we also need to come out with details on that analysis, because if you really have 4.8% as real DRT, that is a bad signal.
Very briefly, and then maybe last question from Claudio. What is your practice, Jens-Erik? Very briefly, is it CT or TE?
That is cardiac CT.
Yeah, thank you, and thank you for raising up, this issue, because I do really. I'm afraid that not, the DRT so classified in the champion was really, thrombus, because it depends if you use the CT. It's much more, sensitive than the TE, and therefore I hope, I'm pretty sure that probably the rates of DRT are much lower than what, is reported in the clinical trial. Sometimes it's really difficult to distinguish industrialization of the device, as compared to a real thrombus.
And you can very easily have 3 millimeters of layering on the device that just continue to the LA wall and across, and it's just a matter of very nice healing. So, yeah.
All right, thank you very much. And in the interest of time, we do have one other very interesting piece of the puzzle, one last very relevant recent trial, which is, of course, Closure AF. And it's our pleasure to invite Karsten Skurk to present on the trial.
Yeah, thank you very much. I figured that there is a lively discussion, and therefore I will just present the data, and then we can discuss the trial. So originally, you see, DZHK trial 16. It was designed in 2015. It's investigator-initiated, prospective multi-center in 42 centers in Germany. It was conducted, and I can go over this. So basically, we know evidence in 2015 was even worse than today. Basically, we thought at that time that it is really important to have a trial in a high-risk population, because that was a population we actually did LAAC in. These were the patients that had a high stroke and high bleeding risk, because then they are not eligible for bleeding, and we should discuss bleeding in regard to closure. And so basically, then the other thing we thought, of course, investigator initiated, we don't have the power of big companies, so we have to conduct a pragmatic trial, and that's why this combined endpoint, that was one part of it, and the other part is, and we discussed it today, of course, major bleeding in this patient population is relevant, and therefore it is a good endpoint. So endpoint: stroke, ischemic or hemorrhagic, systemic embolism, cardiovascular unexplained death, and major bleeding, according to the BARC classification. So how were the patients selected? Schatzwask, larger or equal to, an increased bleeding risk according to Hasbled, not the best characterization, but there is clinically no better one, larger equal to 3. a history of major bleeding according to BARC, history A to C, and renal insufficiency was the third parameter, eGFR 15 to 29 milliliter per minute. Patients on hemodialysis were not allowed into the trial. So these patients were randomized to catheter-based left atrial appendage closure with devices that where results were published with more than 500 patients, so basically Amplatzer and Watchman, or physician-directed best medical care. We figured, okay, these are high-risk patients that might not have DOACs, so that's why best medical care. Primary endpoint, the composite of stroke, systemic embolism, cardiovascular, unexplained death, or major bleeding. And originally, it was planned at least 18 months follow-up. In the end, we were at minimum of 6 months follow-up, and I will tell you why. So the trial was originally designed as event-driven with an expected event rate of 11.2, and that would, we expected 1,586 patients in the trial with a non-inferiority margin of 1.3. Just as comparison, Prevail had 1.8 and Prague 1.5. So this is a really tight non-inferiority margin for an interventional trial. Then there were 2 planned interim analyses that we conducted, and we found, these were blinded of course, that the event rate is higher or was higher than expected, and therefore we could change the design to less patients, and then Prague 17 came out with another event rate, so that we were pretty sure that we had enough events to close the trial, and it was ended in November 2024. We would have liked to present it with a presentation at AHA, but there were some unforeseen problems with, I can talk about later. So, what was the peri-interventional therapy? That's really important at that time in Germany, and I would say before closure was published, 60–70% of centers, that is 3 months stopped, and aspirin until 6 months. If there is no other indication for aspirin, if you had excessive bleeding risk, then you could go down, and these was just a recommendation to 6 weeks of DAPT and aspirin up to 3 months. In the best medical care group, it was advised to give DOACs if the patient was eligible for this therapy. So 912 patients were randomized, and we see 446 were randomized, were included in the primary analysis in the LAAC arm, and 442 in the best medical care arm. And patients were therapied as one, got the therapy. 93% in the LAAC arm got an LAAC, and 85% in the best medical care arm were treated with a DOAC. So basically you could say, well, actually it's a trial intervention against DOAC. So with these inclusion criteria, we were quite surprised which patient fulfilled these. So basically 80-year-old, 40% females, but a Schwarz-Warsk of larger than 5.5 spread of 3, but look at the other characteristics, major bleeding, almost half of it, status post major bleeding, and a stage 4 chronic kidney disease, 1/4 of these patients. So really high-risk patients for stroke and bleeding. And here we see the medication. So basically, adherence was quite good. You see the DAPT got off after 3 months, but, and that's interesting in this age group, not surprising, approximately 70% of patients received aspirin over the whole period, and that's a point for discussion. In the best medical care arm, we see, if you want to have that, a really good adherence in this high-risk bleeding group to DOACs, because basically 70% of these patients took DOAC during the whole time of the trial. So mean follow-up was 3 years, maximum follow-up was 6.7 years, so quite good. And then the other question is, of course, 42 centers in Germany. These were all experienced centers. How good is the quality? And I saw the registry data, and it's basically the same. It's quite the same age, and we have technical success of 98.3% with these older devices, but procedure success is good as well, but a little more leaks than Champion has, but 3 major leaks in the LAAC group. Of course, if you have high-risk patients, you have a higher complication rate. As you can see here, 5.7% is almost double as much as you would have expected. Major bleedings, okay, older devices, but we have a device embolization and 2 deaths due to pericardial tamponade in these patients. So you know the event curves, and what you may not know is that as farther you go out, over 4 to 6 years, this is great territory because a lot of patients died or are censored. So less event rate that could be by chance. You see that the curves narrow and then separate again. And then, of course, ITT analysis and per protocol analysis look the same. 16.8 events, whereas 13.3, and this means that LAAC is non-inferior to best medical care in this patient group. Why do I say that? Because we did not pre-specify a test for non-inferiority. So Premier, it was planned as a non-inferiority trial with a second test for superiority for LAAC. Good, then the other question is, okay, non-cardiovascular death is the same in both groups, pretty much, and we see here the event rates. And you can appreciate that basically, except for ischemic and hemorrhagic stroke, these event rates are more often determined in the LAAC group compared to best medical care. So basically, it's non-inferior because you have more events of the primary outcome in the LAAC group. And we just want to thank all the people who contributed to the successful completion of the trial that took twice as long as we originally planned. And I have some slides for the discussion, but maybe we should start.
Kasper.
First of all, great achievement, Carsten. It's very impressive to do investigator-led studies, and I don't think we all know how hard it is, so congratulations on that. On a second note, if you calculate, it's 10 procedures per site across many years. Do you know how many procedures that were done at each site? Because this is not an all-comer study.
Right.
This is a selective population. And the indication, the inclusion criteria is pretty much the only indication we have at the moment.
I know that is one critique of the trial, but in general I would say we tried our best to recruit more patients. But there are several aspects to it. So first of all, of course, in Germany we do more LA closures. This patient population is actually the patient population LAC is done in, or was done, let's put it this way. And the other one is that hospitals lost half of their patients if they recruited into the trial. And I guess that was one reason why recruitment was lower than we expected. That is first of all. Second of all is then COVID came, and we had 6 months pause of recruitment in the trial, and afterwards it was really slow coming up again. So there are several issues with recruiting. I guess no trial recruits as expected. So finally, with these high event rates, otherwise we would still recruit patients. We could go down with a patient number and had the statistical power still in the trial.
Yeah, Carsten, a question. How that trial change your, let's say, looking at the patients which are now in your center, let's say, selected for the LA closure? I am asking that because in my practice that trial changed not so much. But in many Polish centers, many of patients are now, based on the results of the trial, excluded for the LA closure because physicians who are not directly involved with LA closure are using the trial to say that it's harmful to perform the LA closure because these patients are too sick. So what's your strategy in your center? Does the trial change anything or not?
Yes, of course. We have a trial which I think is of high quality, and that shows that if you do LAC as done in the trial, then it might be harmful to the patients. So what are we doing? We are more critical in selecting the right patients. And that is one thing. Can I have the slides up again, please? And the other thing is, of course, the peri-interventional antithrombotic regimen. So as soon as closure was done, so I don't give DAPT anymore. But then, of course, okay, this is randomized data. Can you have the slides again? I just want to show. So the good thing is, of course, even in this high-risk population, and we saw Champion and we saw Option, even in this high-risk population, the LAAC is doing what it's supposed to do. This is really important. So if you speak about bleeding, I don't know any randomized trial that could prevent major bleeding. And Philippe said that, and so it's never has been shown in any trial, LAC versus anything, that major bleeding is significantly reduced.
Non-procedural, yes, but if you take all major bleedings together, there's no trial that shows that, except in the Marcumar vitamin K antagonists. And the same happens here. So if you look at bleedings and you just exclude these 18 major periprocedural bleedings, it might have been non-inferior. And if you look what happens within the first 3 or better the first 6 months, because data capture is a little bit slow. So after 6 months, you have only 50% of major bleedings in the LAAC group. So it might be that in Champion, 5-year follow-up will for the first time show that major bleedings are reduced in a randomized study. So as long as you wait, as better it gets, even in closure. Although, and that's the other discussion, this is time to first event. So repeated bleedings are not in here, and we will do an analysis with all endpoints in the trial. Experience tells you that that is not really different, but since ischemic and hemorrhagic stroke have low event rates, this might be really a difference in major bleedings because they appear quite often. So this is one thing. So if I have a closure patient, and there are, I don't want to show you all these slides, there are some data out that imply that it's safer to use other regimens, half-dose NOAC, single antiplatelet, much better than dubbed, without any harm. Although there's a selection bias in these registries because, of course, people with a really high bleeding risk or active bleeding get these medications, and these are few people, and stroke rates are really low. So yes, we are more critical in this patient group, and we would do another peri-interventional antithrombotic regime.
Javi, you had a question?
Yeah. So for me, it's really surprising the control group, the high rate of, DOAC plus aspirin, DOAC plus DAP. So it was like 90%. So if I imagine, my population, the patients that I treat, that, mostly are, like patients with previous major bleeding, like yours, I cannot imagine just that these patients would accept, just to go back to the medication that causes a major bleeding. So my question is, in that sense, there was a selection bias to select patients that maybe could tolerate, like the anticoagulants in the, in general, or you dismiss, the patients, with very.
I don't know. No selection bias. There are inclusion-exclusion criteria, and then the patient get into the trial. And of course, you would select really few people, and that was when we, applied for the grant for closure. How many contraindicated DOAC patients are there really was the question in all these fields, right? And so we see Champion adherence 90% over three years, surprising because NOAC trials had adherence rates 70, 60%, 70% over 2 years. Not a high bleeding risk population. And these are the data. So I can't tell you, but I wouldn't say it's a selection bias because people wanted to give DOACs. It just tells me that we overestimate how well DOACs do.
Yeah, no.
That's my opinion if I see these data. I wouldn't have expected it.
One thing that is of concern to me is the mortality rate. The yearly mortality rate is 14% in this trial, and cardiovascular mortality is the primary driver for the difference between the groups. And my point is here, you are probably very, very advanced in the stage of the AF disease. So can you really, with an interventional procedure, change anything, or they are just dying from other causes? And I can tell you that we went back and looked at our mortality rate in our Danish cohort, and it's 2.9% per year in those we are treating with LAAC. So that is 3% versus 14%. So it's extremely different, at least to what we are doing in Denmark. So.
Yeah. We did not go back, look in our cohort, but I'm quite sure it's lower as well. Yeah, these are 80-year-old patients, and 80-year-old patients. So in the States, 78-year-old or 76-year-old have 8% mortality per year. So so this is a little bit higher, and that argument, of course, that people die a lot in the trial, in both groups, for whatever reason. There is a small signal for more cardiovascular death in the occluder group, but that could be by chance. So that's the other problem with these patients, right? So overinterpretation. So I would say, okay, they die at the same rate, which is high, but still before they die, they have events, and these events are distributed in a way that is disadvantageous to LAAC.
Thank you very much, Carsten. I think we need, you cannot leave the room because we need to do our poll questions here and try to see if we make some kind of equal interpretations about those trials. So can you please get us the poll questions for session 3? And you can only do one voting per question. So you have to choose the question that you feel is the best, or the answer that you feel is the best answer to the question. So let's see if we can get the set of questions up here. And we also need Tom to vote yes. Okay, I don't see the questions on my phone yet. Or the poll questions for session 3. What's going on?
Benjamin told us that there is no slider on this session.
Oh, yes.
So we don't have any Slido.
What is going on?
Benjamin.
We have
Is the only one that...
yours or? Okay, we don't want to miss there's some technical problem. I think we'll take the coffee break, and then you will get the questions after your coffee break. Is that okay? Yes.
Do it in the beginning of the next session. Thank you very much.
the birds in the morning don't sing anymore. The grass in the valley is starting to die, and out in the darkness the wells cry. Alone and forsaken by fate and by man, oh Lord, if you hear me, please hold my hand. Oh, please understand. Oh, where has she gone to? Oh, where can she be? She may have forsaken some other like me. She promised to honor, to love and obey. Each vow was a plaything that she threw away. The darkness is falling, the sky has turned gray. The hound in the distance is starting to bay. I wonder what she's thinking of, forsaken, forgotten, without any love. Alone and forsaken by fate and by man, oh Lord, if you hear me, please hold my hand. Oh, please understand.
You should have shot me, baby. My life is done. You could have shot me with a gun. I hear those sirens scream my name.
vado io giù. Ciao. 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 Buona serata. Ehi. 7:30.
Ah, già me l'ho detto?
8:30 inizia. Anche oggi hanno fatto un'ora prima dell'inizio delle
Portate
prove.
i corretti, per favore.
Sì.
Va bene.
Un pezzo di riuscire a trovare. Ok. Ehi, provando test 1, 2, 3, 4. Ok. Grazie. Grazie Andrea. Grazie.
Quindi lui si è andato per quello che non giocare.
Alla fine, tra tagli e tagli e tagli e tagli, alla fine si può praticamente rifatto quello che c'era su i due presenti. Sì.
Just a kiss, just a kiss. I have lived just for this. I can't explain why I've become this chatelaine. Just a smile, just a smile. Hold me captive just a while. I can't A smile, hold me captive just a while. I can't explain why I've become Micheline. Every time your eyes meet mine, clouds of warmth burst into sunshine. Just a kiss, I have lived just for this. I can't explain why I've become Micheline, 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 Micheline.
I can see you're disappointed by the way you look at me. And I'm sorry that I'm not the woman you thought I'd be. Yes, I've made my mistakes, but listen and understand, my mistakes are no worse than yours, just because I'm a woman. So when you look at me, don't feel sorry for yourself. Just think of all the shame you might have brought somebody else. Just let me we'll both know where we stand. My mistakes are no worse than yours, just because I'm a woman. Now a man will take a good girl and he'll ruin her reputation. But when he wants to marry, well, that's a different situation. He'll just walk off and leave her to do the best she can, while he looks for an angel to wear his wedding band. Now I know that I'm no angel, if that's what you thought you'd found. I was just the victim of a man that let me down. Yes, I've made my mistakes, but listen and understand, my mistakes are no worse than yours, just because I'm a woman. No, my mistakes are no worse than yours, just because I'm a woman.
Everybody's got the feeling that is something we all know. Fever is such a new thing. A fever started long ago. Romeo loves Juliet. Juliet, she felt the same. When she put her arms around her, he said, "Oh, Julie, baby, you're the play."
tables in the back.
Specify. Okay, welcome back after the coffee break, and please scan the QR code again because we didn't get to finalize session 3 fully. So scan the code and you will get the poll questions for session 3. And again, only the physicians, cardiologists in the room are invited to vote here because, again, we want to use this for some kind of consensus later on. So have you scanned the code, all of you? Then we can maybe ask for the first question. So based on the Alone AF and Ocean trials, will you be ready to skip anticoagulation post-ablation in AF patients, CHA2DS 1 to 2? So there's a clear signal here. 75% says yes. Okay, it's not finalized. Okay. Why is only we have only we have a total votes of 7 only?
I think it is people who complete it because you can fill in all the answers and then send, right? So I think we can go over the questions and then in the end you have to press send, right?
Okay, so you are answering all the questions now, yeah, okay.
And I think it means we have 10 complete answers now, right? Is that correct? Okay, I guess we can go to the next question. We have 16 complete already. So based on the ALONE-AF and OCEAN trials, will you be ready to skip anticoagulation in patients with prior stroke, regardless of CHA2DS2-VASc score? It's a pretty clear answer, I think. Nobody seems to be ready to do this. And let's go to the next question. If you do skip anticoagulation, how would you monitor for recurrent AF? Apple Watch or similar? Majority of responses. Holter at regular intervals, implantable ECG recording, or symptoms, no systematic monitoring. This is an interesting result, I think.
Yeah. The friendly way to monitor for patients.
Well,
yeah.
this is a very interesting result. It's not what was being done in the trials that were performed. It's definitely not what is being done in clinical practice in the CHA2DS2-VASc 1 and 2 population, not by a long shot. Probably a good way to monitor patients, but not what is happening in practice.
Still getting a few responses. Yeah. Let's take the next question now. Based on the Champion AF results, will you consider LAAC as a reasonable alternative to DOAC in a shared decision-making process? Majority says yes. Still only got 36
I think that's probably
votes,
about right.
or is that what we can expect? Yeah, maybe. Let's go to the next then.
Let's move to the next question, please.
And that's for people that do not consider LAAC as a reasonable alternative with the current data. And there are different arguments here. More data, wait for the data after 5 years, and still concerns about the stroke rate difference. And some wants to wait for the catalyst to have more randomized clinical data. Okay. Let's move on to next question. The Closure AF trial enrolled relevant LAAC candidates and failed to demonstrate non-inferiority to standard medical care, and we should therefore forget about LAAC. That's also a hard question. So, yeah, I'm glad we have a clear answer here. So should we see the next question? Can you move on to the next? Yeah. The Closure AF trial can guide us to determine which patients should not be selected for LAAC in clinical practice. And I'm a little bit confused about the bar that I see here. So it should be only... okay, they moved to... there's some confusion here. Oh. And
this is the question, if you believe that closure should be used for patient selection, by which parameter. So I think the majority voted, and slightly more than half identifies patients at high age with high degree of comorbidity, right?
But we really missed the correct question for one thing here. But okay, we don't have more time, so thank you very much for the input, and then let's proceed to the session 4.
Thanks.
It's my pleasure to co-chair this session with my friend Sergio Berti from Italy. It's going to be a nice session about emerging indications. So we have talked a lot about patient profiles, which patient would be a good candidate for LA closure. There are some emerging indications that we are addressing now within this session. There will be some polls also that we will.
I think yes, we can start with the. We have one poll.
The first poll, maybe. So just to say that we will have the poll before and after the talk of Dr. Stiermaler. So let's start with this one. So what is your preference approach for stroke prevention in hemodialysis patients with AF? So vitamin K antagonist, DOAC, low molecular weight heparin, LA closure, or individualized decision?
Yes, individualized decision. Yes, the personalized medicine approach.
So it seems already that there's a controversial aspect of this indication.
Because it's a very unexplored territory. Okay. Okay, the treatment should be based on an individualized decision. Okay, can we move to the next poll? In the dialysis patient with atrial fibrillation prior major bleeding, should LAAC closure be preferred over anticoagulant?
So it's half and half almost. Okay.
Yes, routinely.
And there was
Okay,
there was a last poll, I think. Yeah, there was like 3 questions. Can we see the last one? So the patient with the end-stage renal disease with a CHA VASC of more than 2 but no prior bleeding, would you consider LA closure? So it's really like
the consensus is
it's not clear.
Not balanced. Not balanced.
Okay. So it's our pleasure to invite the first speaker from the team of Lübeck. That's Thomas Stiermayer.
Your microphone.
Yeah, you have the microphone there. So he's going to address the LA closure in dialysis patients.
Yes, Thomas, after your presentation, we will see the impact of your presentation on the opinions of the colleagues.
Yeah, but I just realized that we forgot one option, inclusion in a clinical trial.
Okay.
So I'm very happy to be here and to contribute to this important meeting. Also, you might have heard of the German airline strike. So my trip started at 4 a.m. and was a bit like oral anticoagulation in hemodialysis patients, a bit of chaos and a lot of uncertainty. But as you all know, you know the numbers that atrial fibrillation is increasing. We have a lot of patients. It's increasing with age. And the incidence is even higher in the end-stage renal disease cohort, with an increasing incidence of atrial fibrillation with a decrease in eGFR. And these patients are also at an extremely high risk of embolic events. Also with a further decrease of renal function, the strokes and embolic events increase. But as you can see in this analysis, the amount of patients of end-stage renal disease patients with sufficient oral anticoagulation is low, at least in the warfarin era, where only 1 out of 3 had sufficient anticoagulation or had anticoagulation. And that's probably because of the extremely high bleeding risk in this cohort, because of high comorbidity burden, and we do not have DOACs or vitamin K antagonists that are on label in this indication. And if you look at the outcome data comparing those patients on warfarin to that patient population who did not receive anticoagulation in the warfarin area, you see that the stroke hospitalization rate is similar in both groups. So the question is warfarin really effective in this population? And of course, you have these increased bleeding rates in the patients who receive warfarin. Of course, today we would prefer DOACs, but as you all know, they are contraindicated in hemodialysis patients and in end-stage renal disease. But we do have some data that compare apixaban to warfarin, like this US Medicare database with more than 25,000 patients with end-stage renal disease. And after building a matched cohort, you can see similar events of stroke or embolic events, but again, warfarin is not really good at preventing strokes in these patients. And you can see a lower bleeding rate if you use apixaban compared to warfarin. And we also have 2 randomized trials I will show you now, and you can see on these trials that it's really difficult to perform randomized trials in this patient population, because both trials have been terminated early after enrollment of only a subset of patients than originally planned. Renal EF randomized 154 patients. It's about 20% of the targeted population, and compared apixaban to warfarin on chronic hemodialysis patients. And of course, this small subset of patients doesn't provide sufficient data, but as you can see, the also bleeding rates were similar in both cohorts. And what is really striking, we have a bleeding rate of 25 versus 31% within 12 months. So 1 out of 3 to 4 patients experiences bleeding, and the stroke rate is 3%. So altogether, we have a 10-fold higher bleeding risk in these patients compared to the embolic risk, and we also have high 1-year mortality rates, with 1 out of 4 patients dying during this study. The second trial, Exadia AF, also terminated early. Again, 97 patients in 39 centers in 5 years. So if you calculate that, it's not a lot of patients. And they compared apixaban 2.5 versus vitamin K antagonists in chronic hemodialysis patients. And again, there is not a lot we can derive from this data. Low stroke rate, high bleeding rate, and high all-cause mortality. So the current situation with oral anticoagulation hemodialysis is we have an extremely high-risk population. We do not have reliable data to guide our clinical practice, and we do not have sufficient guideline recommendations. There are some ongoing trials, but I'm very pessimistic that we will get sufficient data on DOAC soon. And we have various off-label treatment regimes. So some physicians use vitamin K antagonists, some use DOACs in full dose, DOACs in low dose, low molecular weight heparin, or just do nothing at all, or just do low molecular weight heparin on dialysis-free days. So some call it chaos. We have chaos in the management of these patients. And of course, LAAC could be the answer, as you know that most thrombi originate from the left atrial appendage, but there are several aspects that we should consider. We have these extremely high mortality rates, probably not related to embolic events. We have this high bleeding risk, which will probably also be high if you give dual antiplatelet therapy or even SAPT. And we have probably a higher procedural risk and a high comorbidity burden in these patients. And do we have data? There are several registries that compared LAA closure to standard of care, but we do not have any randomized controlled data, and I think the most reliable publications in this field is probably this analysis comparing LAA closure in CKD versus non-CKD patients, and it shows a similar efficacy, but a higher rate of acute kidney injury and also bleedings in hospital and in the long term in the CKD group. And we also see this extremely high event rates, also mortality rates in the long term, probably because of the bleeding risk of these patients. And one recent publication, which is quite nice in Czech Interventions, nearly 15,000 patients with end-stage renal disease, and it's from US registry, and they were treated with warfarin, LAA closure, or apixaban, and they built matched pairs, and as you can see, this is quite promising for LAA closure. LAA closure is the reference, and it performed better compared to apixaban and warfarin in terms of the primary endpoint, which was stroke or systemic embolism, bleeding, and all-cause mortality. But again, even in the LAA closure group, we have 42% event rate within, in median 1 year in the composite outcome, and we have a 19% bleeding rate, which is really, really high. So we need a randomized trial, and that's where the LAA kidney trial comes into play. It's an investigator-initiated trial which we are coordinating from our center in Lübeck. It's funded by a grant by Abbott, and we randomize patients with an end-stage kidney disease defined as an eGFR below 15 and atrial fibrillation with an indication for oral anticoagulation, and it's a one-to-one randomization to LAA closure or best medical care, and some say we compare LAA closure to chaos because best medical care is actually everything that I showed before. The primary endpoint is a composite of stroke, systemic embolism, cardiovascular or unexplained death, and major bleeding. It's actually the same as in the Closure IF trial. And we need to randomize 272 patients, and it's an event-driven non-inferiority design. I think the inclusion criteria are quite clear. It's an all-comer trial in the end-stage renal disease cohort, and so far we have 185 patients randomized. That's 68% of the targeted population. But you can see the randomization, the recruitment rates are quite very flatter than we want them to be, so we are happy that Adele and his colleagues in Belgium will join us soon, so we can get the remaining patients. But you remember the trials I showed before. We already have more patients in this trial than the other two randomized trials could contribute. So I would like to sum up that stroke prevention in end-stage renal disease is a dilemma. We have an extremely high-risk population. If you thought Closure IF was high risk, this even more. LAAC could be an alternative, but we need clinical data, which we get when we finish the LAA kidney trial. Thanks.
Thank you, Thomas. Now we repeat the polls, so we check your ability to convince the audience that LAA is a good option. Okay, can we have the first again? Yes.
Okay, we could stop here.
After the polls, I have a question for you regarding this point. Okay. Okay, 60%, 63 individualized decision.
Pretty much the same as before, isn't it?
Yeah, And there was the last one? There was the last...
Okay. Do the next.
Can we see the next?
Wait.
Or we just wait?
Okay. 46 versus 41.
So it's on
Okay, the
balance
next.
again?
Oh, not finished.
And maybe the last question? Yeah, it's a little tendency for selecting patients. And there was a last question, I think. So a patient with more chance of at least 2, but no prior bleeding, still there is like a small consensus that we should go for LA closure. Maybe...
Thomas, on the basis of the data you showed, it seems that the dicumarolic are not effective in to prevent ischemic event, or is less effective to prevent ischemic event, but the rate of bleeding is very high, and the situation is not better for the DOAC because the bleeding is extremely high. So intuitively the LAAC closure seems a good option. That's correct. But the question is, and I want to involve Carsten in the discussion, we are at risk to fall in the closure AF area. So patient very, very sick. So what is the balance?
Yeah, you're right, but the problem is that we also have a 20% bleeding risk in the LAAC closure arm in the last study that I showed. So we have to think about how we manage the patients after LAAC closure. I think this is a point of discussion. And patient selection, of course, we designed an all-comer cohort trial, but after closure F, one could think about selecting the patients more like an age cutoff, but we have to get this data from closure F first, and I think it will be too late for the LAAC kidney trial. But I do agree that probably the high-risk 80-plus patient with a lot of comorbidity will probably not benefit from LAAC closure.
Let's ask someone in the audience, or Carsten, or I can ask the question to you, Carsten. If you have that kind of patient, and you in some way you calculate the mortality, and the mortality for this specific patient is 25%, end-stage renal disease, do you go for LA closure based on your data or not?
He randomizes.
Right. So we randomize, and it's a 1-year mortality is 25% in these patients. So that tells you something, right? But so before closure, we thought it's a really great idea, and it's a new indication. Right now, I'm more skeptical, but yeah, of course, everybody goes into the trial.
But I think we all have different opinions about what to do, but I think the only answer will be from a randomized clinical trial. Otherwise, we'll always get stuck with we don't know exactly what to do in those cases.
Right, and we get a lot of data also in the control group, what is done in these patients, and what is the best way probably if you do it conservatively.
Yeah, Philippe?
No, we don't have randomized data. We need more data from the registries. As we discussed this morning, this afternoon, with Jim. We need large numbers because these patients are really not the same. They are high risk for thrombosis, high risk for bleeding, contraindicated to DOAC, and they have a higher risk of stroke. So I mean, it's really a very specific population, and we don't know the best option. So I run for the individualized strategy for this reason.
I would be interested because we just discussed it a little bit. I mean, my major concern would be they might benefit from bleeding, but you have the device in place and they may have a high risk for DRT. So how to treat this, how to prevent the patients from DRT. So in your study, what is your therapeutic regime after
So the recommended regime was 3 months of dual antiplatelet therapy, and it can be shortened to 6 weeks, and we recommend now to do it as short as possible, to 6 weeks dual antiplatelet therapy. And if there is an indication for aspirin, then they receive aspirin afterwards, and if there is no indication, then they don't have anything at all after 6 weeks.
And do you do, 6 weeks is a very short time frame. We know that DRT occurring later in many of the cases. So do you intend to do a closer imaging follow-up in these patients?
In our center, we have 2 TE follow-ups after 3 and 12 months, but we do not recommend this or do not ask for this in the study because we know that some centers can't do that.
And if you see DRT in those patients, what is your treatment strategy for that?
The first one is low-dose apixaban. A control after 4 weeks, and if it's gone, we are fine. Then the question is, we try again to remove apixaban, of course, because of the bleeding risk, but then it's individualized and also some kind of...
Adele, we have time for 2 short questions.
But the question here from Martin.
So one comment, I think it's great that there's a study ongoing that will recruit as many patients as possible, but for the time being, I think there's one thing that is missing in a discussion, and that is the fact that if you ask the nephrologists, they don't put patients on hemodialysis, on anticoagulation or low molecular weight heparins if they have AF. They only put those patients on anticoagulation if they have an extremely high risk, and that is if they had previous stroke. So for the time being, I think we can already concentrate or focus on these patients that had previous stroke, because in those patients the embolic risk, the thromboembolic risk, is much higher than the bleeding risk, because you need to have a higher thromboembolic risk to overcome the downsides of the bleeding. So in the patients that we want to anticoagulate or offer alternative therapy, LAA closure, or those with extreme high risk for the time being, but hopefully you can expand that population to not only those patients with previous stroke and having end-stage renal disease.
I agree, but and I also agree to the point that the nephrologists use this scheme, but there are no data for it.
Sorry, there are not?
There are no data for it. There are no studies supporting it.
Okay, very short.
Short question. Why DAPT and no, let's say, reduced dose of apixaban? You have shown that apixaban is not worse?
Yeah, because we started a study about 4 years ago, and it was the state-of-the-art treatment for after LAA closure by that time. So maybe we would change it if we designed the study today.
Okay, thank you, Thomas. Congratulations. Excellent presentation, excellent discussion. Okay, we move to the next presentations. We're going to address another very specific situation. Patient that despite optimal medical therapy experience stroke. I invite Gavino Caso for the speech, and the presentation of Lorenz is close, so we will do a single discussion at the end of the presentations.
Good afternoon, dear colleagues. First of all, thank you very much for inviting me to this meeting. So, my disclosure. So, atrial fibrillation is the most common arrhythmia in general population, 1-2% to general population, and is responsible to a high risk of stroke. Direct oral anticoagulation are recommended to reduce the risk. In this database, standard dose of direct oral anticoagulant were associated with low event stroke and cardioembolic and systemic embolic and cardiovascular death. Related to the safety, standard dose of direct anticoagulant therapy were associated with low risk of the major bleeding, so fatal bleeding and hemorrhagic stroke, but a higher risk of gastrointestinal bleeding. So direct oral anticoagulant reduce stroke, but stroke can occur despite oral anticoagulation therapy. The rate reported in different trials from 2% to 30%. This represents a significant clinical challenge in patients' management. Several mechanisms are proposed to explain the occurrence of the stroke despite oral anticoagulation: atrial fibrillation unrelated stroke, poor adherence or clinical inertia, inappropriately reduced dose anticoagulation, and finally, true oral anticoagulation failure. But this mechanism is very complex in more patients. No one single mechanism. Often the mechanism is not understood, very, very complex. First, competing mechanism might lead to ischemic stroke, large arterial atherosclerosis, small vessel disease, coagulopathy and hypercoagulability state, such as cancer, or no-atrial-related cardioembolic source. In this study, the etiology of stroke despite anticoagulation may be divided in three main mechanisms. Competing mechanism, large artery 60%, and small vessel disease 26%. The other, insufficient anticoagulation, cardioembolic despite sufficient anticoagulation. Another point, very important, is a poor adherence to direct anticoagulant therapy. This therapy offers many advantages with respect to warfarin, but not always this advantage translates into good adherence. In fact, in this study, only 66% of patients with in therapy with direct anticoagulant therapy achieve a good adherence. When facing patients with stroke despite anticoagulation therapy, the main key is understand the exact mechanism of the stroke to guide secondary prevention. The workflow can be divided into three main groups. The first, identify mechanism, competitive mechanism, and it's very important to choose the brain imaging like MRI could help us to understand or to distinguish the cardioembolic pattern, large atherosclerosis artery, and multivessel disease. In the context of the large atherosclerosis disease, we needed to use some technical like CT scan, echo Doppler, and MRI angiography. And we need further investigation to exclude other mechanisms of cardioembolic or testing, laboratory testing for hypercoagulability or vasculitis. And in second, poor adherence to understand if the patients give a good adherence to the therapy, adequate therapy, or drug-drug or drug-food interaction. And finally, we can be considered true anticoagulant failure, and in this case, we need to exclude the thrombus in left atrial appendage. So when we move into the secondary prevention, the question is, what is the best strategy for these patients? Continuous oral anticoagulant therapy, switch to another anticoagulant therapy, or adding antiplatelet, or rhythm control, or left atrial appendage occlusion with or without oral anticoagulation therapy. We don't have strong evidence to a routine switch to another anticoagulant therapy. And in this context, switching no give any benefit, but increase the risk. And adding an antiplatelet therapy increase the bleeding risk, but don't reduce the risk of stroke. In a renal extended study, 42% of patients continued the same oral anticoagulant therapy, and 39% switched to another coagulant therapy. And the adding of antiplatelet therapy gives an increase of bleeding risk. So, is it time to consider left atrial appendage occlusion in this context? In my opinion, yes. In this international surveillance study, we studied 95 patients with stroke with a 2 oral anticoagulant failure. These patients, we performed left atrial appendage occlusion, and we find only 1% of the periprocedural complication, and 2 years of clinical follow-up, we find 4% of ischemic stroke and 3% for cardiovascular death. So this is my take-home message. Stroke, despite all anticoagulation, identify a very high-risk population with a significant residual risk of recurrence. Not all events reflect true cardioembolic failure. An alternative mechanism must be considered. Switching or modifying oral anticoagulant therapy is insufficient to reduce the risk of stroke. A mechanism-oriented diagnostic workup is essential after stroke in oral anticoagulation therapy. A mechanism-oriented diagnostic workup is essential after stroke on our oral anticoagulation therapy. Left atrial appendage occlusion represents a promising strategy in selected patients with true oral anticoagulant failure, and stroke, despite oral anticoagulation therapy, remain in unmet clinical need, requiring further recommended evidence. Thank you.
Great talk. Thank you very much. We keep the discussion after the talk, so it's my pleasure now to introduce Lorenz Räber, a friend and colleague from the Elaacc, from other purposes. Lorenz is going to address the LAAC in extreme stroke risk subgroups. And we will keep like 15 minutes of discussion after the two talks.
Yeah, thank you very much. So the pathophysiological considerations were already nicely presented. And I will add what is going on in the field currently in terms of generation of evidence. And of course, the first question would be how, and that's then for the poll, we cannot make the poll now, how would you actually define extreme ischemic stroke risk subgroup, because this is not officially not defined. And I suggest that that we would focus on particular clinical scenarios such as the breakthrough stroke. Why? Because the recurrency risk of ischemic stroke in this population is ranging between 5 and 10%, and there's no other clinical entity that has such high recurrent ischemic stroke risks. In terms of previous randomized controlled trials, you see the CHA2DS2-VASc score here. Clearly the leading is Closure AF with a CHA2DS2-VASc score of more than 5, followed by Prague, then Prevail, Option, Champion, and finally Protect AF. But in terms of ischemic stroke recurrency risk, none of these trials have numbers like 5 to 10% per year. These are the numbers at the maximal duration of follow-up, like 3 to 4 years, and the highest numbers were in Closure AF with 7.2% at 3 years, which gives an annual risk of roughly 2 to 3% per year. So if we then look at patients who suffer from a ischemic stroke despite taking DOAC due to AFib, we have quite some data available, and as you can see here, the risk is really ranging between 4 and 9% per year. And how frequent is that? We did an analysis in the Swiss stroke registry, and the proportion is incredibly increasing. Over the last 10 years, it increased from 10 to currently 40%. So if you look at all AFib-related stroke patients, 40% of those are currently, in the year 25, are taking regularly a DOAC therapy. So that's an unmet need. And the treatment concept that could be hypothetically useful in these patients is a dual strategy combining oral anticoagulation and percutaneous LAAC. Now, this has been actually tested, of course, not in a breakthrough stroke population, but in a population that, as you know, in the LAAC underwent surgery and had a surgical occlusion, and the critical point here is really that they had a high CHA2DS2-VASc score of more than 4, and all of these patients received continued oral anticoagulation on top of the surgical occlusion per protocol. And if we look at the adherence throughout 5 years, it's actually quite high, more than 70%. And as you can see here, the best, the pointer is not working, in the green frame, the numbers of recurrent ischemic stroke were actually lowest in those patients getting both occlusion and those who were kept on oral anticoagulation. So here we get a clear insight into the potential benefit of combining both strategies. So what is known so far, not too much in the field of treatment of breakthrough stroke with percutaneous LAAC. There is one large trial mainly conducted in the Netherlands, a propensity score matched analysis where a total of 440 patients were treated with percutaneous LA occlusion, and in approximately half of the patients continued oral anticoagulation, and they were compared to a 1,200 patient large patient group that was receiving just continued DOAC therapy, and the results were quite interesting. You see the Kaplan-Meier curve that shows in orange those patients who received percutaneous LA occlusion on average 4 months after the breakthrough stroke event, and in blue you see the recurrency rate in terms of ischemic stroke in the oral anticoagulation group, and there was a significant difference. Of course, this was non-randomized propensity score-based registry, but nevertheless very interesting. And this trial that we did, a registry with 95 patients, was already presented. Now, which are the ongoing trials? The first one I like to present is the ELAPSE trial that we are organizing from Bern. ELAPSE means early closure of LAAC for patients with atrial fibrillation and ischemic stroke despite oral anticoagulation. This is an investigator-initiated trial that is supported mainly by the Swiss National Science Foundation, is international, multi-center, prospective, randomized, controlled, with 2 arms. We plan to enroll 480 up to 1,000 patients. Why this range? Because it has an adaptive design. After the occurrence of 50 events, we will recalculate the power and then, depending on that, reassess the total sample size that is needed. Patients will receive within 6 months after the qualifying breakthrough stroke a percutaneous LA occlusion with a continued DOAC monotherapy up from the very beginning, so no addition of antiplatelet therapy, versus continuation of direct oral anticoagulation therapy only, and the primary endpoint is at 6 to 48 months, is a composite of recurrent ischemic stroke, systemic embolism, and cardiovascular death, and imaging is done either by TE or CT at 1 to 3 months. Inclusion criteria, of course, these are patients with AFib, and they had a recent symptomatic ischemic stroke despite active and ongoing DOAC therapy, which is defined as not interrupted for more than 48 hours as per patient information. We don't measure level of DOAC therapies, that's too complex, it's a pragmatic trial. And of course the patient must qualify for an ongoing long-term DOAC therapy, so they are not, and vitamin K is not allowed. Exclusion criteria, the most important is that of course strokes that are not suggestively of cardioembolic nature are excluded, so strokes due to ipsilateral, intra, extracranial, high-degree stenosis, isolated lacunar strokes, or other well-defined stroke etiologies are excluded, and the other exclusion criteria are listed here. Also patients with poor LV function, contraindications to TE, or severe renal impairment where DOAC therapy would not be indicated. 9 countries are participating, 45 sites, and currently we have enrollment is going very well. We have currently included 75 out of 481 patients, and it is exponentially increasing the enrollment rate as we open new sites. The other trial that is actually looking at the very same question is and the PI is Xavi, is called LAAO. It's actually a very similar idea with a total of 380 patients, also randomly allocating DOAC versus DOAC plus LAO. The follow-up is at 12 months, and the primary endpoint is recurrent ischemic stroke or systemic embolism. And then the final, the elephant in the room, of course, is the LAOS-4 trial, which is an industry-supported international multi-center prospective randomized controlled 2-arm trial where roughly 4,000 patients will be included with patients at high thromboembolic risk. Not necessarily breakthrough stroke patients, but the subgroup of the patients included will, of course, also represent breakthrough stroke patients. They will be randomly allocated to either receiving continued DOAC therapy or percutaneous LAAC with continued DOAC therapy. And as far as I am informed, the protocol also allows just DOAC monotherapy without the addition of antiplatelet therapy immediately after the procedure. And the primary endpoint is, of course, in terms of these, due to this very large sample size, it can be afforded to look at ischemic stroke and systemic embolism only. And the inclusion criteria are AFib patients with a CHA2DS2-VASc score of equal or more than 4, so high risk of stroke, and the patients must have been already on DOAC therapy, and excluded are patients with LAA thrombus. That's a difference to ELAPS, where we allow the procedure to be done. And of course, prior LAA occlusion, prior AST-PFO occlusion, and interestingly, ablation is an exclusion criteria, because, as we learned, this would decrease the stroke risk. And this would be the poll, but we come to that at the end. So in conclusion, excessive ischemic stroke risk is observed in one specific clinical entity, and that is called breakthrough stroke patients, those suffering from an AFib-related stroke despite continued DOAC therapy. It's present in more than 1/3 of all AFib-related stroke patients. The surgical LAA occlusion and continued oral anticoagulation is reducing recurrent stroke, so this dual strategy seems to make sense, and the percutaneous LAA occlusion in that specific indication, breakthrough stroke patient, is feasible and safe with low stroke recurrency risk, according to 2 registries, but RCTs are lacking. LAOS-4 in part tests this hypothesis, and also ELAPS and add LAO. And with that, I thank you for the attention and looking forward to this discussion.
Thank you, Lorenz. Now we have the poll, and after that we will have the discussion, you and Uccio together. Okay, can we have the first poll?
But maybe waiting for the result of the poll, I have already a question to one of the speakers. Do you think there is a pattern of a patient that are at increased risk of breakthrough stroke? For example, patient with a previous bioprosthetic valve, mitral valve, for example, patient with a lot of smoke in the LAA. I mean, there is like a pattern of patients that you think are at higher risk but could benefit more from, or we just, not for your, we cannot really select the patient. Okay, okay. So let's go for the, there's only one answer. So what is your preferred approach for secondary prevention of stroke despite OAC?
Yes, but really the data published show that to switch to another oral anticoagulant is not effective in general. The additional LAAC closure with oral anticoagulant based on the LIVESTREAM, but we are speaking of surgical closure of the LAA. It is not exactly the same thing. Seems to be interesting.
I think there is a...
We are waiting for the LIVESTREAM.
Yeah. I think we can say there is a consensus for this question. Maybe we can move to the next question, maybe? Because we will get all the votes at the end.
But this is a good point for the consensus.
Everything will be
We owe the community think that if a patient no responds to the anticoagulant, probably to add on top the LF atrial appendage closure is an effective solution.
What is nice also is that you close the appendage and you keep the oral anticoagulant therapy. So also it prevents device-related thrombus. It's a nice combination also from a patient perspective. And if one day the patient has to stop for any reason because it starts to bleed or something like that, you still have a protection. So I think
yes, one point I want to address with Uccio and Lorenz is the non-adherence to the treatment for patient in DOAC that could be at the origin of the ischemic event.
Yeah. It's interesting. Only after evaluation, which makes sense, of any other causes, that's very important. And I think that it's going to be the neurologist that will send the patient. In Elaacc, also in Elaacc, it's the neurologist that select the patient and send the patient to the cardiologist. Should be the same for the renal issue. I mean, it should be the nephrologist that send you the patient for this indication.
Yes, because we have to exclude the interaction with other treatment, the suspension of the oral anticoagulant, or that the ischemic events is based on a different origin, for example, peripheral vascular disease.
I will take someone random in the room. So what do you feel? If there is a stroke despite it's your regular approach to close the appendage?
Yes, I think for our practice is that we keep both, so we close the appendage and then we anticoagulate the patient, because I see it like when we give statins and ezetimibe and PSK inhibitors in patients who have high cardiovascular risk. So if there's a increased risk of thrombosis, of course we should tackle both ways. So quit the anticoagulation and close the appendage. Of course, there's a little bit of discussion regarding patients who are also at very high risk of bleeding. In that case, you're going to be probably doing tailored decision-making, keeping that in mind.
I want to ask to the speakers the comment on this point. Lorenz, what do you think on this point?
Well, of course, at the first step is always a clarification of the stroke etiology, because maybe usually not everything is known, and so you need a workup. Is it a lacunar stroke? Is it an atherosclerotic stroke with carotid stenosis? Is it a small vessel? Does the patient have small vessel disease, etc.? And then, of course, such a strategy of sending the patient to the LAAC makes absolutely no sense. But if the origin cannot be determined and it's not a lacunar stroke, so everything speaks for a cardioembolic stroke, I think it's a good option. What we see since we do the ELAPS is that it's not so infrequent that we find patients with thrombus in the LA despite DOAC, and I think these are the patients where the most benefit can be achieved. Of course, the thrombus should be distal or mid-part, distal to the landing zone, and should be an inviting anatomy. But personally, I'm convinced that in these patients, you really can change the risks substantially if you do a good intervention.
Of course, I agree completely with you. The point is we have to discuss with the neurologist and to identify the mechanism of the ischemic stroke. Uccio?
Thank you. I completely agree. So we needed to understand the exact mechanism of the stroke. In many cases, we find a critical carotid stenosis. So we can find anything. Another explanation, we are sure that a true anticoagulant failure is correct to exclude the left atrial appendage. If I find a thrombus, it's so easy. They agree.
I would like to go to the other side and would ask the question, why are you so sure? So if there is thrombus in the LAA because of failure of oral anticoagulation, it might be a really high risk for DRT. So you don't know whether it's good to implant these people. It's technically feasible and it's possible, but you don't know whether they have a per se increased risk. And once you have a device in, you have a DRT and another stroke. So it's really important to study this.
Comment on that? No,
And then
because,
we have other questions.
the closure not only, I think, that the closure not only has, the effect of closing the appendage and maybe, control the thrombus, but also it modify the flow dynamics. So if you have like a very large atrium and a very large appendage, and the flow, like it's going into the LAA and then going out, it, kind of, alters all the dynamics. And by closing, you create a more steady and faster flow. So this can be, I don't know if Jordi is around, but in this, like super big left atriums, you see like big changes in flow dynamics. So it's not only the effect of, like the controlling the thrombus inside the appendage, but also the change in the flow dynamics that the appendage closure generates.
I'm quite sure that is the case, but you doesn't answer the question whether...
Carsten.
I completely understand what you're saying and I agree, but it doesn't tell you whether it's not patient risk per se. And even with these flow dynamics and better flow dynamics, there will be a DRT. So I think, that is really important to study it before to say, I think, because of, you know what I mean? Yeah.
I completely agree with you, but here, the advantage, it's that since, you're going to keep on, with the anticoagulant full dose, the risk of DRT, at the end, it's kind of controlled. So it's not, I would never give, in these patients, SAP, because I think that, as you said, like these patients have like a very high risk. And by giving, like the full anticoagulant, I think that the risk of DRT, it's kind of mitigated.
Just a comment. I follow you, Carsten, because just the fact that we have this discussion is because there is uncertainty. And I think it's a major failure that only 9% say we need to randomize these patients. We need to randomize. We can discuss closure AF and say it's selection bias, whatever. Then do the fucking study. We are proponents of this therapy, but it's those outside this room that needs to refer the patients for intervention. So we need to discuss what study should we do, how should we do it, how should we design it, how do we convince the community outside this room to refer patients to us.
And can I make a comment
Yes,
in this sense? Because, and also, you know, just to Lorenz, because Lorenz said that we were running the Atrial study, and to get pure patients, and not biased patients, because, you know, like the patients are sent to you, you know, just to get the appendage closed. Because for the neurologist, it's like, and they feel that they cannot offer anything else.
Yeah.
So for them, you know, they want, you know, the procedure. And I agree, I completely agree, because there's no evidence and we need the data. But to find and randomize patients, it's very difficult. So that's why, you know, after 1 year, like enrolling with, you know, like a very, you know, low rate, and then we decided to join efforts with, you know, big trials like Elaacc and of course Occlusion AF, just to see, you know, if we can get like maybe 5-6 patients a year, you know, just to add, you know, like this evidence. But I completely agree.
But I get your point, and it's true it takes a long time to do these studies, and patients are not running into our offices. But if we decide that we close the appendages outside studies because we think they're better candidates, we will end up with closure AF results. And then we will sit here in 1 year and we will never do that study showing it actually works. So we have to decide in the interventional community that we do not close appendages on this indication until we have the results. Then we can also push those people sitting in the back to support us.
No, I completely agree, but I'm just telling you, I'm just trying just to transmit that this setting, it's especially difficult. You know, for the expectations of the neurology, the patient, and it's not easy to randomize patients. I agree with you that we need to randomize, but it's not easy.
I think you are both right. You have both rights.
Adele,
when you said
we have time for
just
one
comment.
1 minute.
Just a small comment.
Obviously, I completely agree with randomizing and doing additional studies. But what I don't understand is, why should we, if I play devil's advocate, why should we exclude other causes of stroke if we already include or randomize these patients in LAOS 4, where they just have a CHASQ-FASQ score of 4 and then get LAA closure? If a patient has a recurrent stroke, it doesn't matter. He has a high thromboembolic risk anyway. He would be a candidate for LAOS 4 anyway. So why should we? That's sometimes difficult to find out what the cause of the recurrent stroke is. So why should we evaluate the other causes before? Obviously, you need to treat a carotid stenosis for sure. But if there's no carotid disease, then he's a good candidate for LAA closure.
Yes, I think that the neuroradiologist, the neuroimaging is helpful to understand the mechanism of stroke. Just
Sorry, it's a real question, but I think it's not so simple as that. We have many profiles of frail patients. What do you think about stroke repeated despite adequate anticoagulation with cancer? We don't have to treat them because whenever and whatever we do, they will have other risk to repeat strokes. So this profile of patient, I don't think that it will be benefit for them to be on trials because we will not have real response for these very difficult questions, I think.
I agree with that observation. I strongly disagree with the notion that we should put them in randomized trials. It will be like the ASAP2 trial. Nobody will include their patients. We will not have an answer, and the trial will stop at some point for futility. I appreciate the sentiment, but not every treatment strategy needs a randomized controlled trial. Breakthrough stroke is actually a guideline-supported indication for LAA clipping. Okay, you can say we don't have the data for LAA closure. We don't have the data against it either. It is strongly recommended not to start switching anticoagulation. There is no alternative therapeutic strategy. So I don't think we should do a randomized trial for this.
But it's ongoing. It's ongoing.
It will lead to nothing.
Okay, thanks. We have to go ahead with the last presentation. Okay, now we are going to touch a very important aspect. It's the patient preference. It's cited in the United States guidelines. It's not so highlighted in European. And I invite Fabrizio Ugo for the talk. Thanks, Fabrizio.
This was a poll before? Or no?
There's not the poll before the presentation?
The poll before? Okay.
Or you can give it after. Don't worry.
Oh, no, as you want.
Okay, let's do it after.
As you want. After?
Yes, after.
Okay, now we speak about two topics that cannot involve in a randomized trial, clearly. Is the patient preference not to be involved in the randomized data? We cannot have about that, so we can discuss about that only between us. And sorry for these slides in Italian language, but I can translate for you. This is the first flyer that I created 12 years ago in my hospital, where I summarized the indication, a good indication to put the patient to drive to LAA closure. So the first part is there. We divide different kind of patients. So we have the patient naive, at high risk clearly. On the left, we have an high-risk patient, but naive for oral anticoagulant therapy, with contraindication to anticoagulant therapy, with a patient preference, or too sick, too diseased. As an alternative, LAA closure is an alternative to start with DOAC. They can take DOAC, and LAA closure is an alternative. On the other side, on the right, we have the patient, but they experience a failure of oral anticoagulant therapy with recurrent bleeding or stroke, and we look here the presence of also of another. The second topic is non-compliance, not adherent patients. So I include in my flowchart, in my indication 12 years ago, this kind of patient, the patient preference and non-compliance, not adherent patient. So this is the central controversy that we discuss about these two topics. Should LAA be considered in patients who are ongoing preventable risk, eligible for oral anticoagulant therapy, but unlikely to stay on oral anticoagulant therapy, and we have to select oral anticoagulant versus LAA closure. So just to share my doubt and perplexity with you, if a patient persistently refuses oral anticoagulation therapy after appropriate counseling, this is the most important point, is this patient still adequately treatable medically or effectively untreated? Should informed patient refusal ever open the door of LAA closure discussion, even in the absence of a formal bleeding contraindication? Where should we draw the line between shared decision-making and inappropriate expansion of device therapy? Because in fact, the patient preference is represented by an heterogeneous group of patients who can take oral anticoagulation therapy, but who choose not to take it. So we have data about this topic. I think that we can use this trial to extrapolate the data, because in PROTECT AF, this is the result after 4 years of follow-up. We know very well the data about that. But in fact, in this trial, is randomized to oral anticoagulant therapy or LAA closure. So is the patient that we can choose the oral anticoagulant or LAA closure. We have more recent data provided by Champions AF trial, 3 years. You know very well this data, but I remember to you that this is a trial, this is a randomized trial. We follow the patient also in the arm of our oral anticoagulant therapy very close. 1 month visit. So in the arm of oral anticoagulant therapy, the address is 90%. In real life, if 50% at 3 years. This is the difference between randomized trial or registries. But in fact, we have this trial that published Roberto Galea the last year that involves, this is a registry clearly, it's not a randomized trial, but involved the patient that refusing oral anticoagulation therapy. This is the flowchart, so we have a small group of patients that refuse oral anticoagulant therapy. In the other arm that we compare, we have the medical indication of LAA closure. This is a classic European indication to LAA closure. So this is the picture, the photo of the phenotype of two groups. Clearly, we have two uncomparable groups with high heterogeneity between refusal group and control group that follow the medical indication, classic indication. Younger patient is more represented in the refusal group. Clearly, the young patient don't want to take oral anticoagulant therapy long life. Completely different is the control group. Most diseased patient, look here, most hypertensive, diabetes, chronic kidney disease, expressed by CHA2DS and summarized by CHA2DS score. Look here, we have CHA2DS score is more similar to Champions AF patient for the refusal group and is higher in the control group, like to close AF trial. And look here, also regarding the bleeding, we have a low risk of bleeding in the refusal group and high risk of bleeding, or people that experience a previous bleeding is a classic indication to control group. It's not surprised that and I will be provocative, the patient preference is better, the doctor indication, no. Clearly, is not, they are not comparable to group, very heterogeneity, but by the way, I would like to show that we don't have high events in the patient preference, despite we have high events in classic indication. This is a Champions AF patient, this is a closure AF patient. We can compare that. The second topic is adherence. Okay, no, we understand very well this problem. In randomized trial, we have 90% of adherence patients in the group of our anticoagulant therapy arm, but in real world, 50% at 3 years. And this impact clearly is a time dependent to interruption of oral anticoagulant therapy. More than 6 months, we have more events with increasing the CHA2DS score, clearly. And the reason, the most important reason of not adherence of our anticoagulant therapy is provided by the fear of severe bleeding, or also different patients that had previous bleeding or fracture that don't want to take lifelong therapy, and other reason as too much cost or different piece. They take a lot of drugs in his life, they don't want to take another anticoagulant. So I can imagine the patient preference and the non-compliant as 2 big quadrants with a great heterogeneity inside of people. So in patient preference should not be reduced to a convenience of patient alone. In clinical practice, patient preference may reflect different conditions as a fear of bleeding, prior traumatic bleeding experience, anxiety for long-term anticoagulation, poor trust in chronic medication and refusal after counseling, and lifestyle incompatibility. For example, I'm a sport cardiologist, and I follow the master athletes. Sergio, you are a real high-level biker, so I treat 2 bikers, patients, sportive athletes of 70 years, they're competitive, after fall down and femoral bone fracture. They don't want to refuse a category to take another time our anticoagulant therapy. This, for me, is a good indication, and I close 2 patients of sportive athletes, master athletes, clearly. For factors that impact of non-adherence, we have different conditions regarding the patient, the knowledge of the disease, the fear, for example, to take. We have an overlap between non-adherence and preference. Look here, the fear of bleeding, the fear to take a medication, the condition of the patient, asymptomatic patient. The patient is not acknowledged the real weight to importance to take anticoagulant therapy long life to cure his condition. Also healthcare systems and also social economic factor impact of non-adherence. So it's important to understand and to individualize the barriers to medication adherence and to overcome that. So if we want to fill these two cadres, we have different aspects, but they can they are comparable, I think, and they are matched between two different topics. And finally, there's a common final path characterized by the two groups may remain at risk and high stroke and embolism problem. So my take-home message are the patient preference and non-adherence patient should not be treated as automatic standalone indication with LAA closure. However, in carefully selected patient, I think LAA closure may be a good indication as a shared decision-making, a multidisciplinary framework. This interpretation is consistent with current guideline logic, even if it goes beyond the narrowest traditional indication boundaries. Thank you.
Thank you, Fabrizio. Now, can we start with the first poll? Yes, Fabrizio, I agree completely. The point is that the consideration is if the patient preference and how the patient preference should impact on medical decision, because it's a very critical aspect. It's a social, it's a philosophical, etc. Because the patient doesn't have all the elements for the decision, because it's a perception of dangerous therapy or discomfort therapy or the risk of a procedure, but it doesn't have all the elements or even though I think that to involve the patient in the decision is correct. Okay, can we start?
Yeah. Please.
Can I add
sure.
comment? No, regarding this group of patients and what the patient wants, I think that if the trials go well, it could be a good option. But we have an important issue here because we are in the catalyst, and the appendages that we found in the catalyst trial patients are super difficult to treat because they are healthier patients with more contractile appendages and more lobes and more trabecula. And these are appendages that need to be treated for interventionists that are very experienced, because in the trials that we will see the results, the interventions were performed in centers with a lot of experience. So what will be the problem if the trials go well and everybody starts doing this kind of appendages, and they are very difficult ones, and this is something that needs to be super safe because it's healthy patients that have another option. So this is something that also needs to be addressed because it could be a problem for the therapy.
You mean that those populations sometimes have higher risk because they are very contractile appendage, and then if you don't give them the drug...
No, that it's difficult to close this appendage.
Okay.
So if maybe the intervention is not so skilled, it could be difficult. Maybe we have embolizations, maybe we have perforation, and it's very, very risky depending on the hands. If everybody starts closing appendage and healthy appendage, maybe the people will start thinking that it's very risky, and maybe the therapy just goes down. So this is something just to keep in mind also.
Okay, do you have, Adele, do you have, yes, Claudio.
Yes, can I make a provocative comment? Maybe too much naive, but really, truly, I don't have, many patients who are not, adherents to the therapy. maybe just, the patient who, suffer from paroxysmal atrial fibrillation, they want to have a catheter ablation because of discontinuation of anticoagulation. Really, truly, just the majority of patients follow, in our institution, really probably 85–90% are on anticoagulation without, any doubt. So I don't know, where this, data come from. If you look at the randomized clinical trials, there are patients who, not really adhering to the anticoagulation. So I doubt that we have so many patients who really, not, on anticoagulation all the time, and they drop maybe after 1 year, 2 years. That's not my experience.
Can I also join in this comment? So it depends also, as a doctor, what you're telling to your patient. So their choice will be mostly influenced by what you're going to tell to him. So of course, I think this we should keep in mind. So exactly, I have the same experience as you. So a lot of patients will take their pills actually.
There's a difference between refusal and non-adherence. This is something, there is an overlap, but I remember one patient that I put in the registry, this was a butcher. So he was cutting meat every day, and so he said, I cannot live with that. So sometimes, really, there's a fear about taking long-term. And it was, like you said, a low-risk patient, so close the appendage, and it was a difficult one. I remember it was super difficult.
Domenico.
So, disclosure, I'm an electrophysiologist. So I would
can you speak to the microphone?
I would have liked to see a third option, that is refer the patient to catheter ablation. So I think those are like 60 to 70% of these patients are kind of alone AF or ocean patients. So I think, and what we can do in these patients is probably in 60% of them, we can just manage with ablation, and also we take care of progression from paroxysmal to persistent, and stop anticoagulation safely, and eventually in the intermediate patients consider concomitant procedures. But I think at this point, these patients should be referred to catheter ablation, especially if they don't want to take anticoagulation.
But this is a special population of patients. The point is, if tomorrow is Saturday, next week, in your hospital, one patient with indication for the oral anticoagulant, he say you, okay, I don't want to take the anticoagulant because I am afraid of for the risk of bleedings because I am an active sportsman and so on. What do you do?
So first of all, I consider ablation, and then based on the risk of the patient, I will go for ablation alone, and then after 2 months stop completely anticoagulation. Or if you are talking about like a 3 or more Ochaz-Vasc, consider eventually concomitant procedure.
Yes, but in the real world, no one of us interrupt oral anticoagulation.
I disagree with that.
But it depends.
In a patient 1-2 Ochaz-Vasc,
clearly.
after ablation,
No, the patient.
That's why I'm saying that if we start considering ablation as part of the pathway to treat these patients, because if I see like the study of Roberto, so I see patients that have low risk, but at the same time, those are patients who are going to progress to persistent AFib if we don't take care of the arrhythmia. And so even the stroke risk is going to increase over time. And so maybe at this point we can occlude the appendage, but then these patients are going to have other comorbidities and other things, and it's going to be hard also to manage in the future. So I think as first line, starting with ablation and eventually consider concomitant.
That's a very good point. Yeah, thank you.
Can I have a comment? I'm really surprised to see 72% of us think this way, because where I feel it, I think it's important what we tell the patient, because if we agree as this is the consensus, this opens up to a large way of thinking, providing unnecessary LAs to the patients, and also in like UK National Health System, we are not able to do this. So even though there are a lot of caveats to it, but the way it is framed, I don't think this should be the consensus of the, because we have to adhere to guidelines. Guidelines are based on randomized trials and a lot of evidence. And if you try to personalize this, I think it is a big danger, in my opinion.
So we keep it aside that it's not a consensus about this indication. Do the audience agree about that? That a patient refusal first, we need to convince the patient that it's good, or we have to send him to ablation and to cure the AF or as much as possible. Do you agree with that, or so we change a little bit the consensus here?
Yeah, or you can, Adele, you can either ask, you know, I will close the appendage if the patient is not going to take. Because, I mean, if you know that the patient is not going to take the anticoagulant, okay, you need to advise the patient to take the anticoagulant.
Okay.
But would you prefer nothing or just closing the appendage?
Yeah.
I mean, just to pose this question again, it's provocative, no? Because
no,
you have to, but between one or the other, that's the situation. Or nothing, or... And you cannot randomize those patients.
So after extensive information to the patient and still refuse something like that, okay. But the point about ablation was a very good point, I think. First, if it's a low risk that you can cure the AF, I think you should go for that first. And then we have now 2 trials showing that the risk of stroke is extremely low, so probably you don't need to close the appendage. Yeah, it's a very good point.
Yeah, 2 comments. I probably see a different patient that electrophysiologists see, because my patients are not so adherent to oral anticoagulants. It's point 1. And according to guidelines completely do not accept that there are patients who are not adherent to the therapy. Guidelines are saying that you have to push and push and push your patient to oral anticoagulants, but according to many registry studies and so on, there are 30 to 50% of patients who do not accept that, are not adherent to that therapy. And the problem is what to do with these patients. We can close the eyes and say, yeah, you should take oral anticoagulants, but these patients do not want and want next.
Yes, but in the real world, we know that more or less 30% of patients are without anticoagulant because they are not adherent. Okay, we have to move to the last because we are... no, we can jump the last, close the session.
Yeah, okay.
So, okay, thanks.
So it's time to...
It's time to move to the last session. Thanks so much for the speakers and the audience for the interaction. And I invite Ignacio and Lorenz.
So let's begin the last session. It's my pleasure to chair this session with Loren. And in this session, we will talk about, again, the LAAC registry. Yeah, the LAAC score. So we come back to the origin. I mean, in the first meeting, we talked about this, and now let's see what we have done and what we are going to do. So, Adele.
So I think it's going to be a nice session because we will talk about the score, but also how to go towards a clinical validation of this score. I think it's very important. So these are my disclosures. So just to the people that are not still aware about this classification, so you know that the LAAC remains challenging. It's a challenging procedure due to the extreme variability of the anatomies of the left atrial appendage. And that necessitates some kind of accurate classification to guide the implanter for an optimal procedure planning. And so the classical, well-known anatomical classification, like cactus, cauliflower, chicken wing, windsock, actually just provides a visual understanding of the morphology, but we thought that it lacks specificity in predicting procedural complexity and potential complications like pre-device leak, device-related thrombus, embolization, and so forth. And so there was a clinical gap, and there was a need for a novel and more pragmatic classification for the implanter, which would integrate essential anatomical and functional details that can influence the choice of the device, planning of the procedure, and the management of the risk. So you look at this appendage, for example. Okay, is it complex or is it not complex? And look at those appendages. So definitely on the right of the screen, you see extremely more complex appendages as compared to the left side of the slide. And that's okay. You just say, okay, visually it's more complex, but you don't have like some anatomical parameters to quantify the complexity. And so we published this classification, and this was done by the Elaacc board with 11 experts from 9 European centers. We developed this classification based on a structured consensus and voting. And remember, this was presented, all the parameters were presented during the first Elaacc meeting. So we wanted also this system to be comprehensive, easily integrable into daily practice, and useful for distinguishing between standard and more complex cases. So a criterion was included in the classification only if more than 50% of the board members voted yes, ensuring some kind of true consensus. Although now we say that it's 2/3, but at that time it was 50%. And the final classification integrates 5 key anatomical and functional parameters. I will very quickly redefine those parameters. So the entrance, the landing zone, the anatomy, the axis, the contraction, yielding at the end 12 binary criteria, yes or no, that categorize LA anatomies. So one important step also, because it was to define some clear anatomical landmarks. So we have given a clear definition of what was the LA ostium, and the plane where the appendage opens into the left atrium. So we define it as a virtual line connecting the inferior LA margin, just proximal to the circ, and above the mitral valve, of course, and to the super LA margin, with the ostium plane being perpendicular to the central axis of the neck. And on the 3D MPR view, it can include or not the Coumadin ridge. So, I mean, if you come back, it can include or not the Coumadin ridge. And based from this anatomical ostium that you need to define first, you can have the working depth, the Coumadin ridge distance, and the presence or not of an early sharp bend, as I will show here. So the entrance, the definition was a LA ostium diameter of more than 35 millimeter, and every time we tried to figure out what will be the potential challenges. For example, here it was challenging in terms of device sizing and also increasing the risk of peri-device leak. And then there was the fact to have a long pulmonary vein ridge, which was defined as a ridge extending more than 10 millimeter from the anatomical ostium, and that could, as a consequence, have an unclear, not well-defined ostium, and also increasing the risk of device-related thrombus, which has been shown in the CHAVI registry. Also, the fact to have a low position of the ostium, a low takeoff, which was defined as an inferior LA margin within 5 millimeter from the mitral valve annulus, and this we thought that this could create some issues with catheter alignment and mitral valve interference. And then there was a landing zone. There was like 3 parameters. The first, no, 4 parameters, sorry. There was the large dimension of the landing zone, so more than 30 millimeter, the same difficulty with device sizing and risk of peri-device leak, extremely eccentric landing zone, and also we give here a cutoff when you have the ratio between the maximum diameter and the minimum diameter of more than 1.5. And this creates some difficulty for device sizing, conformability of the device, and also peri-device leak. The fact to have a proximal lobe that could lead to an uncovered proximal lobe, challenging for a single component device. And also the fact to have a protuberance or any kind of proximal bifurcation, also with a clear definition. And also this can lead to improper device engagement, stability issues, and so forth. Then the anatomy, so the fact to have an early sharp bend, which was defined as a bend within 10 millimeter from the ostium with a very acute angle. So this can create difficulty for implanting the device on axis. There was also the definition of a short working depth, which can also have impact on device stability and the risk of embolization. And finally, the funnel shape, which also we have given a clear definition, like a LA ostium to landing zone diameter tapering of more than 30%. The axis, so pronounced anterior or posterior deviations, which could also give issues with device and catheter manipulation. And the final one was the contraction, so having a very hypercontractile LAA, which was characterized by diameter changes greater than 50% during the cardiac cycle. This was supposed to be associated with the highest risk, the higher risk of erosion and device embolization. So we ended up with 12 characteristics, 1 point for each. And we just proposed a color-coded system when we say that the challenging case will be like the combination of at least 3 of those parameters. When you have nothing, it's a simple case, and when you have 1 or 2 parameters, it's going to be a moderate case. But this was not validated, of course, at that time. We did a very small epidemiology of those parameters, and you can see that the distribution, at least 1/5 of this population had a challenging score, like more than 3, moderate 42%, and simple 1/3 of the patients. Just give very quickly some examples. A case, for example, with the proximal lobe, when we decided to implant the Watchman. In this case, despite repositioning of the device, you can see that the proximal lobe was not covered by this specific device here. In another case, you can see combining many of those parameters, so short depth. You can see that also a long comedian ridge. You can see that the ostium is extremely large, it's very eccentric, and so you end up with a very high score here. And when you look at the simulated simulation by Philips, you can see that really it's very difficult to place this device into this case. So you can really anticipate the complexity of this specific anatomy upfront using those parameters. But the Elaacc score is based on expert consensus, so a structure that inherently is subjective. So we need a prospective clinical validation, which is currently lacking, but Lorenz will give some insight. So the K unanswered questions, does a higher Elaacc score independently predict complexity? Does the score predict specific complication, like PDL, DRT, embolization? Is the score reproducible across operator and centers? Do some of the parameters carry equal weight, or should they be weighted differently? Does the score perform differently depending on the device used? These are a lot of questions that we still need to answer. And though we need a large-scale, multi-center prospective data to address this problem. Also, just a glimpse into the talk of Lorenz, what will be the primary endpoint? Is it going to be like the procedural complexity? Could it be procedure duration, number of catheter exchanges, number of device recapture, so the procedure efficiency or the need for a rescue strategy? Or do we go for like secondary endpoint or not? Or what kind of secondary endpoint also we can try to anticipate with this classification? For example, the risk of acute complications, pericardial effusion, tamponade, embolization. Should we go for mid, long-term outcomes? And also imaging endpoints. So we need to also have a clear concordance between TE and CT, and to address the inter and intra-observer reproducibility. So we need this multi-center registry. I think the Elaacc registry will be the ideal platform. And what will be the target population to validate? We don't know actually. So is it like more than 1,000 patients? How many centers? To have enough power to detect the association between the Elaacc scores and the complexity. So the Elaacc score provides a structured 12 criteria implanter classification to address the LA anatomy complexity based on an expert consensus. The prospective clinical validation is needed, and so a future multi-center Elaacc registry is the natural step to validate this score. Thank you very much.
Thank you very much, Adel. We continue with a first attempt towards the validation of the Elaacc score, and Victor Eskilsson from Aarhus will present on the reproducibility of the Elaacc score. Thank you, Victor.
Thank you very much for the presentation, and thank you to the Elaacc committee and to Jens Erik for inviting me to give this talk. And could we have the slides on? Perfect, thank you. And in this first talk, I would like to focus on the reproducibility of the classification. And our efforts in this field has led to the production of a study that we hope to see published in the near future on the reproducibility of the Elaacc anatomical classification in the field of procedural computed tomography. And this study was conducted in parallel to the clinical validation work that we will see presented later in this session. And the design of our study builds on the original work by the Elaacc group that we just heard presented by Adele. And the work was, of course, centered around defining an implanter-based anatomical classification. And as we see highlighted here in the central illustration from the original paper, we see the 12 binary characteristics and the color grading for the Elaacc score. And our study was conducted as a dual-center cohort study based around independent imaging analysis by 2 blinded raters of 800 consecutive pre-procedural CT images. And patients were, first of all, the sample size of 800 was based around a power calculation performed for subsequent clinical validation, but patients were included in a one-to-one fashion by the Inselspital in Bern, Switzerland, and Aarhus University Hospital of Denmark. And we saw included patients with a comparable distribution of age and sex, and an average CHA2DS2-VASc score prior to procedure averaging around 4, with the Swiss patients having higher rates of congestive heart failure and also vascular disease prior to procedure. Our main endpoints were inter-rater agreement and reliability, which we evaluated for all parameters of the Elaacc score, and also for the combined score, and for all underlying continuous anatomical measurements where applicable. So, in this table, we see the distribution of the Elaacc parameters in the population based around the mean measurements from the raters. And the first thing we see in the distribution column is a great disparity in the distribution of the individual parameters. Some parameters, including the long Coumadin range and a short working depth, are prevalent in more than 50% of included patients, while others, such as the low ostium, indicating the short distance from the low takeoff of the ostium to the mitral valve annulus, being very rare. And our analysis for agreement was centered around absolute agreement, as we see in the agreement column, with expected chance agreement in brackets, and then around a Cohen's kappa analysis, which is a statistical estimate of agreement taking chance agreement into account, where a score of 0 amounts to no agreement outside of what could be expected by chance. And our reliability analysis was based around Kendall's tau, which is an estimate, a non-parametric estimate that tells us if raters are likely to move in the same direction when giving scores and making measurements. And highlighted here, we see the 3 best performing parameters being large ostium, large landing zone, and proximal septa, while a parameter such as the low ostium, which was exceedingly rare, performed not so well. We saw only a slight to moderate agreement, but that was likely also based around chance agreement being up to 90% due to rarity. And one of the main findings of the study is that some of the key parameters in pre-procedural planning are highly reproducible, and this was especially true for all the landing zone and ostium measurements, so the area, perimeters, and maximum and minimum diameters. And this also held true for transseptal puncture angles and our measurements pertaining to the LAA axis. And in these continuous variables, we measured our reproducibility, first of all by agreement, as we see here in our blind Altman plots with limits of agreement in red. We see very few outliers outside of the limits, and we see no tendency towards systematic bias, except for a slight proportionality bias in the area measurements, where we see raters tending to disagree more in very large measurements. And for the reproducibility of the combined score, first of all, we performed an unweighted analysis where we see only a moderate or slight agreement based on the kappa analysis. But in this analysis, a disagreement of 1 point is given the same weight as a disagreement of 5 points. So we performed a linear weighting scheme in which the ordinality of the score was taken into account. And here we see a very, very high absolute agreement between the raters and a moderate kappa analysis, which was also likely driven by the rarity of very extreme cases of 5, 6, 7 points given. This also held true when we applied the color coding that we saw in the central illustration for the original paper, where we also see a moderate agreement for the stratification into simple, moderate, and complex anatomies. Finally, as a sensitivity analysis, we wanted to do a stratification of the Elaacc scoring by both raters and by inclusion site, in which we saw no significant change in the distribution. So, to summarize on the present study, we find moderate to substantial reproducibility for most individual anatomical measurements of the LAA. We find a combined Elaacc score with a moderate reproducibility by the kappa statistic, but high levels of absolute agreement in the linear weighted analysis. And we find that certain critical parameters, which are so important in device sizing, strategic planning in the pre-procedural stage, show substantial reproducibility, including all measurements at the ostium and the landing zone. So how does this work contribute to future efforts in the field? We find that CT measurements in general provide good reproducible anatomical characterization of the left atrial appendage, and we hope that the efforts of this study may be able to build upon the growing framework for future efforts in the prediction of challenging cases and for subsequent clinical outcomes. And as the purpose of this study was centered around CT measurements, we have not done an analysis as to how our CT measurements correlate with TOE, and this is an obvious next step, and TOE also faces other aspects, such as interoperator reproducibility, which would need to be addressed in coming studies. But with the great role of TOE in many centers in the field, efforts to extend the validation study to this modality are important next steps. Good. So, before letting the next presenter come to the stage, I would like to thank you all for your attention.
Thank you, Victor. So we will have the discussion at the end, and now Lorenz is going to present the clinical validation of this score and the path to the Elaacc score version 2.
Thank you very much. So our idea was then, after the reproducibility assessment, also to see whether or how useful the score might be to predict some endpoints. And of course I have to acknowledge the people listed here and the Elaacc board members, and I must admit that the analysis took quite some time. We had a year, and we really just finalized the first results a week ago, so there was no, let's say, a possibility for everyone to look at it in depth. So this is the very first time we probably can discuss it. So the background is that, of course, what we want to achieve is a really complete LA sealing, and we discussed that this is today, despite all the best techniques, not always possible, as we know, and what we want to avoid is device embolization, because it's associated with a 10% mortality periprocedurally. We want clearly to avoid peri-device leaks, because there is a continuous risk increase the larger the leak is, and there is also some data suggesting that the device implantation leads to a higher DRT risk. And as you know, the Elaacc score is really aimed to anticipate, based on LA anatomical and functional characteristics, the risk, PDLs, DRT, and device embolization. And we do have this gap in knowledge that was not yet clinically validated, and therefore the aims of the study was to evaluate the clinical performance of the Elaacc score, and second to derive and potentially internally validate alternative CCTA-based prediction in case that the predictive ability of the Elaacc score that is based on a binary approach, we just had expert-based single cutoffs, but not a continuous approach, and we thought that we might aim to improve the Elaacc score in case we would not find it sufficiently predictive. So about the design, it was already said. We discussed and agreed upon during the Elaacc meeting in Munich which design would we or should we choose. This we decided mainly for practical reason to do it in a two-center approach, because as you can understand, the availability of CT in a large proportion is not that easy, together with, of course, the availability of the clinical characteristics and outcomes. And you need serial imaging methods of the same nature, in that case CT, so not only pre-procedure but also at the imaging follow-up time point. And we therefore included Bern and Aarhus. And each center provided data of the last 400 consecutive patients that received CT to plan and then to follow up the result. And this was between September 19 and December 24. As said, from both sides we included 400 patients, makes a total of 800 patient cohort that had a serial CT, and we assessed the pre-procedural CTAs and the follow-up CTAs, and assessed the clinical and imaging outcomes in a prospective fashion. Now, this is something, of course, we can discuss, but we have pre-specified the primary and the secondary endpoint for which the Elaacc score could be predictive, and as a primary endpoint we have chosen aborted procedure, death within 7 days, device embolization within 7 days, residual PDL, actually any PDL. We did not take a cutoff because there is evidence that there is a graded risk increase independent of that starts actually at 0, and this between 1 and 6 months imaging follow-up and deep device implantation. And we also had a secondary endpoint that did not consider deep device implantation, so aborted procedure, death, device embolization, and residual peri-device leak at 6 months. So these were the two endpoints for which we tried to make a validation. And the statistical methods were as follows. We anticipated an event rate for the primary endpoint of 40% and expected area under the curve of 0.7, and by the inclusion of 11 candidate predictors as per the Elaacc score, we would need 786 patients, and this is why we have chosen 800 patients. And in terms of statistical analysis that was performed, we evaluated the Elaacc score in terms of discriminations, or area under curve, and ROC analysis, and calibration slope. And then as a next step, so this first step is based on the binary Elaacc score approach, but then as a second step, we also used non-scoring parameters expressed as numerical variables to build an alternative prediction model by means of a full multivariable logistic regression model using the lasso method. Now, these are the results. You see here the overall column, Aarhus and Bern. As already said, I mean, this is representative of the activity at the two sites. You see the average age the average age is not 80 but 74. 30% females. The average CHA2DS2-VASc is 4, Haspel score 3. Major bleeding is present in 50%. Some differences between sites, interestingly enough. And the amulet versus watchman distribution is also site depending, 30% amulet and 65% watchman. LAAC thrombus was present in 3.5%, and echo guidance was used in 100%. And there are general anesthesia in 10% with differences between sites, and sinus rhythm was present in 56%. As this was a CT-based analysis, the contractility could not be assessed. Now, regarding the primary and secondary endpoint, it occurred overall in 62% in both populations, the Aarhus and Bern, and the secondary endpoint occurred in 30%, and below you see the individual listing of the contributors to the end point. Now, if we look at the binary Elaacc score, whether the variables that contribute to the Elaacc score, you see them listed here, present or absent, and you see that there was that actually contributed, of course, to the primary endpoint. So if they contributed to the primary endpoint, and there was a significant difference, this was true for large ostium diameter, which was defined in the Elaacc score of more than 35 millimeter, and a long pulmonary vein ridge length more than 10 millimeter, and a proximal lobe. So these were the Elaacc, the binary Elaacc score parameters that were significantly more frequent in patients that suffered from the primary endpoint. And here you see the distribution of the primary endpoint as a function of the Elaacc score, and what you note is, of course, that there is not an increase, but actually that there's actually a decrease the higher the score gets, which already tells you that the predictive ability is obviously limited. And if we then do the same for the secondary endpoint, we see that there are also significant differences. The large LA ostium, again binary, was significantly different in patients meeting the secondary endpoint versus not meeting the secondary endpoint. Large landing zone was significantly different, early sharp bend, and funnel shape. Tapering more than 30% was also significantly different. And if we look at the distribution of the frequency of the secondary endpoint according to the Elaacc score, again you see that it increases, but then again decreases the higher the Elaacc score gets, again speaking for a limited predictive ability. Then we set out to develop a new Elaacc, or let's say a modified Elaacc score, taking into consideration all the Elaacc score criteria, but expressed in a continuous fashion, no longer binary, but really in a continuous fashion. And the criteria that we used are the same, are listed here: LA narrowing, LA tapering, landing zone eccentricity, working depth, pulmonary vein ridge length, mitral wall distance, and then finally also the fossa ovalis versus LA posterior and anterior angle as illustrated here. So these were the variables that we took into consideration in a continuous fashion. And the results were as follows. So regarding the primary endpoint, we were able to find independent predictors for that. First, LA ostium mean diameter was associated with a 1.75 increased risk increase for the primary endpoint, and pulmonary vein ridge length was also significantly increased, mitral valve to LA distance as well, proximal LAO lobe as well, but inversely. Remember that we had the implant death as a part of the primary endpoint, and of course if you have a proximal lobe you try to place the device much more proximal. This is why the odds ratio is below 1. Then LAA tapering, LAA narrowing, and the fossa ovalis and LAA posterior angle was also predictive. So if we use this model now, you see the frequency of the primary endpoint according to the quintiles of the predicted probability, and you see that here we have now a pattern that we wish to observe, namely it is increasing the higher the score gets based on the continuous variables. And if we look what the impact is on the area under the curve, orange line indicates the binary Elaacc score and the blue line indicates the Elaacc score that is based on continuous variables, and we have area under the curve of 0.65, which is moderate in terms of predictive ability for this primary endpoint. And we also did the same exercise for the secondary endpoint that does not take into consideration the implant depth. And for that one, the following 4 variables were independently associated or were independent significant predictors of the secondary endpoint: LA ostium mean diameter, landing zone eccentricity, and the angle between fossa ovalis, the mean angle, and the anterior LAA angle. And again, if we look over the quintiles, we see that there is an increase with each increase in the continuous Elaacc score 2. That's what we would like to see. And here you see the impact of the predictive ability in terms of area under the curve. It is now 0.64, and this is again a significant improvement as compared to the binary Elaacc score. So if we want to summarize for the primary endpoint, including death, device embolization, anti-PDL, and deep device implantation, we identified significant predictors of that endpoint, namely the LA ostium mean diameter, the pulmonary vein ridge length, the mitral valve LA distance, the proximal LA lobe, and LA tapering and LA narrowing. For the secondary endpoint that is not taking into consideration the implant depth, the following parameters emerged: LA ostium mean diameter and the fossa ovalis LA mean angle and fossa ovalis LA anterior angle. So the study limitations are that, of course, you can debate the selection of the endpoints, mainly implant depth, because as you have seen, the endpoint occurred in 60%, and that, of course, you can debate. LA contractility was not assessed, as this is not possible by CT. The study was conducted at high volume sites with low event rates, and there's a lack of external validation. But in conclusion, the original Elaacc score based on categorical variables shows a limited discriminative performance in terms of predicting the primary and secondary endpoints that we have pre-specified last year. The prediction models incorporating the individual Elaacc score criteria as continuous variables significantly improved the prediction of procedural outcomes, but despite the improvement, the model discrimination remains moderate, suggesting that we still have room to improve it. I like also to make a comment. So despite the limited predictive performance for the investigated outcomes, the primary aim of the Elaacc score, of course, was, and I cite here what we wrote in the paper, should be a user-friendly and effective in distinguishing between complex and standard LA anatomies, facilitating a common language among implanters and imagers, and this, of course, still is fulfilled. Thank you for your attention.
Thank you, Lorenz, and an amazing presentation and amazing work. And now we begin the discussion. I think that Jans want to say something, and I invite Adele to lead the discussion.
No, thank you, Lorenz. I especially like the last sentence because the primary aim with the Elaacc score was really to create a common language because we talked about those 4 categories of chicken wings, etc., and we needed something much better. So that was one of the main purposes. The second purpose was to really try to predict a complex and challenging procedure. And therefore, I maybe think we have been too ambitious in choosing the endpoints here in this analysis, because it really comes down to whether 12 different parameters can predict PDL. And I think that's a very, very difficult task. And I think the parameters that finally comes out related to ostial diameter and eccentricity means a lot of sense in relation to PDL. But what I also would like very much to see is what is procedure time, what is number of devices used, what is number of recaptures, etc. Some parameters that can really enlighten us whether the implanter was struggling or not. And I'm not completely updated whether you did all that stuff as well, but and then again, it's a little bit problematic that we are 2 high volume centers that tries to evaluate the score regarding procedural complexity. And also, there's this built-in paradox that if you really spend time on your CT scan and understand the anatomy and your Elaacc score, then you have spent the time on your pre-planning in order to achieve a good result without complications. So it's not that easy to validate this score, but I think we have been too ambitious with going directly to PDL and have the ambition to try to see if 12 binary parameters could predict those PDL. And also, what really could be interesting was also if we could get a signal on DRT, for instance. And I mean, the PV-rich length is also a little bit controversial. We set the limit here for T, 10 millimeters, but you know, many anatomies you can simply not, for instance, place an amulet disc all the way up to the pulmonary ridge. So I think there's a lot of limitations, but I would really much like to hear your comments on fluoro time, procedural time, a number of devices, number of recaptures, etc. Yeah, please.
So I could not agree more with your comments, of course, but we had to start at a certain level, and as you have seen in the presentation of Adel, PDL was mentioned as main consideration everywhere, so not validating PDL really would not have made much sense. Regarding all the parameters that are an indication of complexity of the procedure, that is captured. That's the good news, but we still need to look at it. We were quite stressed to make it for this meeting, so we had not yet time, but of course I agree with all the points, and we should not forget what the initial aim was for the Elaacc score. But I think it's already, to me, it was not so much surprising that we're unable with a binary anatomical score to predict much, but I was surprised that it is possible when you use continuous variables based just on anatomy. That was quite a positive surprise to me. And I think if we would then go the further step and even combine it with a patient profile, I think can be a nice outcome. at the very end.
Yeah, there are several questions in the audience. Lisbeth.
So, yeah, thank you. It's very, very interesting. I think I was already a big fan of the first Elaacc classification because indeed it really gave us a definition. But there was one thing that I was missing, and that's something you address now and sometimes it's better to see it on TOE, which is the spatial position of the ostium of this left atrial appendage. Is it more inferior or superior? Is it more anterior or posterior? And that in combination with the position of your fossa. But I didn't really understand now, was it like a significant predictor or not?
Yes.
This spatial relationship, yes.
Yes, it was. It emerged for both endpoints as an independent predictor, indeed.
Yeah, that's very interesting because specifically it's easier to see on TOE, so it would be good to combine both information points.
Another two questions, so Jordi.
There is a microphone, the gentleman here from UK.
So
you have a micro.
To be honest, it's a topic that I think that we can discuss for hours. But I want just to point out that actually we did a study that actually the paper is already accepted at our intervention, but it has to be out very soon. That we do like a similar study with similar variables. Some of them are here are part of the Elaacc score. And I want to point out two things. One, I think that even CT has, or you cannot assess contractility, you can assess it with the atrial fibrillation or typed atrial fibrillation. So it's a problem that we had. We had the type of atrial fibrillation to assess contractility, and the ROC curve improved a lot. So we obtained a 0.8 almost of ROC curve to, try to predict this kind of DRT. And the other thing is, for me, it's a mistake to assess pulmonary ridge length alone, because it's actually very related with contractility. Actually, last year in the Elaacc, it was a presentation showing a Watchman case. They had like a very deep Watchman, but they have like a very, very high contractility. So then what this supposes is that the washing in that area was like very, very nice. So what I want to say or to explain is that you can have like a very deep position and a deep or a high pulmonary ridge length, and this patient will not develop DRT. So I think that there are two concepts that actually are quite linked.
Yeah, but Jordi, at the end, you need to standardize. I mean, in the same patient, what it's better, just to have it, same AF patient, what it's better, just to have it deep or not deep.
So in the ideal, we have ponderized it.
Not deep, I mean that maybe the sinus rhythm and the high velocities may mitigate.
Exactly. So I think here, and I agree with Jens-Erik, this is two envisions and you have to go in step by step. But the other thing is that you cannot give the same weight in every, variable.
But it depends. This Elaacc score, it's just made under the definition of optimal, implantation. Optimal means not too deep to prevent DRT and without leaks, and of course without embolizations. So every single parameter, for example, tapering means risk of embolization, but doesn't mean the risk of DRT. The risk of the ridge, it's just made for it's kind of risking you just to put it, not too proximal.
I fully agree with you, but then you always will have part of your study or a huge part of patients that will not fulfill, your score. Do you know what I mean?
The score is fulfilled. Sorry.
We need to move. There's one question. He was since the very beginning.
Yeah, I think, can I congratulate first for developing this score? I think it's very useful. First question for the developing team is, when you put the first Elaacc score, did you consider the characteristic of the septum? Because the coaxiality is very important. Even if with the Elaacc score of 0, if you have a thick septum, smaller septum, or previous device, you won't be able to get a good implant. So was it considered and didn't include, or what?
It was considered during the discussion, during the first Elaacc meeting, but we decided that it will add more complexity to the whole scoring, which is already complex with 12 variables. So we decided not to include transseptal. Although I agree that it's part of the complexity, but it doesn't say anything about the anatomy of the appendage. So we wanted to keep something really focused on the challenging anatomies. Yeah.
But if you are thinking of an optimal implant, I think maybe in the future you may have to consider. The second point is regarding the Elaacc scores 2. I think like chicken wing acute angles, we always know they are challenging cases. So if you just exclude those and goes to a continuous variables only, I think that maybe not serve the purpose, because I think all these parameters are equally important. Maybe the statistics that we use or what we want to do didn't match it. That's why we didn't see the pattern. But I think the continuous, what we see here, I agree statistically and good illustration, but I don't think we can ignore the parameters already shown in the first score.
I think it's I finished with this comment, but it's difficult to validate those parameters, because if it's a very complex appendage, you anticipate even more the complexity. So probably you end up with a good result because you have anticipated all the complexity of your case. But I think this is a very nice first step, and we need to continue to search about how to validate. And I think procedure efficiency is probably the way to go. How many catheter manipulation? Maybe for the sake of time, I will move to my presentation.
Yeah, we have to, because we have to. Sorry, we have to interrupt because we have to be at dinner in 15 minutes, and we don't want to miss your talk. And the poll at the end is also important for the consensus. So please, sorry about that.
Okay. Can I read my slides, please? So I will talk about something relatively different from the anatomical score. So this is the path to an Elaacc clinical score. So why the field requires a clinical risk stratification score, okay? So we have, as we have seen, we are talking today about the selection of the patient, okay? So we know that there is an early mortality problem. So there is high 1-year all-cause mortality in real-world LAAC registries. So basically the patient will die before driving any stroke prevention benefit, and this is called futility. So the procedures carries a risk but insufficient time to benefit for the patient. So closure AF was a kind of wake-up call. We know, we have seen this trial today, which was nicely shown by Karsten. So LAAC was not non-inferior to best medical therapy. There were more cardiovascular death and bleeding in the device arm, and you all know these sentences from the editorial. LAAC failed to fulfill its promises, at least for older, frail patients. Best medical therapy should remain standard for older patients. So the key message from the editorial was the procedure is not for everyone. So the answer that we have to tackle here before the dinner, if you have still time, we need to validate a clinical risk score. So we know the Euroscore 2 for cardiac surgery, we know the TRI score for tricuspid repair, we know the STS Euroscore 2 for TAVR, and we need some kind of a new clinical Elaacc score to identify which patients are at too high risk for LA closure. I think we need also to define a threshold for futility, which is not easy, honestly, and we need this future scientific validation. So we have to learn from analogies from other scores. The TRI score model, as you know very well, for tricuspid defines a low-risk, intermediate, and high-risk population for surgical tricuspid replacement, giving a very high mortality in the high risk, and this drives the therapy between the surgery and the transcatheter or medical treatment. And I think the LAAC field needs its own equivalent score. So the aim here, if you still have time, or we do it tomorrow, but is discuss its weight, some kind of relevant clinical parameters from published evidence, define a framework for open discussion, define a futility threshold when LAAC should be reconsidered. It's not easy, and plan a scientific validation. So just to give, because we've discussed a lot about the mortality, and we said closure AF is a high mortality. Yeah, okay, but if you look at some other registries, like the Evolution or the Amulet Multicenter Registry, we look at the 1 year mortality, it's not low actually. Okay, we have talked about Champion, we have talked about Option, very low risk population, but if you look at some other registries, we have quite high mortality. I just focus on closure AF, was already presented by Karsten, but I just show one multi-center registry from Spain and Canada, and this was published like 4 years ago or 5 years ago, and they showed that actually in a multi-center registry, unselected patient, the mortality at 1 year is 15.5%, which is quite high, which is the same or even more than in closure AF. And these are centers that, with operators that you can see here. And we see that the annual mortality was not changing over the years. From 2009 to 2019, which was the inclusion period, you see that the mortality is extremely high and go below, a little bit below and far above 10%. Very important, you see that mortality was not associated with procedural success or the antithrombotic treatment after LAAC, meaning that it has no impact. So you can do a perfect procedure in the patient, but the patient can die very early after the procedure. So they have found very important independent predictors, the age as a continuous variable, but here you can see as a dichotomized cutoff, the BMI, the presence of diabetes, the EGFR, so the renal function, and the fact to have heart failure as a previous history, not about ejection fraction, but previous heart failure. So all of these parameters independently predicted mortality in this registry. And very importantly, if you start to add many risk factors, for example, you go up to 2 risk factors, you have a 1 year mortality of 16%. 3 risk factors, 1/3 of the patient are not alive at 1 year. 4 or 5 risk factors, half of the patient are dying at 1 year. So this already gives you a threshold for futility. The same group from Spain and Canada, they assessed a frailty score, the essential frailty tool within, again, a multi-center registry with 452 consecutive patients. You see the mean age, 76-year-old, 1/3 of women. And so they assessed frailty in a prospective fashion, and this is a very easy tool. So there are a lot of frailty tools that have been published, but it is actually, so you have like this 5-chair rises test. This is less than 15 seconds, it's 0 point. More than 50 seconds, it's 1 point, and unable to complete is 2 points. The fact to have cognitive impairment or not, and this was defined as a minimal mental status score of less than 24, 0 if it's not, 1 if it's present. The hemoglobin level with differences between male and female. So if it's low, you get 1 point, and the serum albumin, which is a testimony of the patient cachexia or not. And this was already validated in the TAVR field. If you look on the right, when you had a high EFT score, it was associated with a very high rate of 1 year mortality in the TAVR field. And they show, the same group show again that when you use this frailty score in patients undergoing LAAC, you also predict mortality. So patients that had an EFT score of at least 3 or more than 3 have a very high mortality at only 1 year. So 32% versus 7.7%. And this is like there is a stepwise increase, and if you get like a score of 5, then again you have an extremely high mortality. The distribution of the different parameters you can see here. So for example, the inability to complete the 5-chair rises was one of the most common one, including, and the other one was the hypoalbuminemia. And if you add this frailty score on top of the classical clinical risk score, you really increase the accuracy of the prediction of this model. So you take the clinical risk factors and you take the frailty scores, and this adds really a very important prediction for the patient. So just to open up the discussion, so what kind of other predictors we can take into account? So age, either as a continuous variable, it was shown in the multi-center registry to be significant, but probably a cutoff will be more appropriate. In the Amulet multi-center registry, which was published by Chavi, there was at 2 year, there was a 20 0.3% all-cause mortality if the patient was equal or above to 80 years old, as compared to less than 10% in patients less than 70 years. So age alone, does it define futility? It's not clear, but age and comorbidities probably increase the risk. Sex-based considerations, so there are many studies showing that actually sex is not really something that will define the mortality. For example, when you compare in the US registry, when you compare the benefit of LA closure as compared to DOAC, there was no difference in terms of being a woman or a man. EGFR, this is probably a strong predictor. It's not an absolute contraindication as we have seen today, but probably it should be included in the clinical score. Which other variables? Reduced ejection fraction, LV dysfunction, it is something that independently predicts mortality. Diabetes, especially if it's insulin dependent. Hemoglobin and albumin, but these are already part of the essential Freighty tool. The presence or not of previous major bleeding. So this is some kind of paradox because major bleeding is both the main indication and the risk factor. Maybe we can subdivide into prior intracranial hemorrhage, which probably gives the highest risk of mortality, and other cause of bleeding. But we know that the recurrence of bleeding is also a factor of increased mortality. The BMI, and we have to define the threshold. And the CHAS-VASc and ASBLADE, probably it identifies patient at risk, but not probably the patient that will have a higher mortality. So very quickly, what kind of variables we can integrate into the score. So I've shown you the frailty score, the EFT more than 3 is a strong predictor in the multi-center registry. The presence of the history of major bleeding could also be a strong predictor, LV dysfunction, diabetes, and some other parameters. And what we want is to end up, this is just like a future proposal with some kind of quick reference calculator that can predict mortality in patients undergoing LAAC. And we could define like a low-risk population, an intermediate one, and a very high risk where actually the procedure is totally futile, and we should probably not consider this procedure in the patients. So which variable we should include, how we can implement it in a practical, from a practical standpoint. We need something that can be calculated easily at the bedside of the patient, which tools are feasible across all Elaacc or all centers for a multi-center registry, at what point in the LAAC pathway should the score be calculated, and should the score be a hard stop or just an advisory recommendation. And I think, of course, we need to validate, and this is a great task to validate the score, even if we define what will be the variables. So my key messages, so 1 year all-cause mortality of LAAC is non-trivial. It's more than 8% in many registries, up to 15% in the very elderly. So closure AF is a wake-up call. LAAC is not for everyone. Patient selection will determine the outcome. The frailty score, it's a strong single predictor of 1 year mortality, and we need a dedicated clinical Elaacc score as a next step on top of the anatomical one. And if we still have time, I don't know if we still have, or we keep that for tomorrow, but we have to define the variables. So I've prepared a vote. I don't know if we still have time to do it, or yeah, we go for it? Okay. So can we show the vote, please? Just to know which variables you want to include in the score, and that will be part of the consensus. Of course, then we need a clinical validation. So the first one, the first question is, do we need an Elaacc score, yes or no? So, okay, so everyone agree that we need a clinical Elaacc score on top of the anatomical one, okay? Okay, the next, please. Oh, no, sorry. Sorry.
I think you need to go through all the questions until it's shown. That's the problem.
Oh, okay,
you can go through the questions.
Oh, okay.
I have a comment. First, while people are answering the questionnaire, I think this is one of the most important presentation of the day. As I told you, we are for the Elaacc, and we said that this year the theme is about patient risk profile. And I think if we go and if we want to improve our anatomical score, we have to go to the clinical one, as it was done for the TRI-score, for example, where some clinical and biomarkers and imaging imaging we already have, I mean, are there to scale the procedure, the complexity of the procedure, and what we did is really great with the anatomical score, but then we can go to the prognosis of the patient. And if we want to say, okay, but closure is a problem because the patients were not good, I mean, we have to define what is a good patient. And we cannot just say, Carsten, you did bad, you are, I don't know, you did what you did.
Please don't.
No, I don't do that. I just say that we have to define, we have to have some objective criteria, and this is going to the good way. And hopefully you have the frail study that Xavi did with Pedro and all the team and some clinical variables. And I think it's really important to define the good one and then to scale everything and then to define this is a champion-like patient, this is a closure-like, etc.
If I may have just one comment, Ian, from... I think the way to move forward is you first need to gather a lot of variables that you put in a very large database. That's your discovery cohort. And then you define your endpoint, mortality or patient selection. And then you just run a model, like Lorenz did, and the model will determine the weights on each variable. And some variable will be redundant and will disappear. But the way, like we will do now, we will give 2 points, and that will not work. It's not a scientific approach.
I didn't put any points. It's just which variables we are going to assess. That's it.
Yeah, we are going to measure. We have to measure and put it in a database in the Elaacc. And once we have like 5,000 patients, we can link it to an outcome. And then we have like a kind of Euroscore. And the larger the cohort, the more variables we can develop. Because the degree of variability will depend on the total number of patients. If you have 800 patients, you will have like 5. But if you have 10,000 patients, you might have 20 variables.
Of course.
And that's the way to move forward. And then once you have a discovery cohort, you need a validation cohort, and then it's online. But yeah.
Yeah, I agree. But anyway, you need to search for some variables that you think will impact the outcomes. Of course, you need a scientific validation, but at first we need to agree on first the cutoff of what will be.
No cutoff. The cutoff will be determined by the database. Yeah, now we need to discuss which data point are we going to measure. Like the frailty, but the cutoff, you need to put it in a linear way, and the cutoff is not important. The variable we will measure, that's what we have to discuss.
Yeah. I think, Carsten, thank you very much for this important...
Just one short comment. So what we did right now was to develop a score who benefits from MCS. And how you do it, you have a derivation cohort, and there you have your characteristics, and you showed how some people got some characteristics that were predictive for outcome, but usually you should have a huge database where all these people of different risk are in, and then there you can statistically attribute certain characteristics with such and such importance, and then you go into your...
Yeah, of course.
So because if we look now and we say, well, we think this is this, I don't think that leads us to where we actually want to go.
Yeah, of course.
Jens Erik.
As I see it, we are talking now about 3 different Elaacc evaluations. The first one is an Elaacc anatomical classification. Complexity score, and I feel we still need to validate that with procedural times, recaptures, number of devices, etc. Then we are talking about another prediction, and that is the prediction of PDLs. And instead of trying to derive that from the original Elaacc classification, it would be better to look at cases where we actually see PDL and then go back and find the most relevant parameters that will predict PDL. I think that will be the way to go, and I think it's very, very important if we can have some tools to evaluate or predict PDL. And then the third one is your suggestion, which I find extremely important, namely to have some kind of systematic evaluation of futility and frailty. So that will be a third kind of evaluation. But right now, trying to mix an anatomical classification with prediction of PDL with also clinical outcomes related to old patients, it will simply be chaos. I think we are talking about three different things.
Of course, but today we'll discuss a lot about which patient benefits from the procedure, and so we have talked a lot about mortality. And,
but we should just work on those three columns.
Yeah, one question there.
I'm really impressed with particularly the data set that came out of Aarhus and Bern, and that as we're putting together, it also impressed how much hard work it has taken to do what you've make the statements that you've been able to make. It seems like to me that you're developing a really rich database that would be very good for machine learning model, and that which using things that I don't know anything about, but beginning to learn about AI models, so that with the Bern Aarhus data set and correlating anatomic features with clinical outcomes, I think that someone much more sophisticated than I could start using that as a machine learning model to develop, to really come out with things that probably will surprise us all. And afterwards, there's a lab at Columbia and then in New York, and also one at MIT that I've worked with that might be of help to you.
That's a very good comment, of course.
Lorenz, yes, I agree completely with Jens said. The net benefit of the procedure is a mix of aspects. In one hand, we have the procedural risk, and we are going in the right direction with the LAAC classification, because now we are improving the quality of the classification, and at the end I am confident that we will be able to define the real risk of the procedure. In the other hand, we have the clinical evaluation of the patient, and with the frailty, life expectancy, and so on. But the model is a complex model, and I think we have to address separately each one of these aspects. Probably machine learning, I'm not sure that machine learning is enough, probably deep learning model will be able to integrate both the aspects. But for the data collection and for data analysis, I think we have to address each one of these parts separately. After that, probably deep learning model, I'm not a very expert, but I think it could be one of the possible solutions.
Yeah, I totally agree. Just one quick comment. I agree that we should develop this score or whatever based on the database, as you said before. The problem is that some of the variables that you propose are not included already in the Elaacc registry. Mm-hmm. So maybe we need to find some kind of agreement in which variable we should measure or whatever, or integrate, because this should be integrated in the Elaacc registry in order to validate if they work.
This is also, scientific validated by previous registries. I've shown two registries showing that frailty was an independent rate, so it's good when you have something already validated that you take into account what was shown to be predictors. Otherwise, if you take just...
Yeah, but as he said, the ideal scenario, you have all the variables in the world, just including the registry, then you develop the score based on that. But we don't have all that variables including the Elaacc registry, so maybe we need to have a consensus with variables we want to include prospectively in the Elaacc registry in order to validate this.
And what will be the cutoff for futility? Yeah. What is the 1 year mortality that the people here will consider as a contraindication? Or it's not clear for me. Is it like 30%?
I think that the poll makes sense.
I think we have time for two final questions. Tom and you, maybe you first. Because
So this is maybe an opportunity you combine with the US data. They have 500,000 patients. So why can't you do a combined project and as he exactly said, run a model to identify the variables which predicts and use those as to develop the Elaacc registry.
Yeah. Just before the talk, I saw that the US registry, they also assess frailty, but I had only the 45 days outcome, but it was also predictors of mortality at 45 days already.
Final question from Tom.
Well, also
Comment?
for me, I think super important. Congratulations on doing this, and I share the sentiment about the US database to find parameters. The other observation I had was, you're absolutely right that futility is one of the things killing the therapy. The other thing, of course, is not just midterm mortality, but acute procedural issues. And beyond the implant itself, do you see a way to capture elevated risk for procedural complications? For example, I'm surprised that you don't do BMI on both sides, low BMI, but also very high BMI as a surrogate for potential for high risk of access complications, particularly small atria as a surrogate for potentially more high risk punctures, stuff like that. Do you see? Because I think that's the other component that's killing the therapy. If we look at closure AF, it's not trivial.
Honestly, today is just a proposal for open discussion. So everything that we said here will be integrated. As you said, I'm just proposing some variables just to open the discussion. So it's just a project. Nothing has been done. It was just to go towards this clinical score. So I think we all agree that we have to go for it. Fully agree with Jan that we need a very large prospective data set to validate. So it's going to be a long way ahead to have this clinical score ready, because I think retrospectively it's going to be difficult. And so, yeah, let's go for it. And I don't know if you can still see the rest of the voting.
Yeah, exactly. We're very lucky that we're in Italy, so the kitchen is closing late. But nevertheless, I think we should slowly come to an end, because we have to meet afterwards, immediately after the meeting at the lobby, because the dinner will be served in the hotel, but we meet at the lobby immediately afterwards. Okay, but I think we should, before that, go through the answers.
Yeah, okay.
And then this would be the final step of today.
So age should be included, of course, and then of course we need to define the cutoff. It's just informative, huh? Just. So 20% is I mean, there's like it's not a strong consensus. It's like, okay, so at least 10% is not a limitation. So 20% of mortality at 1 year is already something that we should reconsider the therapy.
So in conclusion, age with a threshold,
LV function.
dysfunction, LV function,
frailty.
Yeah, frailty, but not diabetes.
No, and CKD.
And body mass index. Yeah.
And then let's try to validate that. Okay, I think I'm finishing. I'm concluding this very nice day. Thank you very much to everyone. It was. It's not the story is not yet finished. I think we have a lot of work to do, and I like very much those open discussions, because that's the only way to reach consensus. So thank you very much. Have a great dinner, and thanks a lot.